Good afternoon.
Hello, Uma ma'am.
Hi, Chinmay. Good to see you again.
Yes, ma'am.
Madam, it's 2:30. Can we make it live?
Well, I hope my other is Anshu ready? Just check on Anshu, and then we'll start. Sudeep.
Yes, ma'am.
I've got my thing on the desktop, my talk on the desktop. I just want to check whether it'll come onto the screen. Can I do it now? It's too late.
Yeah, you can do it.
So it is, no?
Afternoon, Chinmay ma'am.
Hi.
Good afternoon, Nirmala ma'am.
Hi, good afternoon.
Good afternoon, ma'am.
Yesterday, this thing was very nice. The culturals. I was actually logged in. I couldn't log out.
Thank you so much. Tried our best to give whatever is possible on virtual.
And many of my college people are actually there, I realized. Dr.
Oh.
Jigyasa, Dr. Himangi Negi, Dr. Ekta, they're all my college
Dr.
friends.
Superstar. She is
Dr. Jigyasa is my senior, 1 year senior, both in MBBS as well as MD.
so nice.
Okay. So it's 2:30. Should we begin?
So we start make it live.
Nandita, is Dr. Uma ready? So our Uma, Dr. Uma. Oh, she's muted. Okay, I think we should start because we should stick to time.
5, 4, 3, 2, 1. We go live.
Hello, everyone. Welcome to our 20th annual ceremony, annual CME, our Noida CME. And our CME is a CME with a difference. Our theme being Untapped. We are going to touch on subjects and clinical situations that we face normally, but that are not commonly discussed. Taking advantage of the virtual platform, we've got exemplary speakers, excellent experts and chairpersons from far and wide, both national and international, and who all are an authority in the subject on which they're going to give their inputs on. Our own Noida Society members and FARMED are doing their bit to make the CME a memorable one. Welcome to our delegates. I assure you, this CME is going to keep you wired, sharp, and engaged all the way through. A great clinician that you already are, I'm sure the CME is going to make you a much better one. Now, before we begin, I just want to make a couple of announcements. One is we would like time. So all the speakers, please, I wish they could stick to time. And we want to keep our time for the academic discussions. So even the CVs, we are just going to show a slide CV. All our faculty are known and they need no introduction. So we just put their slide CV onto the screen and just give a brief introduction so that all that time is used for academic. So now I hand over to our Master of Ceremonies.
Good afternoon, everybody. A very warm welcome to all of you to the first session of our Day 2 annual CME. The eminent speaker, chairperson today are Dr. Deepika Deka. Ma'am is a consultant fetal medicine and genetics at Cloud9 Hospital, Gurgaon. She is an ex-professor and head of the Department of All India Institute of Medical Sciences, New Delhi. She has many awards to her credit and has published many papers in national and international journals. Our second chairperson is Dr. Nirmala Jayashankar. Ma'am is a renowned senior consultant gynecologist at Apollo First Med and Apollo Cradle Hospital, Chennai, and has many awards to her credit. Welcome you all, ma'am. Dr. Uma Ram, she is a director and consultant gynecologist at Sithapati Clinic and Hospital, Chennai. She's also a chairperson, South Zone AICC RCOG. Welcoming you all, ma'am, and Looking forward to your expert comments for our session.
Hi, very warm good afternoon, everyone. I'm Dr. Aradhna here. Now I want to invite Dr. Nidhi Malhotra. Dr. Nidhi Malhotra is Associate Director and Coordinator in the Department of Endocrinology at JP Hospital, Noida. Welcome, Dr. Nidhi. And then the next chairperson is Dr. S.S. Gulati, sir. He needs no introduction for us, and he is a professor, unit head at the School of Medical Sciences and Research, Sharda University, Greater Noida. Welcome, sir. And now we hand over the session to the respected chairpersons.
Very good morning, afternoon, Dr. Sujata and the team, Noida Obstetrics and Gynae Society. Can you hear me?
Yes.
Yeah. So it's really a pleasure to be here. And I remember very vividly 25 years back, I was very actively physical conferences we used to have. So anyway, online, but wish you all the best. So it's my pleasure to call the first speaker, Dr. Sujata herself, Sujata Bhatt. She will be speaking on interpretation of OGTT and adverse pregnancy outcome and analytical approach. It's a very, very important topic. And well, we know Sujata, she's the president, she's the organizing chairperson of this conference. She works as a senior consultant at Kailash Hospital, and she is an expert in high-risk pregnancies, menopause, and all women's problems. She's the author of the Pocket Planner for, it's covered. So I think you should give me a copy of this.
Yeah, sure.
Yeah. And I invite her to give this talk. Dr. Sujata Bhatt, please.
Yeah, thank you. Thank you, Dr. Deepika. So, yeah, now I have to share the screen. Just 1 minute. Yeah, is that okay? Okay.
You can make it full screen.
Yeah,
I'll do it. Right. So the purpose of my talk today was for 2 reasons. A, to stick to the, to abide by the theme of our CME, which is to abide by the theme that is tapping the untapped. And also for another reason, because I want to emphasize that screening in pregnancy is done with a glucose load and just an RBS. So as you all know, gestational diabetes mellitus is discussed in every forum, but adverse perennial outcomes in comparison to the blood sugar. Excuse me, and there's a lot of disturbance. Could the host please? Okay, so now we come to, I think we all are a study, which was way back in 2010, where the adverse pregnancy outcomes were compared with the glucose values in an OGTT, which was done by the IAD-PST method. So there was definite evidence that there was a linear relationship between rising blood sugars and adverse pregnancy outcomes, and that too with a glucose value of a lower threshold than the normal cutoffs for diabetes. Unfortunately, India was not in the study, but subsequently over the years, there were a lot of studies in several countries, including a lot of Asian countries amongst their own population and including India, where studies were done on the adverse outcomes with rising blood sugars. I must thank Dr. Umaram for giving me a lot of data on the Indian studies. Most of it, I guess, were done by her and her team and a few others too. So now, in fact, HAPO study has even come up with its follow-up study. So now the most important point I want to emphasize on is please do an OGTT for every patient of yours and not just a random blood sugar, because it's only then you would know about the adverse pregnancy outcomes with your results. So before I just go into the talk, I would just briefly want to talk about the physiology. The second trimester is more like an insulin resistant state because of all the placental hormones and other local hormones. And as a result of which there is hyperglycemia, more flux of glucose to the baby through the placenta, because hyperglycemia actually even causes apoptosis of the syncytioblast, causing major openings in the placenta for more. to be transferred to the fetus. Because of increased fetal insulin secretion and decreased fetal glycemia, more glucose gets influxed into the fetus. Normal maternal adaptations do not adequately occur in all pregnancies. So now this was the main reason why I wanted to give this talk. Here was this lady, 18 weeks, 86 milligrams percent on a random test. No screening was done, and only at 35 weeks, when a big baby and polyhydramnios was noted, her fasting and PP was done, and she was told to get admitted for a cesarean section. So she came to our hospital for a second opinion. We were doing her blood sugars because we were giving her 2 doses of steroids. We were trying to look for any preeclampsia. And as you can see, her ultrasound showed a growth centile of 99.9 with polyhydramnios. So she leaked and we had to do a cesarean. Fortunately, Abgar was good. There was no PPH and the baby had a small ASD and bilateral ventricular hypertrophy. Now, could not this have been avoided? Why an RPS? She could have been screened glucose load. So now these were the articles, thanks to Dr. Umaran. Actually a study done in 2016, and it was a study amongst the doctors, a survey done where they were given performers where they had to, it was assessed on how they do their screening. And out of 341 doctors, which included diabetologists, 50% of them were gynecologists. It was nice to note that 85% were doing universal screening, but only screening at booking. But most surprisingly of all, amongst all of them, 5% were not doing the procedure correctly. They were not following the criteria, the cutoffs as per the criteria, the glucose load, the sample collected. So I thought it was very important to show the prerequisites for an OGTT. I mean, I hope all your patients are being told about what are the prerequisites before you subject them to an OGTT. And it's but natural that they would all buy a Glucon-D packet and arrive at the lab. So just remember, 75 grams of anhydrate glucose is equivalent to 82.5 grams of Glucon-D. And you should remember that if she vomits within 30 minutes, you have to repeat the test again the next day. Even the glucometer that is being used in certain centers, it should be a plasma calibrated one. And even subsequently, if the patient is doing a self blood glucose monitor, it's very important that she buys a plasma calibrated one and compare her values on and off with the same sample in a lab. So now I come to my data. So there is this data from Australia where early pregnancy screening was done, and they found that yes, there were results in the results were with a lower neonatal morbidity because they could identify the cases early and manage accordingly. Our own guidelines, February 2018, we too insist on a 2-time test of an OGTT. That is the first one at the first antenatal visit and subsequently at 24 to 28 weeks. Of course, they're doing it even at the primary health center levels. Of course, they're doing the DIPSI method where the glucose load is given irrespective of the fasting stage. And the test is done with a plasma calibrated glucometer so that the results could be given immediately and the treatment could be started. Now here too, a survey was done in Tamil Nadu and Madhya Pradesh, and it was found that GDM was more prevalent in the urban sector than in the rural. So we who are here, when we have better resources, why can't we do a regular GTT than a DIPSI alone? The patient is anyway going to sit in the lab for 2 hours. Why can't we do a 1-hour sample too? Because every isolated value has its own adverse outcomes. In a low resource sector, doing it as a DIPSI method, yes, at least she is being screened with a glucose load than just doing a random blood sugar. And of course, studies have been done comparing the DIPSI with the other GTT methods, that is the IADPSG and the WHO and the NICE, and it has been found that it has a low sensitivity and a low positive predictive value. So in an urban sector where your patient is a little more compliant, why not do a regular OGTT, which includes a fasting value? So now there was the study where, just like the HAPO, they did a study in their population and they also noticed that there were adverse outcomes even with isolated values. Fasting, when it was high, it was found that insulin was required in most of the situations. And as you can see, the adverse outcomes of neonatal hypoglycemia and preeclampsia when both values were high. Now I'm going to begin with my case scenarios in relation to an OGTT, where you can have either a fasting high or a 1 hour high or a 2 hour or all high or all low or a 2 hour low or an adverse effect even with a normal OGTT. So now let's begin with the beginning one where the fasting blood sugar is high. Here you have to make sure it is genuinely high because there are various factors that can influence the fasting value, as you can see, which includes even how you've slept and what you've eaten and when you've last eaten. Now, here are these studies which show that a high fasting value, and even when they were divided into medium and high, millimoles, if you multiply into 80, you will get the milligram percent. And it showed that when it was in the very high value, the adverse outcomes were almost equal to the outcomes when all the three values were high. So similar studies over here, when compared to the IAD-PSG criteria, the adverse outcomes of increased cesarean rates were more when the fasting was more than 100, and fastings when they were between 92 and 100 also showed an increase in cesarean rates. This was an Indian study. And again, another one, a small study sample in Bangalore, which showed that there were adverse outcomes when they were screened with the WHO method, but the values were much lower. Fasting blood sugar is 87 and postprandial 134, post 2 hour 134. So are we at a higher risk with a lower glucose cutoff value? So as you all know, people who are doing the GCT, the one-step method, the cutoffs may be 140 elsewhere, but for us in India, it's 130. Some people take 135 as the cutoff. So already we know that we have to take our values a little lower than what the normal values are outside the other screening methods. Now, talking about the next type of scenario where the 1 hour value is high. Here, it's definitely a reliable predictor of poor maternal outcome. There is definitely an indication for future diabetes and cardiovascular disease. Now, this is a situation that all of you will get in your practice, meaning you all will notice when a 2 hour value is high and you definitely say she's GDM. But I do not know how many of you all actually look at the fasting and the 1 hour too, because as I told you, even isolated values can have adverse outcomes. So this was another study in China where they found they divided the groups, and group 1 was again isolated values, and they found the adverse outcomes were almost equal to when all the values were high, when isolated values were high. Now, how many of you all look at the 2 hour value, which is low? This GTT cannot be ignored. This is a condition called reactive hypoglycemia, which is actually an insulin-resistant state and indicates a pre-diabetic situation. Although there were conflicting results regarding the adverse outcomes, it's very important to do a self-blood glucose monitoring over here to make sure that it is genuinely a low hypoglycemic state and not a reactive hypoglycemia. Again, how many of you all look at the values when it is low? This is another which should be taken seriously. Low values can predict low birth weight, but if you do a self-blood glucose monitoring, you would probably find they're normal or maybe a little high. Now, this is what I said. Independent of risk factors like BMI, etc., a normal GTT, and you can yet have macrosomia. As I told you about the physiology in the beginning, the openings in the placenta cause so much of flux of high glucose from the mother that it attenuates the high values and gives you the impression that it is a normal. It's called the fetal glucose syndrome. So as fetal glucose steal syndrome. So I come to the take-home messages. Point 1, please screen with a glucose load. Screen twice, first visit and again at 24 to 28 weeks and at 34 weeks if clinically indicated. And do not ignore isolated high values, do not ignore low values. And please remember, postnatal follow-up is absolutely necessary. Thank you very much.
Thank you very much, Sujata. That was a very crisp presentation, focusing on very important aspects of looking at the values of a GTT in an attempt to individualize the kind of risk factors or risk that it poses. So gestational diabetes, as we know, is a spectrum of women who have glucose intolerance in pregnancy, varying degrees of insulin resistance, and they all don't fit into one basket. In fact, if you look at women studies from our own population, the conversion rates to type 2 diabetes going forward are extremely high and happen within even 3 years of the pregnancy, and you don't have to wait for post 5 years. And again, the values of their GTT and whether they need insulin or medication helps us triage those women who are more likely to develop type 2 diabetes. So I just wanted to add to what you're saying in terms of pregnancy outcomes and say that looking at those GTT values and whether these women need insulin and medication also to a large extent helps us triage those women who are more likely to convert early to type 2 going forward. So it's extremely important that we stick to what we're doing for screening. And I mean, the take home from that study about what we use is people thought they were doing the IADPSG, but when we asked them what the cutoffs were, they were still using an old Carpenter system. Or they thought they were doing DIPSI, but they were, looking at the fasting and the 2R values also. So, so it's important that we know what criteria we are doing. It's important that we follow the same criteria across pregnancy. And I think it's very valid that we understand why, if there is a better test and our population is able to come and have it done, we should, offer them the most optimal care.
Right. Thank you.
And also, if I may add, Uma, just stick to one method because it is so confusing when you go, there are so many methods, DIPSI, WHO, so if you are following one method and just stick to that method throughout the pregnancy. Another thing which I would like to say is in a patient who has got GDM, we expect to have a little bit of, growth being on the higher centile. But when there is a mismatch between your sugar and the growth, be beware. Supposing a gestational diabetic mother has a baby which is going on the lower centile or the LICA being less, then you should definitely, that's a red flag. Because clinically and sonologically, it is not correlating, and those pregnancies need more care. When there is no correlation, you expect the baby to be little on the larger side. But if it is growing on the smaller side, then it is all the more important.
Yes.
Hi, I would add something. Well, it's a pleasure to be here among all the gynecologists, I being an endocrinologist, and Dr. Sujata has given a very informative talk. And it has always been a confusion, of which test to be done in the OPD setting. And she has clearly elaborated that, yes, still the test which is the test of choice is the one from the International Association of Diabetes and Pregnancy Study Group, that OGTT post 75 gram glucose should always be used. But yes, recently seeing the increasing prevalence of gestational diabetes in India, our DIPSI group has come up with the non-fasting 2 hours 75 grams 75 grams glucose. But then this kind of test is basically because the prevalence is so high. It works more in the community setting, but where we are working, like in the specialty clinics, we still cannot afford to miss. Even the way she said that even if isolated fasting glucose is high, even if you don't do that, we would be missing many gestational diabetes patients. And it has been seen with using the DIPSI criteria, we are still missing many percentage of gestational diabetic patients, and which we cannot afford to. So we should still stick to the IDAP-ST criteria, and as far as possible, try to do that. But yes, when the resources are limited and it's better or not doing anything, then we can go for, just doing a single WHO 475 grams 2 hours sample, or we can go by the DIPSI criteria and do a non-fasting 2 hours 75 grams glucose blood sugar. So yes, we should always stick to the IEDP-ST criteria, because this is the only test which can identify isolated fasting plasma glucose elevations, or if there's isolated 1 hour post glucose elevations, or there is isolated 2 hours post glucose elevations. So I agree with Dr. Sujata.
If there's is there time for another comment?
Nandita and Aradhana, you all are checking on the time. Please tell us. You might as well give the comment.
Yeah, okay, right. So no, I just wanted to tie up what everybody has said and bring back and take Nirmala's point about fetal growth, because I think it's very important. It's a very important message there, because we become glucose centric when we're following these GDM women. We should not forget that the baby is the one that's getting affected by the hyperglycemia. And the reason we call GDM the mother of all NCDs is because this baby is then being exposed to hyperglycemia, becomes at risk of various metabolic problems going forward. So don't just look only at the sugars, look at how the baby is growing. And if at all, unless you're in a really resource limited situation, try and get more sugar values, glucose values across the week or across the day to know exactly what is happening, because that's how you assess control. 2 values 15 days apart really is not going to give you a good status of what is happening to the woman's glycemia. And watch the baby, because how this baby is growing, as Nirmala said, makes a big difference to how we are going to manage. I think I'll just stop there, because otherwise this discussion will go on and on.
Thank you very much, Dr. Uma, for the valuable comment. I think, may I request the chairpersons to announce the second speaker to introduce?
I think it's my really proud privilege to introduce Chinmayi. Even though I do not know Chinmayi personally, I have heard her talk with so much of clarity and conviction in many, many conferences. And it is always a pleasure to listen to Chinmayi, because you always have some take-home messages, very clear take-home messages to take. So can I have a little slide to introduce Chinmayi? Yes. As Sujata told, the awards are endless for Chinmayi, but the one word I would like to say is, this is a person with very clear-cut messages in whatever she talks. Over to Chinmayi.
Thank you so much, ma'am. It means a lot coming from a very senior person like you. And it's a privilege to be here in front of all of you. Thank you, Sujata ma'am, for the opportunity. And indeed, the topic is one which is very close to my heart and my work, because we work with fetal anomalies. And you have chosen to address the issue of continuing a pregnancy with confirmed fetal anomaly. Now, malformations are part of our assessment. We know that when a body part is not formed properly or has a developmental defect, we call it a malformation. And the sad part is, even in the so-called low-risk population, the incidence is about 2 to 3%, and the 3 to 4% of all live births may have fetal anomaly. So in a routine obstetric unit also, you may encounter these cases every week if you are looking at a large volume. So when you diagnose a fetal anomaly, that's actually just the beginning of the whole process, because then begins a whole story of counseling, looking at literature and finding a solution to this issue. Many times we feel if there is a fetal abnormality.
There are no slides.
Do you have slides?
Oh, I'm so sorry. I have shared my screen.
But it's not visible.
Not seen.
Oh, I'm extremely sorry.
No, that's okay.
What I have said is that whenever we diagnose these fetal abnormalities,
thanks.
Can you see it now?
Yes, let's go on slideshow.
What is important is that the answer to a crisis in a pregnancy is not to eliminate the child altogether. So termination is not the only solution of finding a fetal anomaly, but sometimes you have to eliminate the crisis, which is the fetal anomaly, in whichever best way you can. So continuing pregnancies with fetal anomalies is what happens in many cases. Now, this is one case where there's a 26-year-old primigravida who's had a early scan, and you've seen that there's a single live average for gestational age fetus, but there are bilateral club feet with no other abnormality. As soon as an obstetrician gets this report, there is a small degree of shock involved there, because neither the doctors nor the parents are actually expecting an anomaly when they send the patient for an anomaly scan. It's somehow assumed that this is one tick box in your antenatal care, it has to be done. But the moment there is an anomaly there, everybody is in shock and awe. Now, what happens? Then this comes to the fetal medicine clinic, where we look at a lot of things. What has been her screening history? What is the spine looking like? Are the movements okay? Are the joints okay? Are there any family history of similar issues? Because sometimes we need to find out whether this is just a pure structural issue or something associated with a lot of other multi-system abnormalities. And once we've dealt with that, we need to counsel the patients. So every abnormality has some natural course, and thereafter postnatal correction, some methods are available. So we can tell the parents how these things are corrected. So for clubfoot, there's a lot of pictorial help available where you can show them how exactly the manipulations and the surgeries would be done postnatally if that happens, and how a good outcome can be obtained with some quality of life compromise, but that also is like manageable to have a good functional life as the baby is born and grows. So we talk to the neonatologist, who's usually the first port of call whenever a baby is born, so that he's not exactly anxious the moment the baby is born, and he also is not answering all these questions at that point. If he is aware of the problem beforehand, he can have a consultation with the family beforehand. Sometimes we involve a neurologist when it comes to bilateral clubfoot, because there may be other issues which are not purely musculoskeletal at that point, but have a neural origin for having bilateral clubfoot, and there may be progressive things like arthrogryposis. So all these are settled down in the antenatal period with a proper evaluation and counseling. Now, if this patient continues the pregnancy, we know that this problem is an isolated problem. It can be corrected, has a good prognosis, and there is no specific antenatal intervention required. So what made the difference here? Proper explanation, workup, follow-up, and multidisciplinary support. Similarly, this is a case of an anterior abdominal wall defect. As you can see, there are bowels protruding out of the area where the umbilicus is, and this definitely will need postnatal surgery. What matters here? Screening history. Is she low risk for aneuploidies? If not, check for aneuploidies by doing an amniocentesis, because there is a close association. Tell the obstetrician that there will be need for intensive maternal care, because she will develop polyhydramnios as the pregnancy progresses, risk of preterm birth. So place of delivery, timing of delivery, and mode of delivery. Again, the literature says not required to do a cesarean section, but you have to time everything, because you have to have an obstetric setup where you have a neonatologist stand by all the time, because you don't want her to deliver at a time when you don't have a good neonatologist standing next to you. So if that requires a C-section for logistic reasons, you have to think of all that. So this woman continued her pregnancy, and at 38 weeks delivered a 2.3 kg female baby. And that made it easy for the surgeon to work on the baby, because if she had a preterm delivery at 29 weeks, the outcome would not have been good. And they continued, they had a neonatal stabilization followed by surgery, and did well. So what made the difference here? Timely diagnosis, evaluation, proper explanation, follow-up, and multidisciplinary support. Similarly, in cleft lip and palate, again, a problem we know that can be corrected by surgery, but the immediate outcome of this anomaly is a severe cosmetic problem, which really puts the parents, it shakes them, and then the baby cannot feed normally. So it needs a lot of support in the neonatal period, and mentally there has to be some preparation. Now that we are using masks everywhere, that's become kind of routine. But what we used to tell the parents at that point is to put a mask on the baby's face till the correction happens, so that they don't have to deal with that question every time somebody sees the baby and says, oh, what is this problem? Why does the baby have a problem? What really changed our outcome in cleft lip palate was our association with the plastic surgery department of the Nizam Institute of Medical Sciences in Hyderabad, who gave us very good visual aids. And there is a government supported program where the parents don't really generally have to pay for the surgery, and they also get a travel allowance for the surgery. And if we book them with the government hospitals well in advance in the antenatal period, they are able to get their surgery scheduled well in time. There is a timeline when these problems, and they give us visual aids like this, where patients who've had corrections, they speak up, and then all the speech problems and all is taken care of. So what made a difference here? Awareness of the results of surgery and multidisciplinary support. Now, this was another case where we had a baby with bilateral microphthalmia, and we thought this is a non-correctable abnormality. You can't create eyes after the baby doesn't have eye sockets. The baby will be visually impaired all over. And we thought parents would probably opt for discontinuing. But you know what? They continued the pregnancy despite this anomaly, because both of them themselves were severely visually handicapped, and they had become teachers in a blind school. So they said, if this is the only problem that the baby has, we are not willing to discontinue the pregnancy. So what made the difference here? The ability to accept an unusual circumstance as a personal choice. So here it was not about correction, multidisciplinary support, but just about the parents' choice, where they decided they're able to cope up with that abnormality. Similarly, this was a case of a rudimentary limb. You see an extra limb there attached to the back of the baby, which was diagnosed well in a time frame that termination could have been offered. And they decided to continue it because they understood that postnatal surgery was possible. And this is how the baby looked on the first day after birth. And after 15 days, a surgery was done, a planned surgery, because they had undergone all that antenatal counseling. And look at this, the baby is beautiful and the parents are very happy, and they are sending us repeated updates on the baby, which is actually a very heartening thing for us. Things like renal problems. Now you see one of the kidneys looks very enormously enlarged, whereas the other is normal. So again, you know that with one kidney, the baby will do well, although there might be a requirement for surgery for that one abnormal kidney. And with a correct planning in the antenatal period, the parents are ready to accept it. Whereas if both the kidneys are affected, the life is not going to be great. And this is different from that bilateral anophthalmia, because here the baby won't be able to survive. And therefore, you may take a decision for termination, but with a good workup, a genetic cause can be ruled out. Similarly, cardiac defects, again, they throw people out of balance because it looks like a very, very serious condition. But then if you work up the defect properly, like this was a case where there was anomalous venous connection, pulmonary venous connection, TAPVC. And with a proper counseling, these patients were advised to continue. They continued the pregnancy. The baby was born at full term, and thereafter had a surgery on day 5. And after surgical repair, the baby is doing well. So all the cardiac anomalies need not be terminated. They have to be planned. The care has to be planned. Specific problems require delivery in very tertiary NICUs, whereas the others can be delivered even in low resource settings, and then the postnatal care can be planned. Similar with thoracic abnormalities like pulmonary airway malformations. You see these lungs look very bad. This was a case where we had done an antenatal cyst drainage, and the pregnancy went on to full term. She delivered, and after 1.5 years, the baby required a surgery of removal of that lobe, but it's eventually doing well. Diaphragmatic hernia is another such case where an exit procedure has to be planned, and then the outcomes are usually good. Now, sometimes you continue a pregnancy thinking this will do well, like a small meningomyelocele in a lumbar region. But as the pregnancy progresses, things become bad, and then the patients realize that now the brain is going to not be so good. Now we want a termination. Now, we didn't have an option till the last month. We didn't have an option to terminate a pregnancy in the 3rd trimester. Although now we have realized that evolving abnormalities are a reality, and the government has supported us by changing the termination upper limit to 24 weeks in routine cases. And in other cases, there is also a possibility of going on to a 3rd trimester termination with legal help. So what is important is for us to realize that, all abnormalities cannot be detected in our antenatal scans. Some of them may be evolving abnormalities. So we need to change our attitude a little bit. And allow me to show you one historic case of Josephine Corbin, where this lady was born with 4 lower limbs, a condition we call as dipygus now. And we always see it as pictures in the pathology specimen, but this lady was born to physician parents way back in 1868. And she was given a name, she was given a life, and she had a very, very dignified life for as much as she lived. So this is from the British Medical Journal, 1889. And what I want to say is it's just a matter of attitude, how we deal with anomalies. I mean, she could have been abandoned on the day that she was born. Maybe antenatal scans were not possible, but we know that people sometimes don't take care of children with anomalies. Also, while I'm telling you all the rosy stories, there are some conditions where abnormalities can have bad outcomes. This was an engineer couple who had the first child affected with diaphragmatic hernia, and they wanted to continue. Everything was done, but the child did not survive. Postnatally, the lungs were not good and surgery could not be done, and the child died on the second day of life. I felt quite bad, and I talked to the mother and I asked her, are you feeling bad that you continued this pregnancy? Because I had advised her to continue the pregnancy if she wanted to. You know what? She wrote me a letter much later when she was okay. And she said, I don't regret my decision because my baby did not end up being a medical waste product of termination, but saw the light of the world because I am a mother today and not just a woman. The fetus, which was told to be terminated by everybody, actually came to the world as a baby boy named Pradyumna. So really, I'm still getting goosebumps whenever I read this letter, that there is a different attitude that people have, where she wrote, today, I have a new identity. I have a name and I am a proud mother of the baby. So what is right is not always easy. What is easy is hardly ever right. But the right choice today will help you make your tomorrow better. So when you diagnose a fetal anomaly, we have to prognosticate it, plan antenatal care, plan delivery, and make a neonatal care and follow-up plan. Tell the parents that all this is possible. Whether they decide to continue or terminate is their personal choice. But remember, the other issue that we need to address over a period of time is to get health insurance for these sick fetuses. That is one place where we are lacking and where parents are scared of continuing because they don't have that much help. Our cleft lip palate experience told us that if cost is not a big issue, many parents are willing to continue correctable anomalies and have a good outcome. So remember, continuing fetal anomalies needs a very good perinatal care team. And the motto is, we cannot cure everything. We may not ever be able to cure everything, but we can certainly care for everything. Thank you very much for a patient here.
Thank you, Dr. Chinmay. That was really an excellent, the way you talked about how decisions depend upon so many factors. I'm sure there would be lots of questions, but I've been told by the organizers that we could keep the questions, if time permits, after the next talk. So I invite my co-chairperson to please invite the next speaker. I invite the co-chairpersons to please invite the next speaker, introduce.
Yeah, I think Dr.
My
Deepika,
pleasure.
Maybe
Dr. Umaram.
Yeah, I can. Thank you, Dr. Deepika. It's my pleasure to introduce Shaijas. Shaijas actually doesn't need any introduction to an OBGYN audience. He is somebody who is known to be an excellent speaker, but also known for his non-academic skills, a brilliant dancer, somebody who really puts together all his artistic skills in conveying important community messages as well. He is the chairperson for the Midlife Management Committee of FOXI 2021 to 24 and the joint secretary of the Kerala Federation of Obstetrics and Gynaecology. So over to you, Shai. Just looking forward to listening to you on endometrial hyperplasia.
Thank you. Thank you so much, madam. I hope my slides are visible and I am clearly audible.
Yes, you are.
Yes.
Thank you. Thank you so much, madam, for those really kind words, such an inspiration. Thanks a lot, Sujata madam, for that invite. It's such a privilege to be here. And I think it's a relatively difficult task to be a speaker after such a brilliant lecture from Chinmay. I hope I can throw some light on the topic that has been given to me. The moment Sujata madam called up a few weeks before and handed over this topic, I first wanted to ask her, do you have a problem with me? And then I just gathered myself and probably decided for myself that even when there is lack of evidence regarding certain things, I think she would have thought that I am the best person to put in certain schools of thought, which can actually help the gynecologist to tackle this entity slightly more better. So on that positive note, let me just go ahead. Now, why are we discussing this today? Especially when there is a committee called Midlife Management Committee and when there is a society called Indian Menopause Society, I'm sure that postmenopausal women are never the neglected category as it once used to be. And postmenopausal bleeding is one of those dreaded symptoms, both for the woman as well as for the treating gynecologist. We obviously know that the vaginal and the cervical causes too can contribute to it, but I'm sure all of you would agree that our primary focus always remains on ruling out cancers of the endometrium as well as the pre-malignant conditions. Now, what are the possibilities if you happen to sample that endometrium in a woman with postmenopausal bleeding, or even in another scenario where the imaging creates a doubt in your mind and you want to sample and have a check on that endometrium under the microscope? There are various possibilities. It can vary from a relatively benign appearing atrophic endometrium, or it could be the most dreaded endometrial cancer. And you have the pre-malignant lesion in between, which is endometrial hyperplasia, especially the ones which are associated with atypia. And as you all know, as per the new classifications, there is no, they have avoided the complexity by avoiding the component of simple and complex hyperplasias. So today, it's only endometrial hyperplasias with or without atypia. Now, if you actually look at the statistics, almost 15% of endometrial biopsies that are taken in women who are 50 years or more would give you a report of a proliferative endometrium. I'm sure that this is the talk in every gynec department where one person who meets the other tells that I have a patient with proliferative endometrium. It's not hyperplasia, so what should I do? And in one word, there is hardly any literature available. What we have is probably some amount of case series and some schools of thought and some expert opinions, which can help us make a relatively balanced decision in consensus with what the patient thinks. Now, this is a report of proliferative endometrium, which probably many of you would be getting in maximum through WhatsApp messages, isn't it? Because the women are never happy with an opinion that is given by one gynecologist. So this probably is the most commonest report for which a second opinion is sought. And whenever there is no evidence, there is no studies, there is a possibility of a medico-legal concern, isn't it? Because nobody knows what is right. So if you decide to conservatively manage, you are still not sure whether you're doing it right. If you go for a radical approach and do something a bit too much, even then you're not really happy within yourself. And that raises a lot of medico-legal concerns in this era. Now, before actually getting on to what we should do for it, let's just understand a little bit of the proliferative endometrium and what role and what is the pathogenetic component that is there in this. Obviously, it's an endometrium, just like what you would encounter in a reproductive age group women. You can actually see the tubular glands with a lot of columnar epithelium, and then there is a lot of activity in the stroma, the mitotic activity of the stromal epithelium, a lot of cellular hyperplasia, and an increase in the extracellular matrix. It leads to a thickened endometrium during the proliferative phase of the endometrium, isn't it? And obviously stimulated by estrogen, which comes from the developing follicles. Progesterone effect, as we would always say, all the bad effects of estrogen are just washed away with a course of progesterone. It's like a stabilizer for the body, just like our electronic equipments are in our own household are protected from voltage fluctuations. So progesterone is that kind of a stabilizing hormone. It does oppose the action of estrogen, and the main effect is that it halts the proliferative phase. It induces secretory change by stimulating the endometrial glands and by increasing the vascularity. And remember that the thickness can increase even further during the secretory change because of engorgement of the glands, the stromal cells, as well as the blood vessels. Now let's look at this slide now. We are looking at extragonadal sources of estrogen, which probably is the most important contributor of estrogen in a postmenopausal woman. Let's go one by one, block by block. In a postmenopausal woman, let's start from here. There are low levels of estrogen and progesterone, which primarily come from the extrafollicular sources, okay? The most important source, as you all know, is from the aromatization in the adipose tissue. More specifically, if I'm allowed to talk, it's the mesenchymal cells of the adipose tissue, including the mesenchymal cells of the adipose tissue of the breast. Next, we come to osteoblasts and chondrocytes of the bone. Then there is vascular endothelium and the aortic smooth muscle cells. And did you know that even brain can itself produce estrogen? Initially, it was thought that hypothalamus can only control what happens below. That means it can control pituitary, it can control ovaries indirectly. But there are a lot of recent studies which are coming up. A few are human studies, a few are studies done in rhesus monkeys. And the pioneer is a person called Terasawa. They're talking about an estrogen which the brain can produce by itself. Okay. So thus, the circulating levels of estrogen in a postmenopausal woman are actually not drivers of estrogen action as you would see in a reproductive age group woman. They are some kind of a reactive component, because estrogen majority of the times, as I already told, is produced in extragonadal sites and it generally acts locally. And if this estrogen manages to escape the local metabolism, then it enters the circulation. And that's why it's reactive rather than a proactive component. Now, phytoestrogens are being in use for a lot of reasons, and it's very popular, even over the counter. A lot of people take this. We know about soy products. We talk about tofu being available in every supermarket in India now. These are structurally and functionally similar to estradiol. Now, does phytoestrogens which are being taken by these women or which are being prescribed induce proliferation and increase the risk of endometrial cancer? In one word, the answer is no. But I would tell you that long-term effects are still relatively unknown. The other component is this one. What is this? I hope you know it's black cohosh, supposed to be a wonder herbal remedy for menopausal symptoms, vasomotor symptoms, hot flashes, and all that. Now, there is some amount of uncertainty that remains that it could actually induce some amount of proliferative effect on the endometrium. Now, coming on to the most important question, are women with proliferative endometrium at increased risk? Now, if you look at it, endometrial cancers, they originate in the background of proliferative activity, isn't it? In a very inactive endometrium, it's quite unlikely that it can turn into an endometrial cancer. The likelihood of simple proliferative endometrium transforming into a malignancy is very low, without a doubt. Significantly much lower than the risk of endometrial hyperplasia progressing into cancer. And that's why a proliferative endometrium as such is never considered to be a pre-malignant lesion. However, you need to consider risk factors like an increased body mass index and age. Now, both increased body mass index as well as age is associated with more amount of peripheral aromatization. And also they bring in common comorbidities for patients with endometrial cancer. Now, what are those risk factors that we are thinking of? We are thinking in terms of conditions which can cause unopposed estrogenism, which could include the most commonest entity, which is a polycystic ovarian disease. It could be type 2 diabetes, a family history of endometrial and colorectal cancers, and a personal history of breast or ovarian cancers. Now, how do you manage these women? In one word, again, there are hardly any studies. Hence, at present, if you really want to give an evidence-based treatment for your patient, then you don't actually have a good amount of evidence which can actually guide your treatment. Now, if you wish to treat them with progestogens, again, there are no consensus on the recommended dose and the duration of treatment. There is neither any agreement on the frequency on which these women need to be followed up to rule out the more sinister endometrial pathologies. But then we have patients with endometrial proliferation, right? So what do we do with them? Let's look at some of the case series. Let's look at some of the schools of thought that actually exist. Now, there are various schools of thought that would exist amongst gynecologists in managing them, and that has been reflected in various case series that have actually come out recently and even before. Now, as the risk of proliferative endometrium transforming into a cancer is very low, one easy option is to reassure the patient and just follow them up. Now, if you actually want to intervene, one way to intervene without much issues is to use systemic progesterone therapy. And that would ensure that you are inducing regression of this proliferative endometrium. If you want to use an oral medroxyprogesterone acetate, it can be prescribed for relatively short periods, around 6 to 8 weeks, to induce endometrial regression. Most people tend to use it almost on a daily basis for up to 6 to 8 weeks, and then they move on to the cyclical regime of using it almost 10 to 14 days every month for the next 3 months, and then follow them up. Now, whenever you decide to begin them on progesterone therapy, it actually always has to be balanced carefully against the side effects that it can produce and contraindications like deep vein thrombosis, which you never want to neglect. What is the more long-term option? Definitely an intrauterine progesterone system, which can actually thin the endometrium by releasing progesterone into the uterus and probably avoids a lot of systemic side effects too. Now, both the medroxy progesterone oral therapy as well as the intrauterine system have been shown to protect the endometrium and proliferation and as well as malignant transformation. And Mirena, as you know, has been licensed to be used for endometrial protection for almost up to 4 years. Now, there are more questions. Is a single biopsy sufficient to treat a proliferative endometrium, or you want to repeat it one more time and then decide whether you want to intervene or not? There are schools of thought, and there are many who believe that a repeat biopsy, especially if it's a PIPL, because it can be made to happen so conveniently, a repeat biopsy is not a bad option. Do we really require a repeat biopsy? If you're happy with the initial sampling, then you may not actually always require a repeat biopsy. What frequency to follow up these women, maybe 3 months later after a progesterone therapy, is a reasonably good guess from the lessons we have learned from managing endometrial hyperplasia. Now, should risk factors such as high BMI and breast cancer reduce the threshold for offering a repeat biopsy? The answer seems to be yes. When there are definite risk factors, maybe you need to keep them on more frequent follow-up so that your patient would be benefited. Now, what is the most radical approach to treat a proliferative endometrium? Is a hysterectomy. On one go, it might actually sound very absurd, but remember that if you are taking that decision, it always has to be a very combined decision, talking to the patient about the risks and benefits involved with such a decision making. Occasionally, it may be justified when patient has a proliferative endometrium and has repeated episodes of postmenopausal bleeding, which you are unable to tackle. And you're always worried, isn't it? In whichever endometrium you sampled, you're still not sure whether you have sampled it in entirety, whether even in an atrophic endometrium where there could be focal areas of proliferation is what you're always thinking of. And obviously, a hysterectomy would eliminate any risk of transformation into an endometrial carcinoma, but definitely weigh the anesthetic risk, the operative risk to the patient, and as well as psychological impact, because many women, we are living in an era where gynecologists as well as patients themselves are on the Save the Uterus campaign. So the psychological impact of losing a uterus also has to be considered. Now, this is a wonderful article which has recently come up in 2020, which looks at the long-term outcome of postmenopausal women with proliferative endometrium on endometrial sampling. I told you almost 15% of endometrial sampling in a woman who's 50 or more could be a proliferative endometrium. This study had almost 962 women who met the inclusion criteria. 278 had a proliferative endometrium, 684 had an atrophic endometrium. 11.9% of women with proliferative endometrium developed either endometrial hyperplasia or cancer. That is the risk that you need to remember. It's almost a 4-fold greater incidence when you compare with a woman with an atrophic endometrium. Now, these are the data. 11.9 to 2.9% of women, okay? The higher risk of developing endometrial hyperplasia and cancer put together. If you take endometrial cancer alone, 5.8% versus 1.8%. I'm comparing women with proliferative endometrium to women with an atrophic endometrium. If you are taking in terms of transformation into an atypical endometrial hyperplasia, it's 2.2% versus 0.4%. Non-atypical endometrial hyperplasia, 2% to 0.7%. So we know that there is an increased risk of progression in these women. So these are women who probably the moral of the story is that they need to be monitored. This is a lot of evidence that have probably come up over the last so many years. Evidence was not so good in the initial year. That's why we never had a clearer picture. But we have better and better case series that are coming up and more definite schools of thought which are helping our women to be managed better. Now, I cannot probably leave you without some take-home messages. Remember about the extra follicular sources of estrogen, which actually can stimulate this endometrium to proliferate even in the postmenopausal phase. Remember that cancers of the endometrium originate only with the background of proliferative activity. So even in an atrophic endometrium, there could be focal proliferation, which has been found out by studies. Likelihood of a simple proliferative endometrium transforming into a malignancy is very low. Beware of risk factors like higher BMI and increasing age, which can actually increase the risk at which these can get transformed into more sinister endometrial pathologies. At present, no evidence-based treatment for such women with proliferative endometrium. As a risk of proliferative endometrium transforming into cancer is very low, one option is to just reassure and keep the patient on follow-up. If you want to intervene, you can use progesterones, either an oral therapy or an intrauterine system. Oral progesterone may be on a daily basis for up to 6 to 8 weeks, and maybe you can shift on to a monthly regime or an intrauterine system, which can be a long-term option. A more radical approach is to treat the proliferative endometrium with a hysterectomy, but only a combined decision only may be indicated in those patients where there are repeated episodes of postmenopausal bleed and patient is so very anxious, and you probably are not in a position to assure the patient that everything is all right. So with those words, with the hope that I've done some justice to that topic that has been thrown to me, thank you so much for a very, very patient listening. It's been wonderful to be here today.
Thank you very much, Shaijas. I think you took, sometimes people give difficult topics to speakers because they expect that they will do justice. So, and I think we all learn a lot when we, tackle a topic that we haven't tackled before. So I'm always grateful when people set those challenges, and I'm sure you are too. You did a very nice job. So thank you. All the three talks today are on topics that
Thank you. It was really actually very informative talk by Dr. Shaijas. Thank you all the chairpersons and the speakers. And now we move on to today's next session, and that is the inauguration. And for this grand inauguration of 20th annual CME of Noida Obs and Gynae Society, I would like to call upon Dr. Anshu Rana, who is the lady behind the success of this annual program. And Dr. Anshu is secretary of Noida Obs and Gynae Society and a senior consultant at Apollo Hospital, Greater Noida. Anshu.
Thank you, Dr. Anshu, for kind words. And good afternoon, everyone. Continuous improvement is better than a delayed perfection. With this beautiful quote, I would like to welcome each and everyone to our 20th annual CME of Noida Obstetrics and Gynaecological Society, that is tapping the untapped. Namaskar again, our respected seniors, dignitaries, colleagues, and friends. Myself, I feel pleasured. It's my honor to welcome you all the inauguration ceremony. For this, I would like to invite our esteemed guests to grace the virtual dais. For this, I would like to invite our chief guest and our own Foxy president, Dr. Shanta Kumari ma'am. Welcome, ma'am. Still not joined. Our next guest is our president-elect, Dr. H.D. Pai, sir. Welcome, sir. Our past president.
So much. I'm nearby you in Gurgaon.
Great, sir.
So our past president, Dr. Nandita Palshetkar, ma'am. Our patron of UPCOG, Dr. Usha Sharma, ma'am. Welcome, ma'am. Organizing advisors, Dr. Madhu Srivastava, ma'am, Dr. Chitra Setia, Dr. Uma Sharma, Dr. Rakhi Singh, and organizing chairperson, our own and vibrant dynamic president, Dr. Sujata Bhatt, our vice president, Dr. Aradhana Singh, Dr. Sanchita Dubey, our treasurer, Dr. Shushmita Prakash, our joint secretary, Dr. Nandita Gore, our joint treasurer, Dr. Preeti Singh. So you all are welcome for this inaugural ceremony. Light represents the Almighty, and without the lamp lighting, inaugural function will be incomplete. So I'd like to formally inaugurate the ceremony by our traditional lamp lighting. For this, I would like to call on all dignitaries on the virtual dais to please join for the lamp lighting. Both, please arrange a lamp lighting for us.
You're not audible, Anshu.
Anshu, you're muted.
Thank you, our all dignitaries, for joining us for virtual lamp lighting. So now, any academic event is incomplete without the blessings of Ma Saraswati. So for that, we present to you the Saraswati Vandana sung by our own loving Nogs member, Dr. Lalita. Mr. Subodh, please play the Saraswati Vandana. Thank you, Dr. Lalita, for a beautiful song in a beautiful. Thank you so much for your participants. Now, I thanks each and every dignitaries, whoever is joining today for our virtual inauguration and for a lamp lighting. Thank you each and everyone. Now I present my secretary report of year 19 to 21. So please bear, I just wanted to share my screen.
I'm sure your voice is not coming. Anshu can't hear you.
कुछ नेट कनेक्शन गड़बड़ हो गया शायद.
Anshu is mute. Why is
Anshu, can you just
Anshu
unmute
can't hear
yourself?
you.
Anshu, you are muted.
No, she's not talking.
Anshu, unmute करो. Anshu, unmute करो. हाँ, unmute करो. नहीं हुई अंशु. म्यूट का साइन आ रहा है.
Can the host unmute her or send her a message to be?
हाँ, can host unmute her? हाँ, वो फोन कर रही है, कुछ गड़बड़ है.
म्यूट का साइन आ रहा है अंशु, देखो तुम चेक करो एक बार.
Ma'am, I've informed Anshu. She's trying her level best, and she's just patient, just 2 minutes.
अच्छा, वो हो नहीं रहा है शायद अनम्यूट. होस्ट कर सकते हैं क्या अनम्यूट?
Mr. Sudeep can help, I think.
No, madam, it has to be done from her side only.
अच्छा. Okay.
So,
Anshu, maybe you just close your PowerPoint and start again and then share.
Can somebody else share the screen for her? Can I share the screen for you if you want? If you could send me the.
Actually, ये बिल्कुल बोल नहीं पा रही ना, उसको आवाज नहीं आ रही ना.
Okay.
Can
I think
somebody
we just
make her
patiently
the
give her
host?
2-3 minutes, she'll manage.
Yeah, she's there, I think. It must be a heavy file for her. 2 years.
Yeah, but sharing is happening now. I think only thing
Yeah.
is unable to
Anshu, ma'am, I think
unmute
you could log
herself.
out and log in once more. I think that could help because sometimes that does help.
Or in the PPT now, since you've shared, you again check if
You
you can
unmute yourself, Anshu. Unmute yourself now.
Can somebody make her
PPT
the
is
host,
coming.
please? She's not the host.
Hello.
Make her the host.
Yeah,
we
हाँ,
can
अंशु,
hear you.
अंशु
Your
आई
PPT
आवाज.
Your
अंशु
PPT is
ठीक है,
visible.
अब ठीक है अंशु, बोलो. हाँ, बोलो.
Sorry for the technical glitch.
हाँ.
So
The share is gone. PPT is gone.
better.
Anshu, madam, should I share it?
It was visible.
Yeah, you can share.
Do you
I'll share it,
want me to share it?
Just a minute. Just give me.
Yeah.
Yeah,
Take
she
your
can
time.
start sharing again. No problem.
Anshu, ma'am, the mute symbol has gone anyways. I think you can try talking and you can check once.
मेरे ख्याल में अपनी स्क्रीन से बोलती जाओ.
Yeah.
So, do you want me to share your screen?
Yeah, you can.
I'll just share it.
It is there.
Just
Yeah, it is there. You can speak now, Anshu.
I'm audible now.
Yes.
Those were the CME days when we used to enjoy the academics with our heart and heartfelt talks. We, as all others, have also evolved smoothly from the CME to the webinar modes and become a little tech savvy. So now I'm going to present my secretary report. I handed over in year 2019 November. Ma'am, you are able to share? I don't know what happened to my.
Yes.
Anshu, we can
Yeah,
see the
सही है.
PPT.
Can you see the
also.
presentation? We can see your presentation, Anshu.
Yeah, it's.
I'll kindly stop share it. I'll do the sharing.
Presentation is visible.
दिख रहा है ना? दिख रहा है,
It's
सब दिख रहा
not
है.
moving correctly. I'll let
Anshu,
me
madam,
do
you can
it.
share now.
Yeah, it's so visible.
नहीं, राखी तुम ही शेयर करो जैसे
Just
कर
give
रहे
me
थे।
1 minute. Just give me 1 second. I am going to do that.
जब तक तुम अंशु अपने उससे पढ़ो।
Yes, ma'am.
हाँ, क्योंकि वो
आ
कोई
गया,
बात
आ गया।
नहीं।
बोलो।
Now it's visible.
Yes.
Yes, yes.
My tenure started on 16th November 2019. You can see the pictures
Yes.
of all the chains of guards. Then I started my tenure with the normal routine physical and in-person CMEs, and we were happily enjoying in initial days our in-person CME. So that's just after few CMEs, the COVID things started, and we stuck with that. But till the time, at least myself was not that tech savvy to present and do all the things on this webinar form. So it was a most horrifying thing for myself. But the thing is, whenever you used to stuck for something, that itself teaches you how to proceed and how to learn. And this was happened with me. And I started my journey with all these. So I started my CMEs, and these are my CMEs, which I started with. And these are the few pictures you can see when we were doing the in-person CME with the few pictures which is available. And after that, we switched to all these flyer forms in webinar form. And then we started and keeps on doing all these webinars only, fortunately, unfortunately. So now we end up with all these Zoom platform and all the meetings on in a webinar form. So after all these things, we always tried our best to just continue our all journey as per the FOXY guidelines. So we did our CSR, the community supportive recreation activity, also by public awareness through the NORCs. And in this, we started our journey through the first by 8th March. And that time, actually, the was started and we were horrified, and it was like in a very panic situation. We did our last in-person camp, and that was on the Women's Day cervical cancer screening camp in association with all 3 hospitals we involved. And with that, these 3 hospitals, we did the camp, and it was successful with lot of patients were screened and examined during that time. After that, we did all the things on a virtual form, but we keeps on doing, and we did our all that National Yoga Day, our organ donation day, that World Environment Day. So these things were covered nicely. And lastly, we started with our CSR activity with the PPE kit and N95 mask donation to the government hospitals. We did so many CMEs with the liaising with the FOXY committees. And in these, the few hours, like with the endocrine committee, MTP committees, and Save the Uterus Mission and committees. And all these committees, we did lot of CMEs. We did our annual CME on a webinar form in last year in month of September 19th and 20th. And it was a quite successful annual CME with the more than 700 to 1,000 of login people throughout and abroad. Then we did our 20th as we are here for this CME, and few recreations activity also we tried our best to do, but not much. But still, we managed to do these kind of things to just entertain ourselves and entertain our Noida Obstetrics and Gynaecological Society members. So those were the days waiting to roll over with CME activity in person. We are still waiting to go for all these days. And the capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice. So thank you so much. With this note, I just wanted our NOGs again and again, and this is my just saying for this. Thank you so much for patience, Harry.
Thank you, Dr. Anshu. You really did great job in tough times of COVID. you and Dr. Sujata, I think both, you know, they need a great round of applause for both of you. And so now we move on to the inauguration. And as it is said that every day is a chance to be better, I think by attending this webinar and listening to the stalwarts here today, we are definitely going to be better and wiser after this day. So now I invite we move on to the grand event of this program, the oration by none other than Dr. Shanta Kumari.
Aradhana, 1 minute. Before we move on to our oration, we would like to invite our chief guest, Dr. Shanta Kumari, to kindly bless us with few words.
You can see
Dr. Shanta Kumari, madam.
Sure,
President Foxy.
Welcome, ma'am.
Thank you. Good evening, everyone. I think it's
For me,
a pleasure.
Nandita ma'am was traveling, and she promised me she will try.
Yes.
And I'm
Yes.
Thank you.
Thank you, ma'am.
Over to you, Shanta ma'am.
Yeah, thank you, Dr. Rakhi. And it's a pleasure to be here. Good afternoon, Dr. Usha Sharma, madam, and my dear friend Nandita and Dr. Sujata Bhatt, Dr. Rakhi, Dr. Anshu Raina, and all the other members of Noida OB-GYN Society. Yeah, it's nice to see you all, but not so nice as it would have been to see you all in person. I would have been happy if it was a physical event, as Anshu has said before. Nevertheless, I think we shall have more occasions where we shall meet physically. And wish you all the best for the Congress. And we did have a very nice evening day before yesterday at Meerut with Usha Sharma madam's blessings. I and Archana were there. So it was a pleasure to be there at Meerut Society, and we're really looking forward to visiting all the other societies, so that, you know, that gives us the sense of feeling or oneness to be with each other. So thank you very much for doing a lot of good work. Noida Society, Dr. Rakhi is one of our very efficient chairpersons, and she's doing very good work. We have seen your whole team do such a great work for the UFOXY conference with Nandita's year. Dr. Anshu, Dr. Sujata, everyone, the whole Noida Society. Sorry, if I'm missing names, I don't want to take names, but the whole Noida City Society did a fantastic job. We really had a great North Zone UFOXY. And now here we are. Thank you. Hello, Dr. Deepika.
Thank you, Dr. Shanta ma'am. Can we have a few blessings from Dr. Nandita ma'am also, please?
Yeah, thank you, Rakhi. Thank you so much. I'm really sorry, but the flight seems to be taking
Okay, ma'am.
off.
Thank you for taking out your precious time at airport to log in.
No, Anshu, thank you so much. And it's always a pleasure when Shanta is there, you know. She's a darling, and she's doing so, she's bringing Foxy to the international front. So I'm really proud of her. And Dr. Usha Sharma, who's here, whom we all love and adore, and is such an inspiration. So thank you for inviting me here, but I doubt I will be able to continue because the flight is moving now. Thank you, girls. And Shanta, thank you very much. Thank you.
You're going to miss you, ma'am.
Thank you, ma'am. Thank you for taking out your valuable time.
Thank you, Rakhi. Thank you.
Thank you.
Bye. Bye.
I think we'll move on to our academic session before wasting much amount of time. We are very much thankful to our Dr. Pai has joined.
Yeah, thanks.
Sir, welcome, sir.
Sorry
Pai,
about,
sir,
I
change
actually...
your name, sir. It is coming, Rakhi Singh. Kindly rename yourself.
Okay. मालूम नहीं क्या हो रहा है. But doesn't matter. That Zoom is saying that we all are one.
We know you are Rishikesh Pai and not Rakhi
either.
Yes.
No, I'm just saying that Zoom is saying that we all are one, whether we are Rakhi Singh or Dr. Rishikesh Pai, we are all one Foxy
Oh my
member.
God.
That is
an
what.
honor.
So, I'm sorry because I got bumped off, from the Zoom. I don't know what has happened. Some internet problems. So I've come through my phone now. So thanks a lot for calling me. And I don't know what has transpired, but, I'm sure that Noida is a fantastic society. And we hope that one day you will do the AICOG for the North. and wish you all the best for the annual. And you're a dynamic team, no doubt about it. Very active, and means overall, I feel the NCR is a very dynamic region, and I think all the seniors are there. I don't know now because I suddenly got bumped off, but Rakhi is there, Anshu is there, the president is there, so we all there. So I would like to really thank you and wish you the very best. Thank you.
Thank you, sir. Thank you. Over to you, Aradhna, please.
Yeah, thank you, Dr. Rakhi. So now we can't stop listening to our dynamic, ever smiling, ever energetic Shanta Kumari ma'am's oration. And to chair the session, I would like to invite Dr. Usha Sharma ma'am. Ma'am, we are honored, and I am really honored to invite you. And you are, Madam is a teacher of the teachers, and she is a Padma Shri by President of India, receiver of the Jewels of India Award, BC Roy National Awards. Ma'am, the list is so long.
Oh, no.
It's long, and I can just say that we are honored to have you here in Noida Obs and Gynae Society today. The next chairperson is Dr. Madhu Srivastav ma'am. Has she joined? Ma'am is the founder president of Noida Obs and Gynae Society, and she is the torch bearer for us, and a great clinician and great human being. Dr. Madhu ma'am. Dr. Nandita has to leave, so I hand over to you, ma'am.
Kindly introduce Dr. Nandita also, please.
Yeah, Dr. Nandita, can we have Dr. Nandita needs no introduction. Of course, she is the former President Foxy 2019, President MOGS 2020-22. She's the President MOGS 2016 and 17, President IAG 2017 and 18, President-elect ISAR, and a great human being and a lovely lady of the Foxy.
Kindly share the screen for Dr. Shanta ma'am's
CV, yeah.
CV, please.
I request Usha ma'am to kindly start.
Oh, yes.
Yeah, ma'am.
Welcome. Mera hata do.
Dr. Shanta.
Meri slide hata
Next.
do.
Yes.
Okay. Thank you very much, Aradhana. I must say, my dear Rakhi, Chairperson Endocrinology Committee, President Noida Society, Dr. Sujata Bhatt, Secretary Anshu Rana, and Master of Ceremony Aradhana Singh, and all other dignitaries who are present over here. I just now saw Dr. Madhuri Patel, Dr. Nandita Palshetkar, Dr. Shanta Kumari, and all of Rishikesh Pai and all others. Thank you very much, Noida Society, for giving me this honor to just introduce the golden star of our Foxy, Shanta Kumari. She was with us on 7th of October, and it was a real pleasure to be with her, because I always say that she is a lady of great ambitions and great encouragement. She is the first president, I said, that who has given the plan for the whole year in the beginning of her tenure, which is really creditable. And it's my proud privilege to introduce our great, dynamic, dedicated, and hardworking president, Dr. Shanta Kumari. Shanta Kumari is a senior consultant obstetric and gynec laparoscopic surgeon, Yashoda Hospital, Hyderabad. She is a FIGO member for Committee for Human Rights, Chair and Violence Against Women 2018 to 2021. She is Chairperson Foxy ICOG 2018, Secretary ICOG 2015 to 2017, Vice President Foxy 2013, IAG Managing Committee Member 2012 to 2018, Secretary TCOGS, Foxy Chairperson MNRRC Committee 2008 to 2010, National Corresponding Editor for JUGI 2011 to 13, and her major awards and achievements are FRCOG UK 2018, FRCPI of the Royal College of Physicians of Ireland, initiated Dhira 2016, a great job,
Madam,
I will say.
thank you, madam.
नहीं शांता थोड़ा सा तो और हो जाने दो.
That's right, madam. आपका आशीर्वाद है.
I would like to add one more thing. She is the first treasurer of FIGO.
FIGO, yes. I was just now. Shanta ने मुझे रोक दिया बीच में. And you know, today she will be telling about a subject which is though it's not new, but it's the most important thing in day-to-day practice, because now the classroom teaching is very old and it is not that beneficial as we have simulation training in obstetrics and gynecology. And none other than our great Dr. Shanta Kumari will be deliberating on simulation training in obstetrics and gynecology way forward. The stage is yours, my dear Shanta, and please go ahead.
Thank you, madam, for your kind words. Can you all hear me clearly? Because I'm outside.
Yes.
Yeah, the internet is not very stable. So I have to really thank the Noida Society for having me here. And Usha madam, let me be very honest. This topic was not something which was close to my heart. It was a topic which was decided by the Noida team. And I was also a bit hesitant then, but then the Rakhi, Chinmayi and Sujata, but all decided, Anshu all decided this is quite a good topic for the oration today. So I think the topic and the credit goes to all these guys and Chinmayi too. Thank you very much for having me here. And madam, yes, we have seen that a lot of changes have happened now in 1 minute. Let me share this. Can you? 1 second, I'm just trying to share. Yes. Just now we have heard Dr. Usha Sharma madam being introduced as one of the most dynamic gynecologists, or it was an excellent teacher. That is what makes Usha Sharma madam what she is now. Why do we all love her? I'm not from UP, I'm not from Meerut. Neither am I from North India. I'm from somewhere Hyderabad. But we have so much of respect and regard for Dr. Usha Sharma. That is because of the one important aspect of madam, that she was an excellent teacher. She was a professor par excellence. I think that is very important for somebody to make a mark in the field, especially OB-GYN or any other field. So now we are now at a cross section where the teaching, training, everything is undergoing a sea change. Will we be in a position to have people who are like teachers par excellence, like Dr. Usha Sharma, Professor Pratap Kumar, Professor Krishnendu, Professor C.N. Purandare, and the likes? They have been teachers. What is the difference between their students and the present day students? I think the situation was very different when these stalwarts were actually leading the OB-GYN department. Now we have seen that the training and the trainees both have actually evolved, and we need to evolve with the times. And that is the reason why this simulation training in OB-GYN is now looking the way forward. So rightly said. That is why it's the need of the hour. And friends, this year, I have been fortunate to take over as the 60th president of FOXY with the theme FOXY for all, always, and Dhira Stop Violence Against Women. Now, when you look at the vision and mission of FOXY, FOXY believes in taking care of women's health and taking care of its members, making sure that the academic interest of the members of the society is given the utmost importance. That is a vision and mission of FOXY when it was formed 70 years back. And now we do understand that despite the COVID, despite the pandemic, whatever it is, our vision and mission should be always there, which will uphold the core of being a Foxian. So what is Foxy for all? Foxy for every mother, so that we can reduce the maternal mortality rate, achieve the SDG goals, and let no mother die in childbirth. Foxy for every woman who we care for, so that every woman is courageous and able to stay strong and fit with Dhira, saying no to violence against women. And Foxy for all Foxians, for the safety, dignity, and being able to practice with protocols. And Foxy is for every student of OB-GYN who is going to evolve into a physician, into a surgeon taking care of women's health. So I think in this aspect, it's so very important that we actually give a lot of importance to the training. Being a man or a woman has a significant impact on health as a result of both biological and gender-based differences. But women are often at a disadvantage. As OB-GYN specialists, we have to overcome this disadvantage. We have to standardize healthcare delivery to our women. That is the reason why we need to train our generation next to be able to be the best to take care of women's health, come what may be the situation. So what is it that we are talking about? A simulation. A simulation is nothing but an imitation of the operation of a real-world process or system over a time. It's an animated model that mimics the operation of an existing or proposed system. We used to actually hear about the video games and all about 10, 15 years back. And then we used to wonder, what is it that these children are getting attracted to? The school children, kids, all were actually addicted to it. And slowly we realized that simulation is nothing which is offering a powerful evidence-based approach to a decision-making by using a virtual representation to test the impact of process changes and what if scenarios. You can find an approach that will deliver the best result. So that is what we understand by simulation. These video games, we used to think that it's a waste of time, it is making the children go off track, and we thought, why is it that we are allowing our generation next get addicted to these video games, and instead of the physical games which will keep them physically and mentally fit? But when you look at these video games, that simulation is providing the kids the out of the world experience. They're of course hooked to the screens, and most of them are finding that the experience is thrilling when compared to the traditional real-time games in the absence of actual friends and playgrounds. So the same concept is being used in the modern. There's a paradigm shift from the traditional medical training to less stressful on both the patients and the trainees for sure. When we were undergraduates, we had a lot of patients, lot of times we were exposed to the clinical cases. I think we have had the opportunity to see every kind of clinical case in our training. And at that time, we had the patients also who are actually willing to get examined by the students. They were actually willing to tell their history to the students. They were willing to be examined by the students. You know, even though if it's a public hospital, the patient had a right to deny. I still remember my surgery professor, Professor A.Y. Chari, who used to tell the patient, who used to make some issues when saying, why do I want this small girl or boy ask me or examine me? So what that professor used to say is, if you don't allow this girl to examine you, if you don't tell her the history, tomorrow when you become old, when your child becomes an adult, who will take care of their health? So unless you allow them, you will not be able to get good doctors for your generation next. But those days, they were still willing to listen. But now we are in an era where we're talking about privacy policy, we are talking about rights, patients' wishes, and everything possible. So in this scenario, we understand that the traditional medical training has to evolve so that it is less stressful on both the patient and the trainees. In that bargain, simulation has been a part of the training modules throughout history. Theory without practice is like a one-winged bird that is incapable of flight. That's so very true. So we need to understand that simulation, though it is there, how you can actually utilize that to learn better is very important. And when I look at history, ancient history, one of the earliest examples of simulation was from 600 BC. It was for the plastic surgery using clay and leaf model to demonstrate a forehead nasal flap. Imagine those days, they were doing the nasal flaps by the Rishi Sushruta, father of Indian medicine. Multiple surgeries were mentioned in the book, rhinoplasty in a very detail, and that could be compared to the modern day rhinoplasty. Because in those days, I believe the corporal punishment of cutting off the nose was very common. And so they need to have these surgical techniques to help them. And reconstruction of the nose using flaps from the cheek and forehead has been mentioned in detail. So that is the history of ancient India. And I believe Sushruta got his students to practice incisions and excisions on vegetable fruits and graduate leather bags filled with mud and fluids of different densities, and graduate to practice on animals and then on human corpses before being allowed to assess surgeries. So true. Now, when you look at the endoscopy and all, don't we tell them, like, you start using the samples where you learn the art of cutting and all with your instruments? I think that is the basis of trying to use a simulation in surgery. So simulation activities are actually designed to provide us with opportunities to learn in a safe and controlled environment. So it can provide an immersive experience which will actually lead to the practice. If you are able to give a platform for the students where they can put what they have learned in the theory to practice before they can actually go on to try on the patient, I think that is which is very important. So in medical education, the term simulation refers to instructions in which the learners interact with specimens of a clinical task, a clinical context, or an environment to learn the clinical skills that can then be applied directly to actual patient care. The use of simulation-based methods provides medical students the opportunities to acquire the confidence, knowledge, skills, and workplace behavior required to provide quality patient care in a safe learning environment. Now, when we look at the present-day obstetric training in India, we do have the mandatory maternity postings for the undergraduates. But 25 years back, when we were undergraduates, 30 years back, we found that we were at a much better situation than the undergraduates now. You know, we used to have that logbook, and minimum 30 to 100 deliveries we had to conduct as a final year student before going for the exam. And now we find that postgraduates themselves are also not doing that much work. So we know that PG training is a unit-based acquisition of knowledge and skill transfer through personal mentoring in addition to the didactic training. So the day-to-day PG teaching in OB-GYNs, we know there's a daily clinical rounds, OPD, everything. Then the lectures, case presentation, and seminar. But there is sometimes we find that there is something which is missing. So the transfer of skills and knowledge, which is done over a period of time in a seamless manner from the mentors to the mentee. And we find sometimes that we need something beyond the didactic or bedside clinics. It doesn't mean that simulation is going to replace the didactic or bedside clinics. It is actually, it makes the learner more prepared, competent before practice. It enhances the learning and complements each other. When we look at OB-GYN, as we review the role of obstetric simulation through the continuum of training and practice, we realize that the concept is there from ancient times. It has interest in simulation as waxed and waned. In fact, if you all recollect, the simulation model started with the endoscopy becoming a boom, because it was realized that was the time where we had expert open surgeons and we had people who were learning the laparoscopy. And so these initial people who were learning this skill of laparoscopy couldn't directly go and do on the patient. So simulation was a way and means of trying to acquire the skill before being tried on the live patients. So this real-time issues of students and teachers in medical training showed the usefulness of simulation in medical training. And that's why we have evolved to the present day. We know that new technology, graphics, and revolution in the internet generation has redefined the role of simulation training in modern medicine. Although obstetric simulation incorporated high fidelity, birthing, critical care, ultrasound simulators, may feel like a new phenomenon. Its roots in academic medicine have been seeded very early all over the world. The simulation training in OB-GYN concepts. At the June 1898 meeting of the Association of American Medical College, the Whitridge Williams of Johns Hopkins presented a paper titled Teaching Obstetrics, in which he identified simulation as an important element in obstetric teaching. As deliveries moved into hospitals in the 1900s, obstetric trainees were exposed to a large and diverse group of patients, and needed simulation appeared to wane. But again, when you look towards the end of the 20th century, the interest in simulation was regenerated because of the contemporary changes in medical education and concerns for patient safety. When you look at 2003, a current commentary published in OB-GYN called attention to a potential role of medical simulation in obstetrics and gynecology. The authors were all military physicians who witnessed firsthand how military effectively used aviation simulators and war games as an integral part of the military training, and ultimately how simulation contributed to mission success. So this aviation training, actually the success story of simulators, the flight simulator training is a valuable tool that the students can utilize to build flight time, improve technique, and learn the valuable lessons. And from here, we actually learn how we are going to manage our obstetric issues like PPH, and how we are going to have those guidelines, how we are going to have the protocols. See, he may be an experienced pilot, but he has that 1, 2, 3, 4. He has to read that. This is the protocol 1, 2, 3, 4, 5. So if I, as an OB-GYN entering into the labor room, if I'm going to face a critical patient, if I'm going to have a patient on PPH, what is it? I may be a senior most teacher. I may have delivered thousands of women, but if I have everything in place, 1, 2, 3, 4, 5 in this, then the chance of missing and going wrong is much less. So the same technology is used for our OB-GYN training. And then the mannequin simulators. We know the history of modern mannequin simulators suggests that early years were marked by several parallel, almost entirely independent development that pursued somewhat different objectives and led to different in the technical approach. And the challenges in psychomotor conception. So this was especially so for laparoscopy with the long instruments, then restricted range of motion, use of the non-dominated hand, amplified reverse movement, small inaccuracy in motion, then the vision, magnification, the coordination between the eye and the hand, all these needed simulators because we don't have the tactile feedback. But with experience, you can even have the tactile feedback when you know with your instruments, you can have an idea. So that is where your simulation will help. That is where all these mannequins, the box trainers, the animal models, and all these simulators are going to help. So the virtual reality simulator, nowadays students are very lucky because we've got a sophisticated, complex algorithm-based software technology combined with specialized hardware, enabling generation of interactive real-time computerized simulation that mimic the visualization and sensation of real-life procedures. And we find that not non-medical people are all giving us real-time simulators for the Generation X doctors. So it's really the entertainers. So you can practice the full procedures and manage the complications. And learning anatomy. We still remember we read anatomy somewhere in our first year. So by the time you reach your final year, you would have forgotten all what you have really done. And when you come to a post-graduation, that is when you're doing surgery, when you're a resident, when you're assisting a surgery, when you're going to do your first surgery, that is the time where your anatomy is needed. Ideally, that is the time you actually go back to your anatomy department and go back to your pelvic anatomy, and then you know where your arteries are, where your veins are, where your nerves are, where the lymph nodes are. What is the relation between each and each part of the anatomy? So when you don't have the chance, I think this virtual reality simulator is going to help you because that will give you an unbiased feedback and performance. Your psychomotor-based skills. Because all these aspects, especially in cardiology, laparoscopy, endoscopy, suturing techniques, now advanced robotic. And robotic is again a skill-based. It is again using the simulation, which will show that the potential benefit of simulation is to improve patients, especially the retroperitoneal surgeries, the pancreatic surgeries. This is where the robotic surgery is helping a lot. So this increased technical performance, knowledge acquisition, and we do understand that mistakes are allowed in simulation. You can't make a mistake on your patient. So new technologies or procedures will be tested in simulation before implementation in the real time with real patients. The team can simulate patient care flow in situ for critical events, adequacy of new facilities and equipment. Now we've got a lot of simulation centers. They are very highly equipped and they're very, very expensive. Foxys, we are looking forward to have our own simulation centers, and we will be coming forward with our simulation centers soon, where we'll be giving an opportunity for our students to get trained in these simulation centers. Essentially, all the original simulators and simulations have evolved into products or concepts that are currently enabling changes in healthcare, education, and patient safety. The most important is acceptance of a new technology. I still remember when endoscopy came, all the seniors used to say, this is absurd. This will not stay. No, you cannot do endoscopy for all the surgeries. And oncology, an absolute no. But now look, see where nobody can survive in the OB-GYN unless you know a laparoscopy. And unless you know the skill of what is latest, you will not be a good practitioner. At the same time, we see that we have so many patients to learn on. Why do we need to have simulators? This was a question which was asked a few years back. It doesn't feel real, but COVID last year, we have seen that we are moved from the real to the virtual classrooms, even MBBS students. I have my niece who had joined the first year just before the COVID set in. And now I was worried that this batch will actually graduate to become the COVID batch, and they'll become doctors without having put their hand on the patient. But now when you look at the situation in the medical college, they've got so many simulation labs, and that has made them very competent. We know that now is a time where we need to evolve. Industries with a perceived higher risk, such as aviation and nuclear industries, have a much better safety record than healthcare does. So 1 in 3 million risk of dying while traveling by airplane. But are we going to stop? Even now, I just flew to Goa. I was back from Delhi. So that is a way of life. So remember, when the risk of patient death occurring due to a preventable medical accident while receiving health care is estimated to be 1 in 300. So naturally, we would like to make this much bigger so that our patients are safe. So that is why we need to adapt to the new education system. Almost all the medical schools used human cadavers for teaching till recently. Many medical schools started investing in mannequins for practice of skills in the past few decades. My classmates from MBBS, we all were just discussing few months back. We were actually when we were doing anatomy, we never used to wear gloves. The concept of wearing gloves was not there. So only with the scalpel and with our hands, we used to do the anatomy. But just imagine now, can you imagine touching anything without a glove? So that's how things have evolved. And so we have to also see that we adapt the new education systems. There are several challenges in adopting simulation. Background of learners in India is different from the West, where role-playing and problem-based learning is introduced right from the formative years, and students make a natural transition to learning on simulators. This is not the case among Indian students, who still tend to differentiate the real and unreal. But now this gap has been met. Our students are able to do it much more easier, and they are very competent. And we know that simulation-based education will add to that competency. But only issue with the simulation lab, they're very expensive. But a lot of medical colleges, even the public and private medical colleges, are actually investing in these simulation labs. So simulation looks like a solution to the current challenges in the medical training. They offer educators the opportunity to teach, test, and prepare for challenges in clinical practice. It allows the trainees to learn new techniques without harming the patients. So it's now very widely accepted and a valuable tool in training in obstetrics. When you look at the obstetric triage simulation protocol, the OTAS, the obstetric triage acuity scale, is the first obstetric triage scale with established reliability and validity. It enables the standardization assessment of acuity within and across the institution. A registered nurse with additional education can perform the triage in assessment room, urgent care centers, and following the OTAS. This is what is happening in the NHS system. So here we have got enough of our doctors who are able to manage the triage in our ERs. So you can use your paramedical staff to help you to triage women and based on the women's gestational age. We have the early pregnancy scale, then pregnancy more than 20 weeks. So if you follow this triage for early pregnancy, more than 20 weeks, and it becomes easy where you can train. Now, training and mentoring of paramedical OB/GYN support staff is very, very vital. The shortage of trained human resources, especially doctors and ANMs, remains a key challenge to improving the maternal health outcomes. Compensation packages for personnel working in remote and rural areas need to be made more attractive. The simulation triage for OB/GYN is the way forward. And we have seen it has actually come into practice in Foxy. Now we have seen how in COVID that we have moved from the real time to the virtual means of training. We have seen the Safe Motherhood Committee, our own chairperson, Dr. Preeti Kumar, has done a wonderful job. This Jeevan Dhara, which is a virtual workshop of life-saving skills of the management of PPH in state of UP, Jharkhand and Bihar. This supported by the MGM, MS, UNICEF and Pathfinder, so many. So they targeted and they were able to train so many paramedical staff. So this shows how you can use the simulation and all this virtual medium to reach out to your paramedical staff. So Foxy has been able to do this wonderful work. And when you look at the code blue, the quick response team, we find that it's remarkable in equipping staff for emergencies. So we have to look at the holistic advantages of simulation training. It helps integrate theory and practical, no risk involved, control environment, real life experience obtained, increased level of motivation towards learning a skill, simulation, self-criticism, which helps towards the high level of skill acquisition. But there are some disadvantages also because it requires a lot of preparation, high level software, time consuming, expensive, and sometimes, everything cannot be reproduced by simulator. So we have to use the power of technology. We have got now the artificial intelligence. Artificial intelligence is the way forward for the simulation labs and training in modern day medicine. So this definitely shows that simulation training in OB/GYN has come to stay to make knowledge and skill attitude easier for our generation next to take care of the patient clinical care using technology. So we have to understand that we have to use the technology to allow learners to acquire skill. Anshu was telling that I was not very good in internet and all. Anshu, even I also agree. I was also not tech savvy, but today I never used to make my presentation. I used to have all my people, but now COVID and all this has made me, now I can add slides, make a presentation, delete slides. So I think that is what is simulation. That is what is technology, which can make a difference. So the way forward is trying to inculcate what is there, and definitely the specialty boards and all the organizations, we recognize simulation as an innovative approach, and new technology will make OB/GYN training and practice much safer. And we look forward to having the next generation of doctors who are very competent, because they are the people who are going to take care of us. So we have to now find out ways and means of teaching our generation next in the best way to make them very competent. So thank you, friends. Let's hope that we'll be able to train our generation next in the best possible way.
Madhu? Okay. Yes. Thank you very much, Shanta, for your such a elaborate description of simulation situations. We all know that our obstetrics and gynec is a combination of medical disorders and learning skills. And simulation is really a very valuable tool that increases knowledge and skill in obstetrics and gynec. And we all know that actually it was created in 1920 for training the flight things to the persons, because they were not able to reproduce it practically, and that is why actually we started simulation. But then we realized that this is because we have got so many skills in obstetrics, like you can have a forceps application, ventouse, breech delivery, shoulder presentation, PPA, management of PPH, as just now Shanta said, that Jeevan Dhara, they are doing so well to train the persons. And with simulation workshop, it is much easier. But everything, whichever you do new, has got its advantages and disadvantages. But you have to weigh. But certainly in obstetrics and gynecology, there are few surgical skills which you cannot reproduce like this. Until you reproduce a things live in live, then only a person can understand when you put her with a patient in live situations. And so simulation workshop in present day obstetrics as well as in our present era are very, very important. And we know that total teaching in a classroom and from the book does not suffice. She has really explained everything very nicely about even this OTAS, that triage. This is very important. If we train the health workers and everyone, then certainly we will benefit not only the doctors, not only the students, but the society as a whole. Thank you very much, Shanta. I really appreciate you said that this is not a topic to my heart, but I say you have dealt with this topic wonderfully well, and you have taken, I think you have not left anything untouched. The things which are advantageous with simulation training or things which are the disadvantages. So we have to weigh, then only you can decide which way you will like to teach the students. Thank you very much, Shanta, for your wonderful oration. And on behalf of Obstetric Gynec Society, I really congratulate you and thank you for such an excellent oration. And I will also like to thank the Noida Society for giving me this opportunity to chair such a prestigious session of oration by Dr. Shanta Kumari. Thank you all very much. We are greatly benefited by your experience, my dear Shanta, I can say. Thank you very much.
Thank you, madam.
Ma'am, can we hear from Dr. Madhu, ma'am?
Yes, yes.
Madhu, ma'am. Yes.
Thank you, Dr. Shanta Kumari, for giving such a wonderful and such an excellent talk about simulation. In fact, this is the time of technology, and I think we all need to benefit, and I'm very sure the future generation will definitely benefit from simulation. In fact, I went to Mayo Clinic long time back, and they had a full block of simulation. That time I didn't understand, and they said the students have to train themselves 3 months before they are really go out in the practice. They cannot be graduated without that. I think that is wonderful thing. Really, we are getting it here, and I'm very sure this simulation will help us, will help all the budding, students coming into the practice. Thank you very much for that.
Thank you, madam. Even I agree. See, even I used to think 15 years back when I also first was in the simulation lab, I thought it is, what is all this? We will learn better with the patients and all. So also, actually, let me tell you, when I went to Manipal for the first time, I was from Hyderabad, from Gandhi Medical College, where in the OP we used to have 150, 200-300 patients falling on you. So in the Manipal, in the OPD, we had the first day, we had about 60 patients. I was very disappointed. The first day and the next day, we had about 100 OPD. Here used to be hundreds and thousands used to fall. Then I was wondering, how will I become a good doctor? That day, Professor Pratap and Professor Murli sir told, you need to look at each and every case in detail. And the way you look at it, how you get trained will make a difference. It was absolutely, I realized it was the quality training, which we were very lucky to get, which made a difference. It was like a live simulation. We had wonderful, and the day I stepped out of Manipal as a consultant, I was able to operate cesarean and hysterectomy by myself. So I think that is also important, and nowadays we find things are so different, madam.
I think the surgical training is really helped by simulations to these students, because we took very long time to get the confidence of surgeries. Our training was very long, but I think by simulation, they can get better training done by simulation, and they can have a better practice. Thank you very much again. Thank you.
And in endoscopy, from the very beginning, we have got simulation training, because there are only pelvic trainers by which we train them, and that really create a real life surgery as they are doing. So simulation is really a very, very valuable tool, I would say.
Thank you. Thank you very much, Usha ma'am and Madhu ma'am, for your valuable inputs. And Shanta ma'am, we are just mesmerized and inspired by your talk. And thank you very much, ma'am.
As always.
Thank you, ma'am.
Thank you, Dr. Sujata, but for inviting me. And okay, I'll take leave. I'm actually outside Hyderabad.
Thank you so much, ma'am. Thank you so much for your valuable time. And I must say the ma'am was traveling today, and even after all the everything, ma'am came and joined us. It's our pleasure, ma'am. It's an honor thing. So thank you so much, ma'am. You always said, and whatever you said, it always done. Thank you so much.
I always say, may God bless her with enough strength so that she can do so much of work. She can run here and there. May God bless you, good health always.
She is the iron lady.
Yes.
Of words.
Day and night.
Yes, yes, true.
Thank you, ma'am.
Thank you, ma'am. Now, Anshu, I request Dr. Anshu to move on to the second session. Yes, thank you, Dr. Aradhana. Now, I would like to start our next with our two keynotes. And the first keynote will be done later because of some technical glitch. Dr. Pai is not able to connect. So we are starting with our second keynote. And for this, I would like to invite our chairperson. So for this, our chairperson is our Foxy Secretary General, Dr. Madhuri Patel, ma'am. And everybody knows ma'am very well. And the introduction is just innumerable. So ma'am is a former committee member of FIGO. And at present, the first lady Secretary General of Foxy. And this is more than the enough of and the things that everything you all know needs no introduction at all. Welcome, ma'am. Our second chairperson is our own Muralidhar Pai sir is joined. I think he's.
I'm not sure. I'm trying to get him on the phone, but I'm not sure whether he has logged in.
Introduce him.
So our next chairperson is Dr. Muralidhar Pai. Sir is a professor and HOD KMC Manipal and at present a Dean Sikkim Manipal Medical College.
Actually, Dr. Muralidhar Pai was very keen to be on the session because he is, I think, a close friend of Dr. Selva. Anyway, I'm trying to get to him to log in as soon as possible. Yes, Anshu, please carry on.
Next slide, please. And our next chairperson is our own dynamic, energetic, and ever smiling and ever helping endocrinology committee chairperson, Dr. Rakhi Singh. And there's no words to explain her, especially by the Noida Obs and Gynae Society members, what she did for the Noida Obs and Gynae Society. That is the things itself represent from where and at what level the Noida Society is gone. So welcome, ma'am, for the today's keynote.
Thank you, Anshu.
So now I will request our chairperson, please start the session with the keynote second by our international speaker, Dr. Selva Priya. Welcome, sir.
Thank you, Dr. Anshu, for your kind and generous word. And I must congratulate Noida OBGY Society for having excellent, annual program. So respected all the dignitaries, especially Usha Madam, Usha Sharma Madam, Dr. Jayam Khan, and all the senior people, respected all of you, my seniors and juniors. Very good evening to all of you. At the outset, on behalf of my co-chairperson, Dr. Muralidhar Pai and Dr. Rakhi Singh and myself would like to thank Noida OBGY Society, especially Dr. Sujata Bhatt, Dr. Anshu, Dr. Rakhi, Dr. Rashmi, and entire Noida OBGY Society for inviting us to chair the session. As all of you
last time भी मैंने बोला था कि please ना don't rely on the Fortis का Wi-Fi. We in Lilavatipuर डाला ही है हमने.
Kindly mute Dr. Pai, please.
Yeah. We all of us are aware that fibroid affects 35 to 77% of the women of the reproductive age group. However, the real prevalence is very high because many of them are asymptomatic. Apart from menstrual symptoms, pressure symptoms, we have of women which fertility is affected, and they are about 5 to 10%, and only sole, fibroid causing infertility is about 2 to 4%. So it can obstruct the fallopian tube, it can, modify or unreceptive endometrium, etc., and gives rise to very low fertility rate for IVF also. So for this, we have renowned, our renowned international speaker and experienced speaker, Dr. S. Selva, who is going to talk on intramural fibroid and fertility to operate or not to operate. I welcome Dr. S. Selva, and before he starts his talk, I would like to introduce him. He's a consultant obstetrician and gynecologist, specialist in reproductive medicine, and heads the IVF Center at Mahkota Medical Center in Malacca, Malaysia. He is a fellow of RCOG and has obtained his master's in reproductive medicine from the University of Western Sydney in 2003. He is a past president of OBGY Society of Malaysia, past president and a board member of Asia Pacific Association of Gynaecological Endoscopy. Dr. Selva is a dedicated laparoscopic surgeon, and till now he has performed about more than 8,000 cases. He also runs a fellowship in minimally invasive surgery and infertility at Mahkota Medical Center. He has published his first book on laparoscopic surgery in gynecology and common diseases in women. He has numerous publications in the international journals. He also runs a blog entitled Surviving Private Practice in Malaysia. He has just started the ultrasound-based HIFU Center at Mahkota Medical Center for non-invasive treatment of the fibroid uterus. So we have very dedicated, Dr. OBGY, and he's always concerned with the women's health. So with this, I invite Dr. Selva for his talk on intramural fibroid and fertility to operate or not to operate.
Thank you very much.
Yes.
Thank you very much. Can you hear me?
Yes, we can hear you.
I will share the screen now.
Sure.
Yes, and I think Dr. Murli also is logging in. So he will be there. He can give us...
Okay. Dr. Murli is a good friend of mine. He used to work in the same town that I am working in, which is in Malacca, Malaysia, where the Manipal Medical College is in Malaysia. So my topic is intramural fibroid and fertility, to operate or not. And I thank the society for inviting me, and also for Dr. Pratap, a good friend of mine, for introducing me to the society. So we all know that fibroid is the most common monoclonal tumor in women, and it is in infertility. About 2 to 3% of women, the sole cause is fibroids. Current literature calls for removal of submucous fibroid and possibly cavity distorting intramural fibroids to optimize pregnancy outcome. Sorry. However, removal of non-cavity distorting intramural fibroid is controversial. So what I'm going to talk today on is this small fibroid, say 3 to 4 centimeter fibroids, that is sitting in the center of the uterus without distorting the endometrial cavity. It is neither subserous nor submucous, and it is completely intramural. And does this kind of fibroids causes infertility? And if it does cause infertility, should we remove it? And that is my topic today. Now, this is based on a paper that I published recently, and that you can get this paper for free on the internet on the same topic. So my topic will be outlined will be as such. First, what are the classifications of fibroids? What is the pathophysiology that causes subfertility in patients with intramural non-cavity distorting fibroids? Does intramural fibroids causes infertility? Does myomectomy improve pregnancy rates? Are there alternatives to myomectomy in these patients? So this is the outline of my talk. Now, firstly, what are fibroids? Now, we know fibroids, they are the traditional classification is submucous, subserosal, intramural, and cervical fibroids. And there is, of course, this FIGO classification, which all of us know. We know that type 0 and type 1 are the subserous, submucous fibroids, and everybody know that these have to be removed if you want a person to get pregnant. The 7, 6, and 5 are subserous fibroids. We all know that this is something that we can leave alone. There's no problem. It doesn't cause infertility. Type 2 fibroids is also partly subserous and partly intramural. This also have to be removed. There's another type of fibroids which are 2 to 5. These probably need to be removed as well. So my concern is these two types of fibroids, type 3 and type 4, especially type 4 fibroids. These are fibroids that actually does not touch the endometrial cavity. These fibroids touch the endometrial cavity, so these might need to be removed, but should we remove small fibroids that are type 4? That is my discussion today. And here is an example of a patient with a subserous fibroid that underwent IVF and pregnant, and we all are aware that this can happen all the time. So my first part is to look at pathophysiology. Now, when we look at pathophysiology of why intramural fibroids cause infertility, there are basically 5 reasons. And these are the 5 reasons: implantation, junctional zone, uterine myometrial peristalsis, fibroid pseudocapsules, and steroid hormones. And I will go through this one by one. Firstly, let's look at implantation. And we all know that implantation is a very complex process. There are many factors that are involved, such as HOXA10, glycodyline, leukemia inhibitory factor, glutathione peroxidase 3. These are some of the factors. And we know that HOXA10 is responsible for cellular differentiation, while glycodyline is responsible for promoting angiogenesis, suppressing natural killer cells, and inhibiting the binding of spermatozoa to zona pellucida. And normally, both these factors are reduced during the follicular phase and increased during the implantation. However, we know that in patients with intramural fibroid, both HOXA10 and glycodyline are reduced during implantation. So this may be a factor, but we do not have any way of improving this. So we can just talk about it, but up to now, we don't have anything to do about this problem. Next, let's look at the junctional zone. We all know that this is the junctional. There's a zone just outside the endometrial cavity, and that is called the junctional zone, and there is something called uterine peristalsis at the junctional zone. And disruption of the junctional zone by fibrosis may lead to increased peristalsis. And thickening of the junctional zone caused by intramural fibroids leads to poor reproductive outcome. Now, NK cells were reduced and macrophages increases in the endometrium closer to the fibroid compared to other areas. So if you have an intramural fibroid, and if this endometrial fibroid especially touches the junctional zone, then there is a very high chance that that fibroid is going to cause a reproductive problem. So because of this, I have personally in this paper classified type 4 fibroids into 2 types, 4A and 4B. 4A are the fibroids that actually touches the junctional zone, and 4B does not. So these fibroids, 4A, probably will cause more disruption and more problems with reproduction compared to 4B. Now let's look at myometrial peristalsis. There are actually 2 types of uterine contraction. The first is called the focal and sporadic bulging of the myometrium. This is not an important problem, but what we call as the uterine peristalsis, which is the rhythmic, subtle stripping movement in the subendometrial myometrium, and that is called uterine peristalsis. And this is a big problem, and this is the one that causes subfertility. And uterine peristalsis is captured by CME MRI. Now, CME MRI is a procedure whereby we do sequential MRIs and look for peristalsis, and this is a laborious process, and it's also an expensive technique to look for uterine peristalsis. Now, from menstruation to mid-ovulatory phase of the menstrual cycle, the uterus contracts from the cervix to the fundus with increasing frequency. This is probably the fact that the sperms can move up the cervix into the endometrium and into the fallopian tube. Post-ovulation, this contraction frequency decreases into a relatively quiet, especially during implantation. And in the luteal phase, the direction of the peristalsis is reversed. So uterine peristalsis is in patients with intramural and submucous fibroid during mid-luteal phase and decrease during the peri-ovulatory phase. Now, in this study by Yoshino, entitled Decreased Pregnancy Rates is Linked to Abnormal Uterine Peristalsis Caused by Intramural Fibroid, he did a very interesting study. What he did is that he took 95 infertile patients with uterine fibroid and examined under magnetic resonance imaging. The inclusion criteria was that presence of intramural fibroid, and he excluded submucous fibroid. There's no other significant infertility factors such as endometriosis. The patient had regular menstrual cycles, and he performed MRI in all of them at the time of implantation. That is the luteal phase, day 5 to day 9. And he measured the frequency of the junctional zone movement known as uterine peristalsis using cine mode MRI. And after the MRI, the patient underwent infertility treatment for up to 4 months. And he didn't do IVF, just normal infertility treatment up to a level of IUI. And then he evaluated them. So out of this 95 patients, 51 patients fulfilled the inclusion criteria, out of which 29 patients were assigned to low frequency, that is 0 or 1 per 3 minutes. And 22 patients had high frequency, that is more than 2 times in 3 minutes, uterine peristalsis group. And he found that out of this 29 patients with low frequency, 10 patients got pregnant, a pregnancy rate of 34% in the low frequency group. Whereas in the 22 patients, none of them got pregnant. So and from that, he concluded that if there is a high frequency of peristalsis during the mid-luteal phase, this might be one of the factors causing infertility in patients with intramural fibroids. Now, next, let's look at fibroid pseudocapsule. Now, we all know what is a fibroid pseudocapsule. This is a capsule that surrounds the fibroid. It contains smooth muscle cells and neurotransmitters. It is highly vascular. It's upregulated by endogolin and CD34. The pseudocapsule thickness varies with the type and location of fibroid. It is thickest in the submucous fibroid compared to intramural fibroid, compared to subserous fibroid. Now, cervical fibroid has the thickest pseudocapsule. Now, the presence of pseudocapsule with its cytokines, growth factors, and hormones may be responsible for the abnormal uterine peristalsis, which may cause premature deliveries in women with intramural fibroid. Now, neurotransmitters in pseudocapsule is important in promoting inflammation and proper wound healing. Now, so pseudocapsules has got a function. So when we are doing surgery, we have to do it intracapsular myomectomy and do not excise the pseudocapsule too much because it will reduce intraoperative blood loss and better wound uterine healing and correct muscular anatomical restoration to preserve the uterine functionality of the reproductive purposes. So this is just a warning that when we do surgery, we need to be within the pseudocapsule. But the pseudocapsule may be one of the reasons for causing the uterine peristalsis, leading to difficulty in pregnancy for patients with intramural fibroid. Now let's go on to steroid hormones. Now we all know that fibroid tissues contains high concentration of aromatase, estrogen receptor alpha and beta, progesterone receptors compared to the surrounding healthy myometrium. Now fibroid is also known to be estrogen dependent. Now, studies by Ishikawa has shown that actually both estrogen and progesterone are responsible for growth of fibroid. And he actually did a study to show that if you give only estrogen, the fibroid doesn't grow. If you give only progesterone, it doesn't grow as well. It requires both estrogen and progesterone for fibroid to grow. So high estrogen level stimulates the junctional zone and induces rapid uterine contraction, and progesterone antagonizes its effects and suppresses uterine contractility. We all know this because we all IVF specialists give progesterone during the luteal phase to suppress uterine motility, and this is the explanation for it. So now that you all have an idea of what are the pathophysiology of how intramural fibroid causes subfertility, the next question to ask is, does intramural non-cavity distorting fibroids actually causes infertility? Now, the literature is actually divided. You have there are many papers that says that yes, intramural fibroids reduces fertility outcome. And there are similarly, there are papers that says that it doesn't, the fertility outcome is same whether there is intramural fibroids or not. So when this happens, we look at review articles. Now, this is one review article published in 2010 by Sunkara, and the name of the topic is that the effect of intramural fibroids without uterine cavity involvement on the outcome of IVF treatment, a systematic review and meta-analysis. And in this study, she concluded that the presence of non-cavity distorting fibroids is associated with adverse pregnancy outcome in women undergoing IVF treatment. And this is another review article, and this article is more recent. It's entitled "The Impact of Non-Cavity Distorting Intramural Fibroids on the Efficacy of In Vitro Fertilization Embryo Transfer, an Updated Meta-Analysis." Now, in this analysis, in this paper, they concluded that the present evidence suggests that non-cavity distorting intramural fibroids would significantly reduce implantation rate, clinical pregnancy rate, live birth rate, and significantly increase miscarriage rate after IVF treatment, but it would not significantly increase ectopic pregnancy rates. So the next question to ask is, now we know that probably presence of small intramural fibroids affect fertility. The question to ask is, does myomectomy improve the pregnancy rates? Again, the literature is divided. You have one group that says, yes, myomectomy improves pregnancy rate. Another group says, no, you don't have to do myomectomy for such patients. So I have looked at the same paper by this gentleman that I introduced to you all, Mr. Yoshino. Now, in his paper, he said that myomectomy decreases abnormal uterine peristalsis and increases pregnancy rate. So what he did is that, remember the cases that he had that have high uterine peristalsis and did not have any pregnancy. So he took 15 of them and he did a myomectomy on them. And then after the myomectomy, he did a second MRI. And he found that those patients who we did the myomectomy and have a decrease in the uterine peristalsis, 6 out of the 15 patients actually achieved the pregnancy. So he concluded that the presence of uterine fibroids might induce abnormal uterine peristalsis, leading to infertility, and myomectomy may improve fertility in these patients. So what have we concluded so far? Now, I have told you all that probably intramural fibroids decreases pregnancy rates. When intramural fibroids causes increased uterine peristalsis, the pregnancy rates decreases. So if we can know which patients have an increased uterine peristalsis, then we know that these patients will have a decreased pregnancy rate. However, however, we are unsure that myomectomy in these patients will improve pregnancy rates. If there is an increase in uterine peristalsis in these patients with intramural fibroid, the chances that myomectomy may improve pregnancy rates. However, measuring uterine peristalsis using cine MRI is difficult and expensive. And so what we know is that when there is intramural fibroid, and if this intramural fibroid is causing increased uterine peristalsis, it will cause decrease in pregnancy rate. If it doesn't, we don't know whether it causes a decrease in pregnancy rate. So now the question is, can we have alternative methods of shrinking the fibroid without doing myomectomy? Because to do a myomectomy on a small fibroid seems like a big procedure. So I had a look at all the other methods that are available, non-surgical methods that are available besides myomectomy, to see whether these could help patients with such fibroids. And there are 5 methods, and I will go through these 5 methods one at a time. Now, we all know about ulipristal acetate. I don't know whether it's still available in India, but in Malaysia, it has been withdrawn. It is a selective progesterone receptor modulator. Advantage over myomectomy is that the patient can conceive immediately after treatment. And there are some case reports that showed that in type 2 to type 3 fibroids, it does help, but we are not sure whether it will work on type 4 fibroids. So somebody must do some studies to see whether we could shrink small fibroids using ulipristal acetate and the patient can conceive. In fact, one of the papers is by Ashish Kale. I think you all know him. He's from Pune, and this is his paper. And he actually looked at ulipristal acetate and IVF outcome. He had 2 case reports which he published. Now, the next is actually GnRH agonist. Now, if we could use GnRH agonist, so we know what is GnRH agonist. It binds to the GnRH receptor, causing desensitization and ultimately reducing estrogen and progesterone, causing reduction in fibroid growth. GnRH agonist also acts on the GnRH receptors expressed by the fibroid to reduce cellular proliferation. So during this process, water will diffuse out of the fibroid cells, causing shrinkage of the fibroid. Since there is a lack of studies to determine the effect of GnRH on infertility, we postulate that the significant reduction of fibroid volume with GnRH analog may reduce the impact of cavity encroaching fibroid and subsequently improve implantation. So there is actually no studies to show that in small fibroids, if we could shrink it with GnRH analog, the patient can conceive. Kessel and et al. Have done a study, but this study is actually for bigger fibroids, and he actually managed to get pregnancy in these patients. So in 3 out of 5 infertile patients with fibroid, he successfully conceived. 2 of them conceived even without surgical intervention. So we can look at this as one of the alternative methods. The next is etosiban. And you all know etosiban is actually a combined oxytocin and vasopressin receptor antagonist. As an oxytocin receptor antagonist, etosiban competes with oxytocin at the oxytocin receptor in the endometrial cells to decrease endometrial contraction and prevent embryo expulsion during the implantation phase. By reducing the oxytocin effect, it will inhibit oxytocin-induced prostaglandin production and increase endometrial blood supply. As vasopressin antagonist, etosiban relaxes uterine arteries and decreases systolic blood pressure to improve blood perfusion to the endometrium and myometrium. However, the antagonistic effect of oxytocin and vasopressin receptor improve uterine receptivity and embryo implantation. But all studies so far has been done for only repeated implantation failure. In fact, the company actually proposed it for repeated implantation failure. Perhaps we could use this for patients with intramural fibroid to see whether this would, because we can't measure uterine peristalsis. So if the patient could not conceive, say with IVF, we could give etosiban at the time of embryo transfer to see whether the patient can achieve a pregnancy. So this is another alternative method. Now, the next is uterine artery embolization. Now, we know uterine artery embolization believed to affect embryonic implantation and difficulty in maintaining gestation, leading to increased miscarriages. The risk of amenorrhea and ovarian failure after UAE in young women is low. However, there's a worry of poor oocyte quality, poor response to ovarian stimulation in patients who have undergone UAE. Several cases of intrauterine adhesions, endometrial atrophy, and fistula between the uterine cavity and the embolized myoma post-UAE has been described in the literature. In one study, more than 1/3 of patients were found to have intracavity tissue necrosis 3 to 9 months post-UAE. American College of Obstetrics and Gynaecology and the Society of Interventional Radiology and the RCOG have placed UAE as a relative contraindication for women desiring future fertility. Now, we all know about UAE, and UAE is usually done for people who do not want to get pregnant, but it may not be as bad as what it shows. So this may be one of the situations that we may want to try in patients who are repeated miscarriages with small intramural pyra, but many of us will not be daring enough to put the patient for uterine artery embolization. Now, let's look at high-intensity focused ultrasound. Now, high-intensity focused ultrasound, or HIFU, is an organ-sparing, non-invasive thermal ablative procedure. It uses extracorporeal transducer to focus a big intensity ultrasonic beam to the targeted myoma to thermally ablate tumors without introducing needles or probes into the tumor. There are two types of HIFUs, the MRI-based HIFU and the ultrasound-based HIFU. There is minimal damage to the surrounding normal myometrium without obvious damage to the elastic and collagen fibers in the normal uterine muscle, resulting in less scar tissue formation and less risk of collagen fiber hypoplasia. Theoretically, this would reduce the pregnancy risk in women who have undergone HIFU treatment for uterine fibroids as compared to myomectomy. Now, clinical studies also confirm that HIFU avoids ovarian function impairment, adverse reaction, thus preserve the ability to conceive. Studies have shown that pregnancy rate loss post-HIFU is 95.4%, which is slightly higher than post-myomectomy, which is 64.6 times 88.6%. Also, the spontaneous abortion rate post-HIFU is 14.9%, similar to post-myomectomy, which is 13 to 24%. This rate is still significantly lower in pregnancy with untreated fibroids. So this may be one of the options that we have to use actually high-intensity focused ultrasound to shrink these small fibroids and hopefully helping this patient to get a pregnancy. And because of this, I have actually brought high-intensity focused ultrasound into my center, and we are going to do research in this area to see whether we could help women who have small fibroids and still not getting pregnant to ablate these small fibroids, and then hopefully will help these patients to achieve a pregnancy. So in summary, there is enough evidence that non-cavity distorting intramural fibroids affect fertility. Type 3 may have a higher risk of poor pregnancy outcome compared to type 4 fibroids. I showed you all just now that type 3 actually touches the endometrial cavity and type 4 does not. But even type 4, we have the two types, type 4A and type 4B. Type 4A touches the junctional zone. That may be even more detrimental than type 4B. There are many possible causes why intramural fibroid affect fertility, but the only measurable cause appears to be increased uterine peristalsis. Unfortunately, not all patients with intramural fibroids have increased uterine peristalsis. Currently, there's no good, inexpensive method of measuring uterine peristalsis. CME MRI seems to be an accurate method, but it is expensive. Transvaginal ultrasound method is cheaper modality, but it is still very user dependent. I frequently use this to look for uterine peristalsis, but it's not very easy. We can see the peristalsis, but to measure them is quite difficult. A better method needs to be devised to measure uterine peristalsis easily and effectively. Now, with vitrification, pregnancy after frozen embryo transfer is improving. Now, myomectomy should not be the first-line treatment for patients with small intramural fibroids. I think all of you all agree that if we can't be cutting up a patient myomectomy just to remove small intramural fibroids. In patients with many frozen embryos, the strategy could be to consider surgical or non-surgical intervention only in patients who have failed embryo transfer. So if you have transferred embryo and you keep failing, then that fibroid may be a problem. And as I said earlier, myomectomy may appear to be a big procedure to perform in patients with this kind of small intramural fibroids. So for all the non-surgical methods that I described above, which include ulipristal acetate, GnRH, uterine artery embolization, HIFU appears to be the most attractive option to shrink this small intramural fibroid because it is non-invasive technique with very few side effects. But however, this needs to be explored in further clinical studies, and this is the area that I'm going to go into research. Thank you.
Good evening, Dr. Selva. It's Murlidhar Pai here.
Hi, Murli. How are you?
Fine, thank you. Meeting you after 14 long years.
Yes, yes.
Through this webinar. I'm sorry I had a glitch in logging in before you started. And also you had to start a little bit prematurely.
Yes, yes, I have to start a bit earlier. I'm trying to stop share. Have I stopped sharing already? Or am I still sharing?
I think you are still sharing.
Okay, now let me see. How
nice
do I,
to see
how
this
do I-
Makata.
Yes, I
Makata
stopped.
Yeah.
Yeah, you are familiar with my city.
Yeah, your city, your place.
When did you leave? When did you leave Malacca? That must have been 15 years ago, I think, isn't it?
Yeah, that's what. 2017, I left, and then I went to Manipal back, and I was there for nearly 14 years. Now I've come to Sikkim.
Yes,
That
I
is
know. I've been following you.
Yeah, northeast of India. It was an excellent talk because all of us know about the effect of the submucous fibroids coming in the way of fertility. But intramural fibroids, you really beautifully told us the reason why there can be infertility, mainly due to peristalsis. But again, as you said, it's very difficult to prove that hypothesis because we know that lots of many women, they conceive with the intramural fibroids. That's why the chapter of fibroids complicating pregnancy is there in the obstetrics textbook still. But have you used Otosiban as one of the injections or methods during a transfer, embryo transfer, to quieten the uterus?
Yes, I have used it for repeated implantation failures. So we don't know what is the cause. There's repeated implantation failures. We have used Etosiban. It is still a controversial area. I'm just postulating whether that is something we can even bring to patients with intramural fibroids. That's my thoughts. But I have not used that in patients with intramural fibroid having reproductive problem.
Yeah. So it's very clear that you are very clear that a submucous fibroid coming in the way of implantation should be tackled. Is that?
Yeah. That is very clear. I think nobody will disagree with that.
Yeah.
Nobody will disagree.
Yeah. So that's why my next question is, when it comes to intramural fibroid, because as far as the submucous fibroid is concerned, we specify a fibroid more than 4 to 5 centimeters. It is in the posterior wall coming in the implantation site. So do you have any specific site and size of the intramural fibroid that has to be removed?
The studies have shown that even fibroids of 2.5 centimeters, if it is intramural, can affect fertility. But all of us are gynecologists. We have many thousands of patients with this kind of small fibroids, and they get pregnant on their own or even by IVF. So my question is always, in those patients who did not get pregnant, what I'm trying to say is, even if the fibroid is small, it might be the cause of them not getting pregnant.
Exactly. I can refer this back to nearly maybe 35 or 40 years ago. When I was an undergraduate student, Professor Kaulgood, he always believed that in an infertile patient, fibroid has to be removed, not otherwise. So, so I don't know, maybe now we are able to explain why it is to be removed. And you are saying that even as small as 2.5 centimeters and anywhere in the uterus?
Sub-serous fibroids, you can leave it alone.
Okay.
Okay. The question is now only intramural. Sometimes it's sometimes it's very
anterior wall. Anterior.
Yes.
I'm talking about anterior wall and all.
The thickness of the end, the myometrium, is only about probably 2 to 4 centimeters.
Yes.
So if you have a 3 centimeter fibroid, it has to somehow affect the uterine cavity in some way, you see. So that is the peculiar thing. When you may be able to have an enlarged or thickened myometrium, and then you can have a fibroid sitting in the center. And whether that is the one causing it is always a big question. I'm sure all of you all will have that problem of this patient with this fibroid and not getting pregnant, whether to go in and take it out or not. What I'm trying to say is, we may look for alternative methods. You can try alternative methods rather than going and taking it out. That's the whole.
So with regard to alternative methods, there is one question in the chat box by Dr. Ekta Singh. She's asking, because you have talked about ulipristal, which is now controversial. At least you said in Malaysia it's not available. In India it is in and out. And you talked about GnRH and all that. Doctor is asking about mifepristone 25 mg. Your experience?
No, mifepristone is actually banned in my country because an abortifacient drug. So we don't have mifepristone. So I've got no experience about it. I am not sure whether
we were actually prescribing that. Dr. Pratap also, you know Dr. Pratap very well.
Yes.
We have been prescribing this Fibro Ease is the actually trade name. I should not use that. But anyway, it is being used again for a few months only. But as we know, whatever you do, the maximum effect of that is it will shrink the size of the fibroid. Maybe best results are 50% only, whether you use HIFU, whether you use GnRH analogs or any other thing. So you cannot totally get rid of the fibroid by these methods. So totally getting it rid of is only by surgery. And of course, you said UAE is not at all advisable because it will come in the way of even other, supply, the ovarian blood supply and everything. So mifepristone is also out in Malaysia.
Yes.
I have that much only. Any other chairpersons would like to contribute? Dr. Madhuri Patil, I saw.
Yeah, Dr. Muralidhar, thank you very much. And Dr. Selva, it was an excellent, talk. We have understood, because every time the patient comes with the infertility problem, as soon as we see the intramural fibroid asymptomatic, you want to remove it. He explained so well about the pathophysiology as well as which fibroid should be removed. And he said the primary aim is not to do the myomectomy. Primary aim is to shrink the fibroid, see whether they are responding or not. If they don't respond, then you go ahead with myomectomy. So these are the very, very practical points he has mentioned about it. And I think it will be very, very useful for all the delegates who were logged in. And definitely everybody, whether it's the IVF specialist or the general gynecologist, everybody comes across such patient, and we can refer. I'm a general gynecologist. I only refer if my patient do not conceive. So it will be very, very, tips to all the gynecologists to how to treat this intramural fibroid. Thank you very much. And Dr. Rakhi, over to you.
Thank you, Dr. Selvaraj, Dr. Muralidhar Pai, and Dr. Madhuri ma'am for giving us the chance. And Dr. Selvaraj, you've explained academically, rich talk of yours has explained in depth about the use of all the other modalities for shrinking the size of the fibroid and the management of the fibroid for the better implantation. I don't want to take much time, and then it was very well taken up by Dr. Muralidhar Pai and summarized by Dr. Madhuri ma'am also. Thank you for being there for Noida Societies.
Once again, I'm sorry for the glitch in the logging in.
No, sir, it's okay.
That's okay. There, sir. Yeah, sir, you did not miss much, everything was fine. You miss only introduction, for which you don't require introduction because you know him personally.
You were very well there.
Another point is I have to suppose to start at 7:30, but I was asked to start earlier. So it's not your fault, actually. It's our fault.
No. I would always log in 15-20 minutes early, but there was a glitch actually.
So, Dr. Selva, I thank you very much for participating in our session and also for coming in a little early in spite of some surgery that you had. Thank you very much.
Thank you. Thank you for inviting me, and hope you all have a good meeting. And nice seeing you, Murali, again.
Thank you. Thank you for being there.
Thank you, Selva sir. And thank you, our all esteemed chairperson, for a wonderful session of the keynote. Thank you so much. Now, I would like to proceed with our second keynote. For this, I would like to call our chairpersons. Slide, please. So for this keynote is our first chairperson is our beloved Dr. Chem Kanan ma'am. Ma'am is a Foxy Adolescent Health Committee 2013-15 Best Committee Award hold and Emeritus Professor of Tamil Nadu MGR Medical University, Managing Trustee of the Garva Raksha Group of Institution, Director of GFC Fertility Center, Trichy and Chennai, Vice President of Foxy 2018. Ma'am, please welcome you, ma'am. Next slide.
Thank you very much for this wonderful opportunity given to me. I think I'm putting Ashok Kumar's slide.
So our next person is Dr. Ashok. There is the present secretary of ICOG 2021, and sir is a obstetrics and gynecologist at Atal Bihari Bajpayee Institute of Medical College and Ram Manohar Lohia Hospital. Welcome, sir. Next slide. Now our own Noida Obstetrics and Gynaecological Society eminent personality is Dr. Uma Sharma ma'am. Ma'am is a HOD and the director of Kailash Hospital Group, Noida, and all that NCR Kailash Hospital. And ma'am is one of a founder member of Noida Obstetrics and Gynaecological Society, and she is our big advisors. Welcome, ma'am. Now I would
start, Anshu.
Yes, ma'am. Now I would like to request our chairpersons to please start the session with our speaker, President-elect Dr. H.D. Pai, sir. Welcome, sir.
Okay. Thanks to Sujata, Anshu. Rishi, I will introduce you. Okay, sure. Rishi is my big brother, and he is known to me for the past 26 years. We have been called Barcelona friends. Myself, Reshma, Rishi, and Nandita. I don't know what nonsenses we have done at Spain, Madrid, in the Madrid by night. From that time onwards, I know Rishi very well. And earlier also, I know Rishi because he is the one who started the infertility work in India as an embryologist. At Pune in 1992-93, he used to carry the ICSI needle in his hand and walk through the conference and tell everybody that ICSI is going to be the order of the day a couple of months after it was detected. From that end, now he has turned into genetics. To that level, he has been working in the last 30 years untiringly. Most human person, most lovely person, and Reshma should be very proud of her husband. And he has held so many posts in Mumbai, India, and outside the country also. And he rightly received so many awards in this country and outside also. And presently, next year, he is the boss of this country, Foxy President. Over to Rishikesh for giving me this opportunity again and again to talk about you, my big brother, with your topic.
Thank you, Jam. I'm really grateful to the Noida Society. There are a lot of friends here. We have I have to actually meet Dr. Mita Saxena, who is also sitting there. I'm very near her in Gurgaon only, but there is some internet issue. So anyway, Dr. Madhuri is there. Dr. Ashok Kumar is our ICOG secretary. Dr. Uma Sharma is there. Dr. Usha Sharma is our doyen. Rakhi Singh, Anshu, and Murlidhar, my friend. You know, a lot of them, all of them are sitting there. So I would like to actually give you a short overview. Can I have the next slide, please? So basically, if you look at fertility preservation, historically it was started by the Ethics Committee guideline of 2005. Then the American Society of Oncology came out with the guidelines in 2006. The word oncofertility was coined by 2006 actually, and then Fertility Protect Group started in 2006 in Germany, Switzerland, and Australia. They were a consortium which was developed for the taking care of the fertility preservation in these three countries. Oncofertility Consortium was started in United States by the National Institute of Health in 2007. Ethics Committee guidelines came in 2013 with the ASRM. And in 2018, there were the revised Ethics Committee guidelines, and 2020 Ethics guidelines of the H3 allowed fertility preservation on clinical basis. Before that, it was experimental, but they offered clinical basis for the guidelines. Can I have the next slide, please? So, if you look at the indications of fertility preservation, we have fertility preservation prior to cancer therapy, breast cancer, hematological cancers like Hodgkin, non-Hodgkin lymphoma, and others. And then we have got fertility preservation in patients with endometrioma prior to surgery, elective fertility preservation for lifestyle purpose, and sometimes we can also do egg pooling in poor responders and patients who fail to get sperm on testicular sperm aspiration. You can do the fertility preservation, who can freeze the oocytes and look for the sperm in the subsequent cycle. I think, can I get the Madam Dr. Jayam? I think you need to mute. Hello.
Tell me, sir, they're saying an issue.
Hello, can you mute?
Yes.
Yeah. So then, basically, if you look at the prior to anti-neoplastic therapy like chemotherapy, radiation, you can do prior to Verheim cystectomy, bilateral oophorectomy. Just 1 week back, I had in 1 week 2 patients with borderline ovarian tumors whom they sent their tissues to us for fertility preservation. Prophylactic oophorectomy in patients with BRCA1 and 2 disease. All these can be used for indication. Next slide. So if you look at the next slide, if you look at the various methods of fertility preservation, the commonest 3 accepted methods are oocyte cryopreservation, ovarian tissue freezing. It is known as ovarian tissue cryopreservation. The short form is OTC, and the oocyte ovarian tissue transplantation, the short form is OTT. So these are the new terminologies, O3C and OTT. And sometimes if you have a patient who is married, you can do embryo freezing. The other 3 techniques of in vitro growth and in vitro maturation, isolation, preservation, and growth of ovarian stem cells, and creation of artificial ovary are all still experimental. Next slide. So if you can see here, on the left-hand side of the screen, we have got the oocyte preservation, mainly done for post-pubertal patients who are undergoing chemotherapy, where there is a delay of at least 2 weeks, which is available to us before chemotherapy starts, and in patients with age-related fertility decline, like more than 35 years who want to freeze up their oocyte, you can take out their oocytes and freeze them. And in those patients where you have the pre-pubertal patient, that is patients who have not yet achieved puberty, or where immediate chemotherapy is required, or chemotherapy is already given in the first cycle, in those patients, you can take out the ovary. You can either do a full ovarian removal, or most of the time, we do a hemi-oophorectomy, because when we want to retransplant the ovarian tissue, we want the ovarian bed. So we leave half the ovary behind. So the retransplantation is done in the ovarian bed. And then later on, when you want to thaw the oocyte, you can thaw the oocyte. You can see on the right-hand side, when the patient has recovered or once she wants to have a child, you can thaw the oocytes, fertilize them with the sperm, create the embryo and transplant it back. Or in patients who are having, you can retransplant the ovarian tissue, and then you can try for either a natural pregnancy, or you can do IVF on the retransplanted ovary. Next slide, please. So what are which strategy? So there are 3 strategies which we can offer the patient. One is oocyte cryopreservation. The second strategy is oocyte cryopreservation with ovarian tissue cryopreservation. So in this patient nowadays, a lot of groups, what are they doing is that as soon as the patient comes to you for consultation, for example, she has got breast cancer and she's going to go for chemotherapy, you immediately next day go in with a laparoscope and do hemiophorectomy and freeze the ovarian cortex. At the same time, one day later, you stimulate her. If suppose you have got 2 weeks more in which you can actually do ovarian stimulation, then you stimulate the patient and recover the oocytes as well. And so you have a combination, and then or you can, if suppose you don't have the window period, suppose the patient says that, no, doctor, I have been told that I should start the chemotherapy in the next 4 days. Then the next day you go in with the laparoscope, do a hemiophorectomy and freeze the ovarian tissue. That's it. So if you look at the risk, so we basically, if suppose she's going for chemotherapy, you look at the risk factor. So the patients can be divided into high risk patients, intermediate risk patients, and low risk patients. So patients who are going to be exposed to cyclophosphamide, chlorambucil, nitrogen mustard, busulfan, procarbazine, thiotepa, melphalan are high risk patients. You should definitely offer them fertility preservation, while methotrexate, 5-fluorouracil, actinomycin, mercaptopurine, vincristine, and bleomycin are low-risk patients, while cisplatinum, carboplatin, and doxorubicin are intermediate risk. So you decide whether she needs the preservation or not. Similarly, in radiation therapy, you can see here that if suppose it depends on how much is the Guy exposure. So if the exposure is more than 2 Guy, then nearly 60% of ovary is lost, and these are the patients you would definitely offer them fertility preservation. Can you have the next slide, please? Next slide. Yeah. So this is as far as the radiation exposure is concerned. Next slide. So if you look at the metastasis, so sometimes suppose you are going to go for ovarian tissue cryopreservation, because when you freeze them, if after 5 years of chemotherapy, you want to put the patient's ovarian tissue back into the ovarian fossa, then you may reimplant if suppose there's micrometastasis in the ovary, you may reimplant the disease. And so we look at the risk of reimplantation. And if patient has got a breast cancer stage 1 and 2, especially infiltrating ductal subtype or squamous cell carcinoma of the cervix, Hodgkin lymphoma, osteogenic carcinoma, Wilms tumor, and non-genital rhabdomyolysis. These are low-risk patients for micrometastasis in the ovary, when high-risk patients like leukemia, neuroblastoma, Burkitt lymphoma, and ovarian carcinoma. So these are very high-risk patients for reimplantation of the ovarian tissue. Next slide. So if you look at this wonderful cartoon, this is the algorithm. So if you look at the patient, if she is less than 40 years and she comes to you for fertility preservation, you ask 4 questions. Is the prognosis favorable? Is future pregnancy compatible with patient's health? Is it high risk of infertility? Is there if you do this procedure? And can fertility preservation be performed with low risk? If the answer is no, then you rather not do fertility preservation. Only if the answer to all these 4 questions is yes, then you can offer them fertility preservation. And based on the time frame available to you and the risk of ovarian metastasis, you offer them a combination of either ovarian cryopreservation or ovarian tissue cryopreservation, or a combination of the two, as I've told you before. Next slide. So when there's another thing I would like to tell you, that normally when we are doing oocyte freezing in a patient who comes to us for elective fertility preservation, that is, say if she comes to us for preserving her fertility for the future, she has not got the right person to get married to, or she wants to postpone her fertility for the time being because her career options are there. In these patients, normally you would start the stimulation on the 2nd day of the period. But if a patient has got cancer and she has to go for cancer treatment, you need to start the stimulation immediately, irrespective of the period date. This is called random start protocol, and the German groups demonstrated in the early phase of fertility preservation that if a patient comes to you anytime and next day you start the stimulation, she will still get enough eggs. And this is a big study that has come from Danis et al.'s group, where this is a systematic review of 19 studies, 7 years, 2000 to 2017, random start of control ovarian stimulation for fertility preservation. was associated with shorter interval between ovarian stimulation and oocyte retrieval, although higher gonadotropin dosage is required, while the yield of mature oocytes and cryopreserved embryos was comparable with conventional stimulation. So random start is now accepted. So irrespective of the time when she comes, you can start the stimulation the next day. And next slide. Next slide. Next slide. Next. 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 So this is the protocol. So if you look at these three diagrams, in the first diagram on the left-hand side of the screen, patient came to me. She had come in the early follicular phase. I did the consultation and I said, okay, we will go for freezing of the oocyte and look at the scan. If the follicle is less than 12 millimeters on the vaginal scan, I can start the gonadotropin stimulation immediately on the same day. After the leading follicle, which is 14 millimeter, I will start the antagonist. I'll also add letrozole 5 milligram daily from day 2 to the day of the stimulation, from the day of the gonadotropin stimulation till the day of the trigger. Because especially in those patients where there is a breast cancer and there is a estrogen receptor positive patient. So in this patient, I will do the stimulation, and after the follicles are ready, I will give the ovarian trigger, and I'll do the aspiration. However, if the next you look at the next diagram, the patient has come in the late follicular phase. She's come on 9th day of the period. You look at you consult her, you say, okay, we'll start you on the ovarian freezing. You look at the scan. If the follicle is more than 14 millimeter on the scan, you wait for 2 days more. Let the follicle become 16 millimeter. You give the ovulation trigger by giving a GnRH agonist and cause of ovulation, and then you start the stimulation, random start. And if suppose she comes in the luteal phase, she's come on the 19th day of the period, you do the consultation, and next 3 days you give her GnRH antagonist. So you suppress the follicles, you synchronize the follicles, and then start the stimulation. So irrespective of the date of the cycle, you start the stimulation. Next slide. Next slide. So this is the short. In short, if you see first day, your patient comes to you, you decide that you want to do ovarian tissue removal. Immediately do the fitness, do the blood collection, do the fitness, and go in with the laparoscope the next day. Remove half the ovary. You can remove half ovary on both sides and cauterize, minimal cauterization of the remaining ovary. And immediately from the second day of the laparoscopy, start her on ovarian stimulation, random start. And after 12 days, when the follicles are ready, you give the final trigger. Normally, the depot is given as a trigger because depot will also protect the ovary from chemo and radiation therapy when the therapy starts. So you give the depot. After 35 to 36 hours, you do the follicle aspiration, and then immediately next day start the chemo or radiation therapy. Next slide. So this is how we do the egg freezing protocol. In next slide. Next slide. Yeah. So egg, go backward. Go back. So egg freezing protocol, ovarian stimulation, egg retrieval. After egg retrieval, we do the dissection of the eggs after 2 to 3 hours. We do the vitrification and we store the oocyte. Next slide. So this is unfortunately we cannot show you the video of this. Next slide. So we do the freezing and then we do the thawing as well. I can't show you the video. Next slide. So next slide. Next. So now this is a very important new addition to our program. This is the artificial intelligence. I have added 3 artificial intelligence tools for my IVF program during the COVID time. I really worked overtime, and because I was sitting at home, so this is what is known as grading eggs with AI toolkit. I've called it grade. So what we can do now is, suppose there are patient is come to you, you have taken out the oocyte, and there are about 10 oocytes. Hello? Yeah. There are 10 oocytes that are there. You find the quality of, so you don't know whether they are enough for giving her a chance of a good pregnancy in the future. I'm not talking about cancer patient. Cancer patient, you have only one attempt. But there are patients who have come to you. She's come to you, she's 32 years old. And she has come to you and said, doctor, I want to freeze my oocyte. I should have enough chance of pregnancy after 10 years. So how many oocytes you should freeze? So normally 10 to 14 oocytes should be frozen. So first attempt only 8 oocytes you get, then you will do one more attempt. But nowadays, this is a new technique that has come. It is an artificial intelligence technique. So after you remove the oocyte, you can dissect them and you can take the photo of the oocyte and you export it to a image analysis server, which has been based on 17,000 images of oocyte. The server looks at the oocyte and then can tell you how much is the chance of this oocyte getting fertilization after you thaw the oocyte 10 years down the line. And it also tells you how much is the percentage of blastocyst formation. So based on this information, suppose she got 8 oocytes, but the great analysis, artificial analysis kit told you only 3 of these oocytes can give a good chance of pregnancy in the future. Then you can counsel her and say, listen, one cycle is not enough. You need one more cycle of preservation. So this is a artificial intelligence kit which can predict how many cycles you need. This is a analysis by Kobo et al. Of 1700 onco-fertility preservation cases and 7,000 elective fertility preservation cases. And you can see that the clinical pregnancy rate after oocyte freezing, thawing is around 41%. Our own group has done a lot of work. We have done nearly 70,000 donor oocyte cycle, donor oocyte frozen, which we have the frozen 17,000 and self oocyte 7,000. Onco-fertility, till now we have frozen 15 patients, but more and more patients we are freezing now more rapidly. And if you look at our oocyte statistics of 2017 to 19, self-freezing eggs 20 to 21 cycles of various patients. Social egg freezing was in 91 patients, cancer patients, 3 of them at that point, endometriosis 1. And you can see that the fertilization rates are nearly 61% after thawing. Egg recovery rate is 94% and pregnancy rate is nearly 41%. Next slide. Next slide. Next slide. Next slide. So if you look at return rate and pregnancy rate of, so what is the return? So if you freeze the patients of cancer, this is a study where you can actually see that the return rate of the pregnancy is around return rate with 6% to 25% return for actually getting pregnant after cancer chemotherapy. And the pregnancy rate in those patients has been as high as 41%. Next slide. So what about the safety of fertility preservation? You can see that patients who undergo fertility preservation, their safety is as good as those patients who don't undergo fertility preservation. Next slide. So if you look at the ASRM guidelines, it was considered to be experimental, but now can be done for patients. So now the ESHRI guidelines of 2020 have allowed ovarian tissue cryopreservation and ovarian tissue transplantation to be open for clinical application. So this is a new breakthrough which has come in. Next slide. So if you can see, normally for ovarian tissue, you can just take the ovarian biopsy, put it in the flushing media, put it in this container, and in ice you can transport it overnight. Next slide. And you can see this ovary is got a medulla as well as the cortex. So you dissect out the medulla. Next slide. And you only keep the cortex and then make it into 1 centimeter strips, and then you freeze the strips. Unfortunately, I can't show you the video. Next slide of this procedure. Next slide. So if you see, after you thaw them, patient has now recovered and you want to transplant the tissue back into the fossa. You can see on the upper side in the A slide picture, you can see that the ovary that was left behind, hemioophorectomy was done, chemotherapy was given. Now this ovary is left behind. Doesn't have any follicles. So you thaw these strips. You can see on the second B slide, you can see that the strips are thawed. They are re-implanted on the ovarian tissue side, and interseed is then put on it. The other way of doing it is that you can open a peritoneal pocket put all the ovarian strips into that peritoneal pocket and then put intestine on top. And many of these patients, next slide, can actually have
Rishi, Doyan Savaiti Paili and Suresh are waiting to deliver their lecture. So,
Yeah.
please. I know you will not.
No, but I was given 20 minutes.
I think the time is little finished.
So anyway, I'm just now. I can't make out because I don't have.
Yes. You have not just now exceeded about 22 minutes. Okay.
So the transplantation of frozen thought tissue. This was a paper by Geller in 2018, and the latest data shows that the 200 live births have taken place by 2020. So it is accepted. Next slide. You can see here that it is accepted. Next. So this is the next, and this is the next. So this is the review of 285 patients of 5 European centers. Chances of pregnancy is 25%. Natural pregnancy chance is better than IVF. Pelvic radiation drastically decreases the chance. Chemotherapy to achieve remission prior to OTC does not affect outcome. Dose and type of chemotherapy can influence outcome, and reimplantation and relapse risk is very low with fertility preservation. Next slide. So this is the last slide. So this is a case, 18-year-old unmarried medical student came to me just before COVID. Both parents were doctors. She had Hodgkin's lymphoma. She had normal ovarian reserve. She was in late follicular phase. When I did she was on day 10 or 9 or 10 or 11 of her cycle. When I did the transvaginal scan, there was a leading follicle of 16 millimeter. I gave a GnRH trigger to rupture that follicle because it could have interfered with the stimulation protocol. And 2 days later, I confirmed the rupture and started her on gonadotropin stimulation, added antagonist when the leading follicle reached 14, gave a GnRH trigger, and got 17 oocytes, which I vitrified. So this is very easy. Next slide. So this is the last slide. Male fertility is also important. So if suppose male is mature, semen cryopreservation can be done. But for immature male, that is a prepubertal male, we are offering the tissue freezing, though there is all these methods that I have listed are still experimental. Prepubertal male tissue, how to convert it into sperm is going to be challenging, but let us hope that in the future. But we offer prepubertal males, we offer them testicular tissue freezing with the hope that in the future we can achieve good pregnancy. Next slide. So the take-home message is fertility preservation is here to stay. It is applicable in numerous areas. One can postpone fertility for lifestyle reasons. Life exists after cancer, and fertility insurance is like life insurance, and we should promote it aggressively within a patient. I would like to thank you all for a very patient hearing. Thank you.
Thank you, Rishi. You alone can give such a wonderful percentage of result of take-home babies. Over to Dr. Sharma for closing this session. Uma Sharma.
Thank you, Dr. Rishikesh, for a wonderful talk. So many new things we came to come about. New developments, especially for the males who would also like to preserve their tissues for future use, especially onco patients. With this, we would come to the close of this session and we have the next session.
Thank you. Thank you.
Thank you, Dr. Sujata.
Thank you. Thank you. Thank you, Dr. Rishikesh Pai. Okay, I think we are already, delaying a lot of people. I'm very sorry for the delay. We'll quickly go on to the case presentations, which is actually a presentation of 7 minutes each with our experts giving their opinions. There are no questions from anyone. We only want experts to give their opinions. And of course, any difficulties that each individual faced in her case, those questions, how they could be tackled, will be answered by our experts. So our first case presentation is by Dr. Shweta Mathur. She has told me she may take about 8 minutes, but the next case is taking only 5 to 6 minutes. So that's how we are trying to balance the time. So Dr. Shweta, over to you. I don't want to waste any time.
Thank you so much, ma'am, for having me here on this platform. And I will just start my screen.
Sorry, I was asked to wind up. Yeah, because I was asked to wind up on this. Otherwise, I will not sit here. Okay, thank you.
Yes, Shweta, you can start now.
Yes, so I would start now. Fundus towards placenta all along and with excreta. I'm unable to move my slide.
Mr. Sudeep, if you have her presentation.
Okay, Shweta, you could click on the screen. I guess it will move. Or you could just
Yeah. Okay, yeah, I got it. Okay, thank you so much. So Mrs. P, age 38 years, presented with amenorrhea of 1.5 months and positive urine pregnancy test and spotting since morning. She was a known hypertensive with amylopress 80 for last 11 years. She had history of 1 full-term cesarean section for fetal distress 13 years back and 2 surgical DNCs. And she had grade 2 obesity with BMI 37. Her BP was very high, 180 106. Ultrasound was done. Single live fetus was seen. In gestational sac was lying in the mid uterine cavity. As you can see, the scar area was very close, and risk assessment was done. Serum iron levels were low. She was pre-diabetic, so concern management was done with antihypertensives and metformin. Her NTNB scan was normal. Down syndrome risk was low. Still NIPT was offered as she was 38 years old. That was also low risk. Level 2 scan showed placenta low anterior and no anomaly. She developed iron deficiency anemia, and injectable iron had to be given twice at 20 and 26 weeks. Growth was normal till 29 weeks, but at 32 weeks she showed suboptimal fetal growth, and the placenta was anterior covering the os. 34th week Doppler showed the placenta. You can see in this slide that cervical canal is seen and the placenta is sitting well over the cervix, and there is loss of plane between placenta and the myometrium. Also, the overlying myometrium looked thin, and but the good thing was that the bladder wall was smooth and no loss of plane was seen there, and increased vascularity was there at the base of the placenta. So it suggested placenta previa with placenta accreta. To confirm the diagnosis, MRI was offered, and MRI showed that placental myometrial interface is attenuated in the lower part. Multiple areas of aberrant vascular flow voids were seen across the basal plate of the placenta, so it was consistent with placenta accreta spectrum. So delivery was planned, echospray was stopped, and elective classical cesarean at 36 weeks was planned at a tertiary care center. Patient was counseled for possibility of cesarean hysterectomy and a need for secondary hysterectomy if a conservative approach was followed, for which patient refused blood transfusion and ICU admission. She was advised intervention radiology consultation for options for reducing blood loss because she was having comorbidity like hypertension and obesity. So option of UAE versus balloon occlusion was given, and PAC was done. Patient was admitted at 36 weeks. Blood was arranged, consents were taken, and on the day of surgery, pre-operative localization of upper limit of placenta was done by ultrasound to plan the uterine incision. And to my horror, it came out to be 4 centimeters above the umbilicus. Now the challenge was how to deliver the baby, because there was no space for vertical incision on uterus above the placenta and had to avoid cutting through the placenta. So patient was explained about this new situation and the need to give an extended vertical skin incision. Patient is shifted to cath lab 3 hours prior to cesarean for intra-arterial occlusion balloon catheter placement in anterior division of internal iliac artery. Injection heparin was given procedure, but unfortunately, balloon catheter could not be inserted on left side, citing extreme obesity, due to which femoral artery could not be accessed. Patient was shifted to main OT for cesarean. Patient position was supine. We can also use a low lithotomy position for proper vaginal access, and general anesthesia was given. Skin incision was median, intra-umbilical with cephalic extension 4 centimeters above the umbilicus. This picture is from the internet, and as you can see that the entire gravid uterus has been delivered outside. This is what we also did. And instead of the vertical incision, I did a uterine fundal transverse incision. This has been reported by Shukunami et al. 2012 and Hiroshi Sato 2016. So future fertility and subsequent obstetric outcome after fundal incision is unknown, and thus caution is to be exercised when uterus is preserved. It caused little bleeding. Breech extraction of male baby 2.2 kg was done, and cord was clamped close to the placenta, and tranexamic acid was given 1 gram IV. Now we tried to do the internal iliac artery ligation on the left side, but because of extreme obesity, there was no access to the retroperitoneum and we had to abandon it. No sign of placental separation was there in next 5 to 10 minutes, and decision for hysterectomy was taken. Intra-arterial occlusion balloon was inflated on the right side. Hysterectomy was not sutured as it was not bleeding. Cesarean hysterectomy was proceeded as usual. Just few surgical tips I would like to tell that about the bladder dissection. We should avoid blunt dissection, as neovascularization is seen as vessels running in the craniocaudal direction, and we should not touch them. We have to go below them. If we are unable to decide the level of the urinary bladder, then Pelosi's lower uterine segment bypass, some steps should be used, like retrograde filling of the bladder with 300 ml saline with methylene blue to demarcate its extent, and separation can be continued, as you can see in this figure, that it can be continued laterally and below the area of adhesion to create a tunnel. Then the division of the lower uterine attachments can be done, and then the area of adhesion can be separated. Also, another challenge is vaginal vault identification due to distended and elongated lower segment, and because pregnant cervix is soft and we cannot feel it distinctly. So either we can have an assistant push sponge on holder through vagina in posterior fornix while incising the vault, as we do in laparoscopic hysterectomies, or there's another technique by Matsubara et al. That is holding the cervix technique. Cervix is held in this fashion before starting the surgery, and the metal hardness can now be felt from the abdominal cavity, and the area to incise is 1 to 2 centimeters cephalad of the hardness, which can be felt easily. Now this is the final specimen. As you can see, I've sliced open the uterus from the back, and as you can see, the horizontal incision I've given to deliver the baby has just missed the placenta, and placenta can be seen sitting right at the internal os in this picture. So post-operative balloon catheter was deflated after surgery, and sheath was removed after 6 hours, although sheath can be kept in situ for 24 hours to watch for PPH and can be reinflated if required. Rest of the post-op was uneventful. So the final word from the histopathologist, that endometrium shows adherent placental tissue focally attached to myometrium directly at some places, and some places separated by decidua. So there was no invasion in the myometrium, and myometrium was not thinned out. So I'll come to the take-home message. So we should keep a high index of suspicion when there is a early gestational sac is seen near the cesarean scar. We should ask our radiologist to rule out placenta accreta in last trimester scan in patients with placenta previa, previous cesarean, multiple DNCs, and previous hysterectomies. Women who have had a previous cesarean section and also have placenta previa or anterior placenta underlying the old cesarean section scar at 32 weeks should be managed as if they have the placenta accreta spectrum with appropriate preparation at surgery. Take time for counseling and documentation, maintain hemoglobin level above 10, use injectable iron if needed. Tertiary center with multidisciplinary team should be present to operate the patient. Pre-operative localization of upper edge of placenta in placenta previa should be done for deciding the level of uterine incision, or we can go for the horizontal fundal incision. In case of stable patient, and there's no and placenta percreta is diagnosed on table as a surprise, and if the facility to manage is not there, we should either wait to arrange the blood, or we can call for help, and we can even close and refer the patient instead of opening up and not being able to manage. Thank you so much.
Thank you, Dr. Shweta. So there are questions for Dr. Paili and Dr. Suresh. Dr. Paili, regarding her difficulties when she had to put the incision, and was her decision right? And Dr. Suresh, early diagnosis of placenta accreta, and is an MRI absolutely necessary, or 3D power ultrasound, 3D ultrasound? And regarding the uterine artery embolization, Dr. Sanjeev will log in. So please, Dr. Paili, you can begin with the regarding how she managed it and what your suggestions.
Thank you, Sujata, and congratulations, Shweta, you managed the patient, a difficult patient, very obese, and came out without much problem. Looking back, it's always easy to be wise behind, after the event, but prospectively, whether you would have thought differently is the question. From what you said, it appears to me that it was probably not a percreta placenta, it was probably just an accreta, not even invasion of the myometrium. So maybe at worst, it is only an accreta. This sort of information is very important preoperatively for us. And we would like to get help from people like Suresh to identify where it is. And in this particular case, as you can see, probably we could have made a more accurate diagnosis on this, and that would have made your decisions much easier. If you knew that there was no percreta, you can even very well go ahead with an incision the usual way, separate the placenta and get it out. But sometimes this, as will happen in this, as happened in this case, it may not be the case. But there were some clues about it actually. In the beginning, you said it was implanted in the not over the scar area,
middle uterine
not over the scar area, mid-uterus.
Mid-uterus.
And later on, you found it like that. So in such cases, it's less likely to invade deeper down onto the scar as well as to the bladder. That's the first thing. But in case you find the placenta was, say, 4 centimeters above the level of the umbilicus, putting a transverse incision like that, that's one of the techniques described by Japanese, as you said. We may even put incision on the fundus if we are planning to do a hysterectomy. It really doesn't matter if you are planning to do a hysterectomy. If you are conserving the uterus, putting an incision transversely in the upper segment is better than, of course, putting it on the fundus in case you are planning to have another pregnancy. So that angle is fine. The difficulty to have the interventional radiologist help you is not all that uncommon, as has happened in your case when there is obesity. All these are problems. So that is why we have developed this clamp, which can be applied just by the obstetrician, not by vascular surgeon. No dissection required. Pull up the lower end of the aorta with the Babcock and then apply the clamp. I have mentioned this many times. I hope you would have heard about it. It's just a clamp which can be applied over the aorta. Over means holding the aorta without dissection.
How long can we keep that clamp, sir?
How long?
Can we keep the clamp on?
As long as you like. We have kept up to 2 hours.
Okay.
Yeah, you can keep it long because you are cutting off the blood supply only to the pelvis and the lower limbs. You look at it, the orthopedicians, how long do they keep a tunic? For hours. So you can put it for, we have kept up to 2 hours in 2 patients. And no problems actually. Because we are not depriving the blood supply to any of the vital organs. So we have no worry about applying it for even, but usually it will be over in about 40-50 minutes.
40-50 minutes.
Yeah, that's right.
So for the MRI also suggested that there's thinning of the myometrium, and ultrasound also suggested that. So
there are some other things that you also look for. The lacunae, that is not a very uncommon, it's not very much obvious in the picture that you showed. So that is another thing. We should also admit that we cannot blame any sonologist or even MRI specialist for this, because this is a relatively new thing and they all have to mature in their knowledge of interpreting these things. If you have people like Suresh at your command, that is a different thing, but you may not always get them. So we should expect that there could be an error in the judgment. What you did is the right thing. Error on the side of safety. You expected that it may be worse, and that's always better like that. Be prepared to tackle it. Just because it happened retrospectively, otherwise, don't blame yourself or anybody, because this is in clinical medicine, this is what will happen. So the precautions that you took, I would appreciate. Take an incision higher. That was good. Be prepared with blood and everything. Be prepared to control the blood flow to the uterus with whatever was available under your setting. So these are the right things to do, rather than face it as an emergency unexpectedly and get into trouble. And this patient being obese like that, of course, would have been more difficult to manage. Congratulations.
Thank you, sir. Thank you.
Can I add something, ma'am?
Yes.
Yeah, Dr. Suresh has to leave for the airport. So
okay, ma'am. Yes.
Hey, you please say something, Neha.
Okay. All these scans were done by me, And the level of suspicion for an accreta was very high because it was a previous cesarean section, 2 DNCs, and the placenta was anterior low lying. And this was a very obese lady. So at level 2 also, we did not feel that that there is it's a morbid adherent placenta. And internal scan was also done to assess it. And if you see the images that has been shown, this is not a very typical kind of a placenta accreta. I agree with sir, because there was no increased placental lacunae. There was no increased presence of really increased vascularity that we see in accreta. And it was a very, very subtle loss of hypoechoic space. And that space is also, if you see the image, is not very, very clear. So it was the level of suspicion in that case that here there might be a loss of that clear zone. So that was the suspicion that was kept, because the other features like lacunae, the vascularity, bridging vessels were not really that much seen. So I could see the increased vascularity, but it wasn't really that much. And hence that is why we proceeded for the MR. And MR also said the same thing. So on that level of suspicion, it was labeled as a morbid adherent placenta. And second thing was that pre-operatively we did an incision planning, and the cord attachment also was marginal. So where the placenta was ending, the cord was also lying along there only. So because of that also, the incision was planned really high up. So
Dr. Suresh, do you have anything to say about the radiological features that Dr. Neha was talking about?
Yeah. See, actually, when you look at the sonographic signs of adherent placenta or accreta, the first foremost important thing is in early pregnancy, a sac which is very close to the scar area. What we do at the time is to distinguish whether the sac is implanted in the scar or it is close to the scar. There is a small niche which we'll be able to see on the ultrasound, and we can say whether this is implanted in the scar itself or little away, because this differentiation has to be done at that time, because if it is inside the scar, then it actually becomes a scar ectopic, and the route the patient has to take is completely different. But when it's close to the scar, we put them at high risk for developing adherent placenta. And even in the first trimester, we can start monitoring them by various things. And the presence of the placental lacunae. There are cases where we have reported placental lacunae even in the first trimester. But as we go along, that's not going to be of much use of them, except to know that this patient is heading for placental adherence spectrum. So the loss of retroplacental sonolesion zone, the thinning or disruption of the serosa bladder interface, and the presence of focal exophytic masses in the urinary bladder. So we actually have to make the bladder a little bit full and see whether the scar area, whether there's any bulging or no. Abnormal placental lacunae. So these are the basic signs which we look at. Among all these signs, as far as ultrasound is concerned, the presence of intraplacental lacunae has got a very high sensitivity and specificity. And if you take MRI, the thinning of the myometrium and disruption of the interface between placenta and myometrium has got a higher sensitivity. So it's important to remember that while doing the scan, we must move the probe right from one end to the other, because often we just put it in the midline and look for the scar, but actually the placenta is stretching across the anterior myometrium, and we need to move the probe from one end of the scar to the other to see any areas of adherence. Some areas can be adherent, some areas need not be adherent. But ultrasound is absolutely excellent if applied well and if interpreted correctly as far as the thing is concerned. So we don't need to do MRI in all cases. Only where you have inconclusive report in the ultrasound, you need to go for MRI.
And sir, also in the cases with posterior placenta or low-lying where ultrasound is difficult.
Yes. In such cases, yes, definitely there may be a role for MRI there.
We've also got Dr. Sanjeev Sharma, who has managed to log in now. He is the ex-director of the Interventional Radiology section in AIMS. And I would like to ask him about, I don't know whether he heard the whole case. Shweta had difficulty in uterine artery. They had difficulty in the embolization.
Balloon occlusion placement in the anterior division of internal iliac artery on the left side. Because of extreme obesity, the femoral artery could not be accessed by the interventional radiologist.
So, Dr. Sanjeev, any opinion on that? Because we have to go on to the next case now. So, please just give us an opinion on difficulties in UAE, because we have to then go on to the next case. There opinion will be required there also. Okay.
So, as I understand, so first issue is the cannulation of the femoral arteries in an obese patient. Well, that's not a very big challenge. It's a challenge, but nonetheless, we can use ultrasound to guide our needle into the femoral artery and gain femoral artery access. In any case, if the femoral artery is not available or not accessible, we can always use brachial access to get into the internal iliac arteries. And we often do actually when we are doing uterine fibroid embolization. So we use a brachial access and cannulate both the femoral arteries from single arterial puncture. So in terms of gaining vascular access is not a challenge, but nonetheless, now, so we have multiple areas where we can possibly occlude this circulation to the uterus. We can cannulate the anterior division of the internal iliac artery. We can cannulate the common iliac artery. We can place a balloon in the abdominal aorta. Each of these has their own advantages and limitations. In terms of their efficacy to reduce blood flow and reduce blood loss during the surgery, the placement of balloon catheters in the abdominal aorta actually statistically has the best effect in terms of reducing the operative blood loss. Does it answer both the questions?
Dr. Piley's aortic
showing the clamp. Yes, sir. Yes, sir.
This is the clamp, and a model like this. What you do is you put the clamp to take the full thickness of the aorta like that, and you can clamp it all the way. You lift it out first with a Babcock and do it. When you go for dissection, that's the time when you get into trouble, because the in vitro vena cava is not far away. There are other vessels there. So just lift it up and apply the clamp, and you can apply it, as I said earlier, for the time that you need to do the dissection. So this, I hope, will make the whole approach very different, because no other specialist required to come in. The obstetrician himself or herself can do it.
Thank you, sir. So, Dr.
Thank you, sir.
We'll get on to the next case. And actually, I think we need inputs from you all only, because the next case is also sort of related. So, Dr. Preeti, please start your case.
Thank you, ma'am. Am I audible?
Yes, yes, you are.
Yeah. I am presenting a spontaneous rupture of scarred uterus in early second trimester. This is Mrs. X who came.
Preeti, your slides have to change.
Yeah. Mrs. X, she is 32-year-old. She presented in the emergency with acute abdomen. Her obstetric history, she was gravida 3, para 2, living 2, with 2 previous cesarean, and she was 22 weeks pregnant at that time. She was giving very important history, that history of fall 2 days prior to admission at home. For that, she went to some local doctor that was in Faridabad. They did one ultrasound and it was told to be normal. One was showing the single live fetus, 22 weeks with posterior placenta. There was no retroplacental clot. Os was closed, and she received injection prolutone, and she was sent back. After observing for some time, there was no pain, no uterine contraction was noted. After 2 days, she went to same hospital with complaint of pain, abdomen, and spotting PV. And again, they monitored her vitals. That time, ultrasound, per abdominal examination, uterus was little bit irritable, but FHS was present. On examination, per vaginal examination, there was spotting present. Os was admitting tip of the finger. They did hematological investigation. Her hemoglobin was normal, platelets, prothrombin time was normal. Again, they did ultrasound. That time was new finding was noted. They saw that small clot 3 centimeter in the uterine cavity at the anterior wall of the uterus. But placenta was posterior and cardiac activity was normal. Her os was closed also. Internal os was closed. In view of In spite of her vitals were stable, she was in labor, so they sent to the tertiary center and she came to our hospital. In our hospital, when we received her, her pulse rate was 120 per minute, BP was stable 100/80, her SpO2 was 98%. On examination, her uterus was tender, guarding signs was also present, and we could not locate the fetal heart. On per-vaginal examination, her os was 5 centimeters, 70% effaced, and vertex was at -2 station. We did ultrasound in emergency. No cardiac activity was noted. Placenta was posterior, but that clot, what they noticed in the private nursing home, that was increased from 3 centimeter to 7 centimeter entirely, and presentation was vertex. Meanwhile, we sent all investigation. Her hemoglobin was 9 gram, platelet 1.6, and other investigation was also within normal limit. In view of guarding and tachycardia, we decided for the laparotomy because there was high suspicion of the ruptured uterus in view of guarding, and she was having extreme pain in spite of, in between the contraction also, there was a sign of the guarding and acute sign of the peritonitis. In PAROC, we saw that 700 to 800 cc was hemoperitoneum was noted, and there was large clot occupying the anterior wall of at the whole length of the scar site. That scar was ruptured. It was and fetus limbs were entangled in the clot. We removed that, and uterus was repaired in the 2 layers. And 3 PRBC, 2 FFP, and 2 platelet. Patient were discharged in the stable condition.
Okay, so here we actually, the 3 things to note: why spontaneous rupture, especially not at the scar site, even though she had previous 2 cesareans. So we actually looked up the literature, and we would like your opinions, because we looked up the literature till the year 2012. The commonest reason was actually lap myoma, because the method of suturing again after the myoma was removed was probably not well done, or certain case reports showed that they only coagulated that area. So that area, the muscle was not very thick, and those were the reasons for spontaneous rupture, even if there was a scarred uterus, a rupture at another site. Then there was another reason saying that the uterine artery embolization also caused thinning of myometrium in various areas. So a patient who had uterine artery embolization in her previous case had ended up with a spontaneous scar rupture in mid-pregnancy. Then we also found the most common, the reason we felt here was that she had an abruption, and because of the abruption, there was an increase in the intrauterine pressure, which caused a sudden release of a weak scar. And that is how this ended up as a spontaneous rupture. So this was the basic deduction we did from this case. Any input from my 3 chairpersons who were there already for the previous case?
Thank you. Thank you, Dr. Preeti and Dr. Sujata. But unlike what you said, Sujata, there are a couple of points. One, regarding abruption, I think from the very beginning, when the bleeding was noted or the clot was in the anterior wall and the placenta was posterior, so it would not have been an abruption. We cannot call this a spontaneous rupture because there is a history of trauma. So we cannot call it as a spontaneous.
Oh, we thought abruption due to trauma.
No, whether we can say this is abruption is the question, because the placenta doesn't seem to have separated, at least in the beginning. Fetal disappeared. Clot was in the anterior wall near the scar. So we can probably presume that it was the scar giving way, probably initiated by the trauma she sustained.
But sir, initially it was done, no? Ultrasound was normal, no.
Actually, 2 days elapsed between the 2. It was a slow process, whatever we say, because initially the fetal heart was confirmed even after the history of the trauma. But there's nothing else which we can put as an inciting factor here. So putting everything together, as I said earlier, easy to be wise retrospectively. Probably putting everything together, we can think that probably it was all initiated by a small bleed, which went on increasing. And my puzzle is, why did the fetal heart disappear? If it was abruption, it was easy to explain, but there was no abruption. In the absence of abruption, if the fetal disappears, that is usually due to two things. One, the mother going into shock and hypotension, or the other thing is the viscous giving way, the viscera, the uterus giving way. Neither of these things happened in this particular patient, isn't it? The baby came out partially, but that is later. So we do not know exactly why, but it is, we cannot put it as a spontaneous rupture. It was probably a traumatic one. It happened slowly and progressed. And after it reached a particular stage, we can imagine blood started to leak out in the peritoneal cavity. So that is how you got about 700 to 800 mils of blood in the peritoneal cavity. Patient had some signs of hemodynamic insufficiency, instability, and that is what probably finally ended up in her getting to you at that stage. So not a diagnostic puzzle regarding the process. It was previous two cesareans, probably the scar giving way as a result of the trauma, slow giving way to the extent that it was bleeding inside, and the scar area, because of the hematoma, increasing in size, gave way, and eventually you got to the stage that you got it. This is how I will reconstruct the story. And you did the right thing. You did the right thing. But having got a rupture and two scars, unless she's very keen on having another baby, I would probably at least suggest to them whether they want to get sterilized. Because next time the chance of her giving way, even without a trauma, is also there.
We did, sir. We did.
I think Dr. Suresh has reached the airport. I think Dr. Suresh has already reached the airport. I'm not sure. But
I'm here.
I just want your opinion. I want your opinion as in current scenario, the way we are having so many previous scars and placenta equita spectrum being very common. Are we now supposed to look at the scar integrity and the myometrial thickness, rule out a niche, etc. in between pregnancies? Do we need to start doing this?
Yes, actually, there are several studies which have been looking at this, because this is a area which has generated a lot of interest. First thing is the inter-pregnancy interval. Looking at the scar, the inter-pregnancy interval. In that, you look at the niche of the scar. You look at the niche of the scar and also the residual myometrial thickness. From the point of the scar to the rest of the myometrium, how much is there? So some said if it is less than 3 millimeters, then this baby has, this woman has got an increased risk in the next pregnancy. Others have said you look at the residual myometrial thickness and also the niche and the depth of the niche and make a ratio. There's a third, so this they said the likelihood ratio of having a uterine scar dehiscence is about 5.5. So sort of a moderate predictor, not a definite predictor. At the same time, if a woman comes in pregnancy and then you do a scar thickness in the first trimester and the third trimester, most commonly we get referred in the first trimester and third trimester, that has not been found to be useful. First trimester scar thickness, it does not correlate with the third trimester scar thickness at all. So doing a scar thickness in pregnancy does not seem to have much of value, but the actual cutoff people say is about 3 millimeters or so. But it is in the inter-pregnancy interval seems to show some promise that this woman, you can categorize this woman as a little higher risk than others.
So that means we should start making it a routine now, because now we have so many cases to scars.
I would encourage rather to do a study first. Create our own evidence. Create our own evidence before bringing it to practice. Because otherwise you'll have to standardize, the methodology. And everybody, like what they did for NT, they enforced methodology like anything. So like this, and you enforce methodology and then uniform reporting and then only come to conclusion.
Right. Thank you. Thank you very much. Dr. Sanjeev, is there actually any point to say? Uterine artery embolization does cause necrosis of myometrium, and we can end up in trouble. That is what we have felt.
Yes, that is true. Actually, one of the uncommon, rather rare complications of uterine artery embolization is a spontaneous rupture of uterus. It's very uncommon. It's, I think, 0.1, 0.01 to 0.1% or 0.2%, something like that. But so 1 in 1,000. But nonetheless, it's a known complication, primarily because what happens is that we use particulate material, and this particulate material, in fact, gets into multiple foci within the myometrium. So it tends to produce a multifocal and rather diffuse myometrial injury, resulting in thinning in various areas, and this thinning is uneven, therefore exposes the patient to a risk of spontaneous rupture. But this is a very unusual and very rare complication.
Right. Okay. Thank you very much, Dr. Paili, Dr. Sharma, and Dr. Suresh. I'll get on to the next case. Dr. Shehla, please, could you start? And we have Dr. Saptarishi, who's an endocrinologist, who is also there, as Dr. Shehla's case is obstetrics. It's pituitary.
Good evening. Good evening, ma'am. Good evening.
Good evening.
Good evening, everyone. Ma'am, my slide is visible?
Yes, but you can put it as slide share. I mean, enlarge it. Share screen.
Is it visible now?
Yes, yes, please.
Okay. Thank you so much and congratulations. And I'd like to take excuse for my voice as I'm badly down with fever. So here is the case, rare case of pituitary apoplexy, that is acute Sheehan syndrome. Sheehan syndrome is a well-established entity, and it is seen as a complication of PPH due to loss of blood supply to pituitary gland. Pituitary apoplexy, on the other hand, was first described by Pierce Bailey in 1898, and it essentially meant bleeding or infarction into pituitary adenoma. An acute presentation of Sheehan's as a case of pituitary apoplexy is described in some very rare literature till date only. Owing to its low pressure blood supply, anterior pituitary is quite vulnerable to massive blood loss. We see TSH, ACTH, FSH, LH, growth hormone, prolactin, and endorphins going down due to dysfunction. So during COVID era, I would like to narrate one case. When the first wave was passing by, I got a call from Triage area that we have received one 27 years old para 3 life 2 in a bad state. She had GCS of 4. She had coma, having history of repeated episodes of convulsions before being brought since last 6 hours. And she was refused by other facilities as her saturation was low and she was suspected to be a case of COVID positive. So on detailed history, there was history of delivery of term baby 5 days back at some private nursing home. There was history of uterine inversion, massive PPH, which was reposited. She went into shock, obviously, and she was transfused 5 units of packed RBCs. Those were the things mentioned on her discharge ticket. From there, she was discharged in a satisfactory condition. She was keeping low, very weak, and suddenly, after 4th day, she developed severe headache, pain in neck and in left arm. She had multiple episodes of vomitings for 2 days. She took symptomatic relief for treatment for that, but there was no relief. Headache progressed. It was severe in the morning of presentation. She had 2 vomitings again and multiple episodes of convulsion. There was no remission in between. She became unconscious after that and brought to our hospital after 6 hours. On examination, there was tongue bite, coarse crepitations. Her saturation was 74%. Abdomen was hugely distended, but although it was coming out to be only gaseous one, pulse rate was 140, BP 84, urine albumin 2+, lochia and uterus were well involuting and nothing was abnormal. Her hemoglobin was 7.8, platelet 98,000, pH was 7.2 on ABG, ECG normal. So we started taking this case as a case of postpartum status eclampticus with aspiration, type 1 respiratory failure with shock with anemia. Patient was intubated, noradrenaline was started, magnesium sulf loading was done, gentamicin, clindamycin started along with other supportive therapy. On further investigation, her sodium was 94, potassium 2.8, blood sugar was 40, and replacement by potassium chloride and 3% saline was started. Creatinine was 1.6, so we stopped gentamicin, and magnesium sulfate dose was also reduced to half. After 11 hours of admission, status quo was there. Again, she had an episode of seizure. Eptoin was loaded. Magnesium was stopped as knee jerks were not appreciated, and physician took the decision to start higher antibiotics and levetiracetam also. Meanwhile, our RT-PCR report came out to be negative. Her CT scan was planned. After 38 hours of stabilization, she started moving her right upper and lower limbs, but in left upper and lower limb, there was no response. On CT scan, there were infarcts in anterior and posterior pituitary. Rest of the things were unremarkable. Thus, we thought of taking into account of her dyselectrolytemia, hypoglycemia, and CT scan report. She was taken to be a case of postpartum pituitary apoplexy or acute Sheehan syndrome. So we started her with high-dose corticosteroids and sodium-potassium replacements, and her further investigations revealed that cortisol, TSH, prolactin, all were deranged. On day 3, there was slight eye opening started, but she had slurring of speech. She was extubated also. Distension also kept on resolving, and physiotherapy was added. On day 6, she became conscious, but disorientation continued. She had slurring of speech. Left hemiparesis was also unresolved. On day 8, she had same status, but she started walking with support, and patient was discharged on day 12 with supportive treatment. On day 16th of follow-up, she had mild disorientation, slurring of speech was still there, left hemiparesis was still there. She was advised physiotherapy and repeated investigation, which were all normal, and I have tabulated it here. On 5th month of follow-up, she had breast sagging, remarkable wrinkling, amenorrhea, slurring of speech is still there. She has still left hemiparesis, and we have started her on estrogen and progestin. So to discuss pituitary apoplexy's medical emergency that is occurring due to hemorrhage in pituitary gland. Commonly, the event is a manifestation of an underlying pituitary adenoma, but in rare cases, it can occur without adenomas also. Recently, when the search of literature was done, there was a review of literature in BMC. They published a case of their own case of acute Sheehan's, and till date, only 21 cases of acute Sheehan syndromes have been published. In 2017, it was the last reported case. The presentation was varied: adrenal insufficiency in some, diabetes insipidus, hypothyroidism, panhypopituitarism, and mean time of presentation was also different. So we have reported this case for 3 reasons. First, initial presentation may mimic postpartum eclampsia or a seizure disorder. So a clear-cut knowledge about the entity helps us to manage such patients better. Secondly, it is a rare but life-threatening condition, such as dyselectrolytemia, which if not taken really fast can deteriorate and lead to morbidity and mortality. And thirdly, although the patient was managed conservatively with good outcome, but for her speech sequelae and her hemiparesis, I think if taken well care in time, it could have been avoidable. Differential diagnosis, if you think of, it can be CVT, stroke, meningitis, aneurysmal rupture, and lymphocytic hypophysitis. So to us, the learning points first point is the clinical syndrome of pituitary apoplexy is rare, but it should not be misunderstood or missed. Second, often it is misdiagnosed because of its highly variable clinical presentation. Emergent decisions and treatments have to be taken. And yes, this is left for discussion that we start glucocorticoids first, followed by thyroid replacement, gonadotropin replacement, and growth hormone deficiency. If there, it should be replaced at last. Thank you so much.
Shall I just like to add on a thing over here? It was obviously a well-managed case, and of course, this sort of a scenario, any of us can land up with a case of severe PPH with the inverted inversion of the uterus, probably. So definitely a very challenging case, a case where we definitely need to learn a lot from, probably. And of course, but one of the things, Shala, that I would want to mention a little bit about was the good part was that hospital which is referred had given you all the details of all that they had done for the patient, which made things a lot easier for us. And I think that should be a take-home thing for all of us, like mentioning everything once we are referring a patient. And I think we have the endocrinologist with us. I think he'll guide us better with the follow supportive measures for this patient.
Thank you for the invitation. So we are having a wonderful academic fest, and this is indeed a very interesting case. So most of the cases of Sheehan's do present after 3 years, 4 years, or even after 8-10 years. So we often tend to miss the diagnosis. Acute Sheehan is, as already mentioned, is very, very rare. I think there are 3-4 important take-home points which are there in the case. So whenever you are seeing a lady with low blood pressure, we know obviously PPH is one of the cause of low blood pressure. But along with that, if you are having a situation where the blood pressure is low, sodium is low, and blood sugars are low, then you have to think of hypocortisolism or adrenal insufficiency, which is the most life-threatening aspect of hypopituitarism or pituitary apoplexy. So the first thing is that usually in these cases, what we see is there is elevated potassium. So hyperkalemia is usually associated with adrenal insufficiency. It can be primary, even if it's primary or secondary in whatever state. So we need to, maybe the lady was getting aminoglycosides. That is the reason she had hypokalemia. So otherwise, any lady in a similar situation, hyponatremia and hypoglycemia, I think are the 2 most important keys that there is a possibility of pituitary apoplexy. Another very important thing is that you need to be very, very careful about the correction of the rate of sodium. So if you land up with a sodium of 94, and if you replace the sodium too early, chance of pontine demyelination and the part of the slatting of the speech, even which also need to take into consideration. Otherwise, so first we start with hydrocortisone, and then after correcting the after 2-3 days of hydrocortisone, we start thyroxine. And once the patient is stable, we think of hormone replacement in terms of sex hormone replacement, or we think of terms of growth hormone. Growth. So a key is active here. So that is also anyway very well missed of diagnosing Sheehan so early, acute Sheehan. This is a very, very rare entity, and it should be appreciated. Thank you.
Thank you so much, Dr. Bhattacharya. Thank you.
Tata, any queries you have?
I was just thinking. No, actually we're running late. But while he's putting up the panel discussion slides, I've requested them to put up the panel discussion slides. Dr. Paili, while they're doing that, is there anything you want to say about Sheehan's, acute Sheehan's? Because the panel discussion slides have not yet come up. I told him to do that.
Madam, can you just stop sharing that slide?
How do we stop sharing this? Who put up? Dr. Shaila said she had stopped sharing.
This is Mitra ma'am slide, ma'am. Ma'am, you're on mute, ma'am.
Dr. Mitra to kindly.
Oh, that is her slide. Okay.
Yeah, if I may add, Sujata, sorry, I missed out the case presentation part and the early discussion. But what I understand is this is post-PPH Sheehan syndrome. Am I right?
Yes.
Yep.
Yes.
Shaila?
Yes.
Yes, sir.
When I continue? Can I continue?
Yes, sir.
Yeah, the point is we have to have a different look at PPH management. Earlier, we were talking about the golden 1 hour, golden 2 hours and all that. All that had gone. Our aim should be to emphasize the point that we have only a few minutes. Immediate steps should be taken to arrest the bleeding. And now we are in a stage where we are able to do these things. For example, if it is a bleeding from the uterus, atonic BPH, which is the most common thing, either by putting clamps to both uterine arteries transvaginally, there's a transvaginal uterine artery clamp, or by putting a suction cannula into the uterus and creating the negative pressure to make the uterus retract onto that cannula, we can arrest the bleeding spontaneously. While we are getting those few minutes, waiting for that few minutes for this to be assembled, the operator's responsibility is the moment you feel the bleeding is excessive, put your hand inside, bimanually compress the uterus, ask for these things and do that. So the approach to BPH has to change. Once they go into hypotension, shock, you are lucky if she doesn't go to death. Even now, with all the things that we have been talking about, BPH remains as the most common cause of maternal death, not only in our state, across the world, except in the developing world. It's a developed world. All over the developing world is the problem. Of course, due to lack of facilities. But here, now we have a chance to stop the bleeding immediately, and that should be our aim. The condom tamponade, the Bakri balloon, all these things should be out. And the tertiary surgical approach of devascularization, uterine artery embolization, B-Lynch, hysterectomy, internal iliac ligation, all these will be very rarely required if you go to this. In case we are getting a patient who has already gone in for shock, almost on the verge or in DIC, the next, again, stop the bleeding, one of these clamps. And if you open the abdomen vertically, go to the aorta clamp, that will stop the bleeding. And then only whatever we give will stay in the circulation and get this coagulopathy corrected. So my point is only this. Times
Thank
of
you, sir.
times
Thank
of
you, sir.
we have to approach in a different angle. Forget about this golden hour. Immediately stop the bleeding. And now methods are available for that. I think all obstetricians have to adopt that. Thank you.
Thank you, sir. Thank you. Dr. Mitra, I'm very sorry for this delay. All the panelists, please, we're very sorry. Please, let's get on to the panel discussion. Yes, Dr. Jigyasa?
Sorry, Sujata, I have to leave now because, okay.
Sir, I wanted you for all the three cases because I knew you would have something to say. Anything with PPH, I know you will have a lot, and we need those inputs.
I have to go now. Thank you very much. And thank you, the whole Noida Society and all the friends over there for this opportunity. Thank you.
Thank you, sir. Thank you.
Good evening, everyone. I'm here to take you to the last session of today. After the mind-boggling case presentations, we have a very interesting panel on optimizing patients for delivery, a major concern, with special emphasis on liver disorders and asthma. We all know because of the increase in the air pollution and indiscriminate use of progesterone, we are coming across these medical conditions more often. So I take this opportunity to call upon our eminent moderators, Dr. Mitra Saxena and Dr. Surekha Taide. Dr. Mitra Saxena, she is a renowned national faculty. Yeah.
Dr. Jigyasa, please just run through the.
Yeah, okay. I'll just tell she's the present chairperson, practical obstetrical committee.
Please, thank you. Thank you.
Okay. And I welcome Dr. Surekha Taide also. She is a chairperson.
I will introduce her later.
Okay.
Yeah.
I think I hand over the podium.
I'm a teacher since 20 years. That's all.
Okay. Okay, I hand over the podium to you.
Dr. Jigyasa, please give me the screen share so that I can start right away.
Okay, okay, ma'am.
Yeah.
Ma'am, you can share your screen now.
The slides are visible?
Yeah,
but please go on slideshow.
Yeah. Okay, so a very good evening to all the wonderful Noida Society, Dr. Sujata, but the seniors who are there, 60 participants I can see, my co-moderator, Dr. Surekha Taide, and the job today is a challenging one to optimize patients with asthma and liver disease. I know the topics are very, very huge, and the only thing that we are going to stick today is get the fundamentals down so that the level of everything rises, as Michael Jordan has said. So we as obstetricians are very good at managing the obstetric part. But these two conditions, so I thought my wonderful Doduni Char partner, Dr. Surekha Taide, so I do hope that together we can take you through so that the obstetrician's general knowledge about these two enigmatic conditions is upgraded. Because in bigger setups, we have a liberty of having a respiratory physician at our service or a hepatologist. But when we are alone or in a smaller setup, if we have a good understanding about these two conditions, I think we will all be better off. So I welcome our esteemed panelists, and I do hope that Dr. Taruna Girish, Dr. Dimi Bakshi, Dr. Sharda Patra, Dr. Sanchita Dubey, and Dr. Ekta Singh are here. I could see Dr. Ekta, Dr. Sanchita, Dr. Sharda, and Dr. Taruna. So all of them are here?
Dimmi, I'm not able to see Dimmi.
But never mind, Dr. Sujata.
Dimmi is there. Dimmi is there.
But never mind, all those who are there can also participate, who have the panelists.
All of them are there. Yeah.
Yeah. But even you, Dr. Sujata, we can fire some questions on you. After all, you put us in this position. So friends, we all know that asthma is a condition of the abnormal response of the human body, reactive airway disease, to the triggers. So I'm not going to be wasting too much of time because we have a lot of things to learn. And it's a chronic inflammatory disease characterized by intermittent episodes of wheeze, shortness of breath, chest tightness, and cough, which worsens at night. So let's go on to the first case itself. Dr. Taruna Girish. Dr. Taruna, are you there?
Unmute, Taruna.
I request all the panelists to unmute themselves.
Yeah, I'm here. Okay.
Okay, yeah, welcome, Dr. Taruna. I can see you now. So we all know that very, very commonly, all the patients who are pregnant, and if they are pregnant primary, they will always complain of breathlessness in the first trimester itself at 5 or 7 weeks. But now here is a case who's 28 weeks pregnant, primary gravida, low BMI, and she reports to the casualty with acute breathlessness. So what are the common differential diagnoses which come to your mind, and how to fix an asthma as the diagnosis? So I would like you to mention all those things because of which this patient could be breathless.
Yeah, see, first of all, the patient, when she's coming, we have to think of the causes of breathlessness in this lady. And first of all, as you said, it's a normal thing, physiological also, to have breathlessness in pregnancy. And then there are other causes which have to be ruled, which can be cardiac or respiratory or metabolic. And first of all, we'll like to take the history in this. If we have to zero down on the diagnosis of asthma, that did she really have this problem even before pregnancy, or if she's had those episodes before, and if she's been taking.
So actually, Dr. Taruna, what I just want, we're not going to ask you how to come at the diagnosis. The question is all these in things that could be contributing to breathlessness. So like you rightly said, that she could be having cardiac. So if you would like to elaborate more on that.
Yeah, so if we go into the causes of dyspnea in pregnancy, one is anxiety. Another is if she could be having the physiological thing, then respiratory, asthmatic, or though amniotic fluid embolism is also a possibility. But we have to keep
enumerate. Actually, nowadays in COVID times, we are getting to see a lot of patients, no? So that is why we have to keep all the reasons of the respiratory tract in mind whenever we are dealing with breathlessness. And as you rightly said, cardiac disease. So
and then anemia, that is very common in our setup. That is one thing which we really have to see. Anemia is a very common cause of breathlessness.
Yes, very good. Yeah, and of course, if patient has any renal disease, metabolic acidosis, there could be only tachypnea. Why I've mentioned is that recently there was a patient where the only thing was tachypnea and renal shutdown. So basically, when we are dealing with anything to do with the respiratory system, we have to think of the other causes as well. Dr. Dimi, we all know any medical condition will influence the pregnancy, the mother and the baby. So would you be worried about asthma in pregnancy, and how does it affect the pregnancy? Dr. Dimi.
Asthma does affect pregnancy because it also causes, in case of severe asthma, which can cause hypoxia and in turn affect the baby. In case of mild and moderate degrees of asthenia, it does not affect the baby much. But in case of severe asthma, it does affect the baby. It may lead to preterm labor, then other problems with the baby, IUGR, preeclampsia. So we have to be careful and we have to ask proper history to know whether her degree of asthma is mild, moderate, or severe. So depending on the severity of asthma, the treatment of the mother depends.
Yes, actually you've mentioned almost everything. What I'm saying is that in acute cases, we have to remember that there can be respiratory failure as well as maternal mortality. So although asthma itself may not deteriorate, may stay unchanged or may improve also, equal proportions, but a patient of asthma can have all these complications, as you've rightly said, and those with severe disease, the asthma control is more likely to deteriorate. Important thing that I wanted to bring to light, which I also learned, that a woman who has asthma and the baby who's baby in utero, baby itself also is at a higher risk of having asthma because of the atopic tendency and also maternal hypoxia. So I will invite my wonderful co-partner, Dr. Surekha. So
thank you, Dr. Mitra, and of course, very nice inputs from all the panelists. And when we are having such a patient of asthma who's coming to us in the casualty, so how do you start a thought process in your mind regarding how to go about managing this patient? This is for Dr. Sharda Patra. Can we have your inputs, please?
Dr. Sharda, have you joined? She told me she is there. Dr. Sharda?
Hello. Yeah.
Oh.
Little अभी panel चल रहा है, बाद में बात करेंगे.
Hello. Huh. Okay, but you take the question.
Can Dr. Sanchita take this question, please? When we have this asthma patient with us, how do you start actually planning the management in your mind itself? How do you start
Dr. Surekha, one second. Sorry, Dr. Surekha, just sorry to interrupt. I got a call from Dr. Sharda. Dr. Sujata, please ask the tech support to help Dr. Sharda because she's logged in. She's unable to, communicate. Please carry over, Dr. Surekha.
Anyways, we go ahead with Dr. Sanchita.
Yeah. Good evening, everyone. So, see, whenever you know that there is a patient with any medical disorder, it is always advisable on the first visit when you are taking a detailed history of the patient that she is asthmatic. You need to tell her to visit her physician and take an update that what all things she would be requiring to be a little careful. A number of times patients are little apprehensive that now since they have got pregnant, they have to stop their medication or they have to change it. So you have to assure them that her medical condition is very important. It should be under control. So before she gets into all these problems, you have to update her that she has to be very particular about her taking medications and all. And now with COVID things and all, whenever you see any patient with asthma, you have to be very vigilant. You have to check for her pulse oximeter. And then the moment you feel that she is having too much of cough or breathlessness, you always need to involve a physician also along with the gynae management, whatever you have to do.
Definitely, Dr. Sanchita, we being obstetricians, we do not regularly see so many patients with acute exacerbations. So there is a grade of severity of these asthma patients. We can see more number of patients who are actually having the intermittent kind of asthma, wherein the episodes are less than one per week. they're sort of asymptomatic, but they will have this asthma episode less than 1 per week, and nocturnal symptom maybe less than 2 times a month. So what we really want to, when we have these asthmatic patients, we need to learn as an obstetrician to actually classify them, whether they are intermittent variety, whether they are the mild persistent variety, the moderate persistent, and the severe ones. So grading the severity actually we will learn how to actually manage these patients. So are they coming with acute exacerbation, or were they the mild ones who have now risen or upgraded to the persistent one? So this is a chart which actually tells you how to grade the symptoms, and depending on the nocturnal symptoms also, and the FEV and PEF of the patients. So we as obstetricians actually need to learn that yes, we should send our patient initially for the physician to evaluate. But if the patient is coming to us in the casualty, we ourselves should be able to assess them which grade of severity they become. And of course, we should know about these previous one, please, the previous slide. We would also know about the warning symptoms which tell us, yes, this patient is going to land into an acute exacerbation. So she has cough, she may having that shortness of breath, tightness in the chest, noisy breathing, nocturnal awakening, and recurrent episodes of the symptom complex. So anything which exacerbates these symptoms, any atopy, the allergies, so we should inquire into them, and certainly we should be able to grade these patients so that we can act quickly. If any life-threatening condition is there, we should be able to recognize immediately in our casualty itself, and we should go. So as an obstetrician also, we should learn this. I think this is a good panel for us to actually learn from. So my next question
very
is
important, very important thing, like whenever there is a patient with asthma, the patient should always be updated about the triggering factors, that what are the situations which can, trigger her asthmatic attack. So I remember one patient, she rang me up of acute breathlessness after watching a show where she was sitting for almost 1 or 2 hours in a very cold environment. So that is also which has triggered her. So when
definitely the preventive factors, the patient should be able to recognize herself, because over the years, actually she recognizes that these are the factors which give rise to this exacerbation. You are very right to say about that. Yes, definitely. Is Dr. Sharda here? Is she able to join? We would like to go on to the
Dr. Sharda can take this one. Yeah,
please, Dr. Sharda.
I sent her the link. I hope she got I hope she's logged.
If she's
sent her the link.
Yeah. Anyways, we move ahead, and we would like to know from Dr. Sanchita, if you can take the next one also, what would you like to look for in examination of such an asthmatic patient? How would you quickly assess from head to toe this patient, and especially the respiratory system?
We go step by step. We have to know the pulse. We need to measure her blood pressure. Then we need to assess the chest. Chest examination is very, very important. You can make out the rhonchi, the wheezing, and also that you can act accordingly. And yes, if it is very, very severe, then you will have to note the cyanosis also on the extremities. So this is how a basic checkup which you need to be doing immediately once the patient reports to you.
And definitely, we would also like to know whether there is a severe episode. Initially, we do want to assess the chest, as you have rightly said. What kind of, is it the wheeze? Is there a rail? Is there any other comorbidity existing? Is there an pneumonia or something which is there? Is an infective variety? Or what is the level of altered consciousness of this patient? Is there any hypoxemia which is leading to lethargy or the consciousness? So the Glasgow Coma Scale, which we really are, trying to assess the patient's consciousness. Is there any inability to complete the sentence? So what kind of exacerbation and what severity the patient has landed into? Is it a sign of fatigue, or is she going to go into a respiratory sort of an arrest? So all these, so if quickly we should be able to assess this so that our next our emergency management can actually rely on that. So these are certain signs of uncomplicated asthma. We should look for the equality of breath sound on both the sides of the chest. Is there any other coexisting condition? And sometimes, you know, if you're not able to hear any sounds, that may be more worrisome. A silent chest actually is more worrisome. Jugular vein, we should be able to, you know, assess also if there is any fullness there. Hypotension, as you rightly said, the blood pressure, the pulse, and if there any infection, a fever, all these are very important in a case of asthma so that we understand the severity and if there is any complication. I think we should go ahead, Dr. Mitra.
Okay. So Dr. Ekta Singh, Dr. Ekta?
Yes, she's there. Please go ahead.
Yeah, although Dr. Sureka and Dr. Sanchita have already mentioned how to examine. So what are the ways to assess? I mean to say the diagnostic modalities which are there so that we can assess and monitor such a patient. Dr. Ekta.
Yes, ma'am. As we discussed, asthmatic patient may be spectrum may be from mild to severe. Here we are discussing a severe patient which came with the heights of severeness is the silent chest, as you told earlier. So to monitor this patient again, after examination, we go for just like what is the pulse oximeter, what is the oxygen saturation at present, what is that is the most simplest thing, easy to assess, and we can know the overall status of the lady at present and how much the baby is in danger at present. So, and then we can go for some imaging techniques and some blood parameters also. In imaging, because patient is our patient is a pregnant lady, but if,
Dr. Ekta, sorry, I just want to tell you that that case was just to start. Don't think we are restricting only to that. Now, actually, we are discussing. So you're going very fine. You are mentioning everything that we want to hear. And yeah.
If a case is a very mild, if a case is a very mild asthmatic pregnant lady, then just intermittent, when she has any attack, then she has to monitor things, her pulse oximeter, oxygen saturation and all. But
would you like to throw some light on the pulmonary function test, the spirometry and peak expiratory flow rates? Because for assessment and monitoring, I think they have a very important role in an asthmatic. Yeah.
Yes, ma'am. If the tidal volume is less, if the bronchus are constricted, then the pulse PFT is really not that much good. It depends on the severity of the disease of the patient.
Yeah. So basically, as already we have mentioned, Dr. Sureka has mentioned, and basically why we are going to go again and again is so that we as obstetricians know that there is intermittent and mild, persistent, which is more common, more often more repetitive. Persistent is persist, and it is mild, moderate, severe. So wherever the spirometry is deranged, already we are dealing with a compromised and a severe patient. Obstructive pattern is there. And a very important thing, would you like to tell about the peak expiratory flow meter? What is it and why is it important? Because it's important for patient to be educated. So I think we as obstetricians should also know that we should be the primary person to tell the patient about this peak expiratory flow meter. Dr. Ekta?
As much as ma'am I can see in the slide, because I'm really not into this thing. Most of the time we actually refer the patient to the
I know Dr. Ekta, don't worry.
But yes, ma'am, as you are telling us,
4 days ago, even our thing, you know, we only know the obstetrics. That's why we are together, you and all of us and my co-moderator, we are all actually exploring and learning all that we have accumulated so that we can share with the audience. So
this peak expiratory flow, if it is very less, it's less than 30%, it means it's a very severe kind of asthma. Ma'am,
Yeah,
I think
definitely,
you are the better person
madam.
to teach us.
We can show them the image which is showing the actually the patient is also able to find out what kind of the peak expiratory flow as well as the forced vital capacity of the patient. These are the two things which need to be measured, and
Actually,
that will tell us. Yeah.
what I would like, like what we have gathered together, Dr. Sureka and myself, main thing is that the peak expiratory flow rate, it doesn't matter how much is the tidal volume in that, because some people will have low, women do have lower. It is the personal, personal readings. So an asthmatic patient should be educated. Of course, the respiratory physician will be the one, but our aim to bring this here was that we as obstetricians should understand that this is a very cheap gadget which is available in the pharmacy, and it's very simple. All you have to do is that the patient has to take a deep breath and just flow out, and there is a small rider here, and that goes with the breath, and the measurement comes here. The patient just blows out into it, and so basically, if we put all the responsibility in the respiratory physician, the patient doesn't go. So we can be the people to tell them that if you start doing the PEF, your own flow levels, then you will be able to know if and when you're going to go in for an asthmatic attack. So basically, because that is one of the pillars for asthma management, that patient has to be educated. That's why we brought in. Do not feel inhibited, because even we don't know and we don't go by the percentages. Most important thing is that every patient should know her personal best, so she can monitor her levels by this flow meter. So as you rightly said, we'll go a little bit faster, that the X-ray chest and blood gas analysis where we are suspecting more serious conditions. And as you said, the fetal surveillance is very important, because in acute asthma, the baby is also hypoxic. So yes. So this is a little bit difficult, Dr. Taruna and all of us, because we'll go through the medical treatment also. Dr. Taruna, how do we manage a patient of asthma?
If we have a patient of asthma and during the antenatal time when she's coming, so we'll have to again see for her what is the category in which she falls. If she's mild, moderate, or severe, she can be treated with only beta-2 agonist or only inhalational medicines, or steroid has to be added. That all depends on the category in which we've put the patient. And likewise, and then we have to counsel her that she doesn't have to stop her medicines, because all these medicines are quite safe during antenatal period and during delivery, because stopping the medication will land her up into trouble, into serious disease and exacerbations. So that is the counseling which we need to give to the patient. And the medicines obviously will be prescribed by the physician, but yes, these are short acting and long acting beta-2 agonists, which we've been using, like salbutamol, terbutaridine, and other like salmeterol, and the steroids. This one of choice is budesonide, which is quite helpful in pregnancy and the preferred one. And then these are the other options which in serious patients which we might consider are other the long-acting muscarinic and the Montelukast and all. But ideally we go for we want to treat the patient first with beta-2 agonist and steroids are the mainstay of treatment.
So I think, Dr. Taruna, that is really very good, because you've been able to bring in almost everything that we wanted. I will just try and summarize it quickly, that our goal is to control the symptoms, prevent exacerbations, and keep the patient to near normal pulmonary functions. And these are the 4 pillars on which asthma management stands firmly. While we are monitoring the patient's lung condition and fetal well-being, this avoidance of triggers, which Dr. Sureka and the first panelist had mentioned, and patient education, herein comes our role also, we are being educated through this panel so that we also, learn and then teach the patient that she has to know her symptoms. And rightly, as you said, that the patient have this fear, and all the relatives also, that if they take treatment for asthma or anything, it's going to affect the baby. So this is one very clear message that you have given so rightly. And then, of course, you've mentioned all the pharmacological treatment. I know it is the best thing is that we should refer or have a physician with us. However, it is very good, like you mentioned. So these are important groups of medicine, and initially all were taken orally. And now with the wonderful drug delivery system, inhalational medication, we have to educate the patient that these are all safe. So this is a short acting. So in intermittent type of asthma, this is very effective. Long acting is salmeterol and formoterol, and glucocorticosteroids. They are the mainstay of the treatment of asthma. So inhaled, oral, and IV. We will be repeating this again and again so that it goes right into our head that it's a step up and step down management depending upon the condition of the patient. So as you rightly mentioned, these are the steroids which are there in use, and very importantly, the steroids with the beta-2 agonists in combination are very useful. Now, this is a very important group: muscarinic antagonists, ipratropium and tiotropium and glycopyrrolate, because whenever it's a serious patient, then there is tachyphylaxis with beta-2 agonists. Then comes the role of adding the muscarinic antagonist. And we also know montelukast, which is a leukotriene receptor antagonist. Friends, actually, there is so much of information, too many products, but I thought that at least we as obstetricians should know this much, and that is fairly good for us. Dr. Taruna has already mentioned. I'm not going to go on to this slide because Dr. Surekha has already mentioned this in the first thing. So important thing is that two group of medications, the controllers and the relievers. The bronchodilators are the beta-2 agonists and the muscarinic antagonists, and the controllers are the preventers, that is the steroid group and the leukotriene antagonists. This is the beauty that asthma now, if it is dealt with intelligently, unfortunately, patients of asthma, they really, either ignore or they let their condition deteriorate. So this will just go fast. This is to just reiterate that the global initiative in managing asthma rests on all these. This basically is just to let the delegates look at this wonderful chart which summarizes everything that has been mentioned. So Dr. Surekha, please take over.
Yeah, definitely. We as an obstetrician would like to know about the drugs, because if such a patient comes to us in our labor room, at least these drugs some of them should be available with us. That is what we would like to stress upon through this panel to our obstetrician practitioners who are listening. Once in a while, we are going to need to manage such cases. And now with COVID coming in and breathless patients coming in more often, we definitely need to know how to deal with exacerbations of this. So that is what we would like to do. So Dr. Dembi, if there is a case of acute exacerbation, is there anything which we need to stress upon, and how would you manage them?
In case of
so apart from what we have already said, yes.
So, in such a case, we need to give injectable steroids.
Yeah, definitely.
And also inhalation beta agonists such as salbutamol and other things. And also injectable has to be given maybe every 60 to 90 minutes till the symptoms are controlled, and then after every 1 hour. And once the symptoms are controlled, it has to be continued for some time, maybe 6 hourly or 8 hourly, depending on the symptoms of the patient.
Yeah, Dr. Dembi, that is very nice. Yes, because we are dealing with a patient who is sick, actually, who's having acute exacerbation. So that is what we want to reiterate again, that sort of an HDU setup is needed here, where a patient, you may need to do an urgent X-ray for her. Initially, we need to give oxygen by a tight oxygen fitting mask. And then, of course, the nebulization by a combination maybe of salbutamol and a bronchodilator and a steroid. So there are good combinations available. We may require to give an intravenous steroid hydrocortisone, which is easily available because prednisolone also is available, but hydrocort is more easily available with the obstetricians. So this we can immediately give 200 milligram 8 hourly, and of course the bronchodilators we can step up, and we could, if required, we could consider an aminophylline drip for this patient, and the IV aminophylline, which also we should be keeping with us, derifylline and aminophylline, which we are used to actually using. So, and consider that this patient may require an ICU setup. And if you really want to step up the management till the patient gets better, and then you could step down the management when she actually the condition improves. So that is how an exacerbation is managed. So to summarize, you need a bronchodilator, you need a steroid. Yes.
Please add, because magnesium sulfate, I'm not sure how many obstetricians know that in life-threatening asthma, where aminophylline tachyphylaxis is also there, magnesium sulfate is a very important medication which relieves the asthma in arresting. Yeah.
So it's interesting that magnesium sulfate is coming to the rescue of obstetrician in so many conditions. If she's having a convulsions, you can give magnesium sulfate. If she is a preterm baby and you want to rescue the preterm baby, again magnesium sulfate. And here again, asthma, we are wanting to give magnesium sulfate. So
I will just like to
learning points.
Yes. Dr. Sureka, I just wanted to share with you and with the audience that I myself didn't know many years ago that magnesium sulfate can be used. But there was a very, very severely asthmatic child. And my brother, being a pediatrician, he had tried everything and she was on very high steroids and still she was not responding. So magnesium sulfate he had given. So when I was reviewing again for us, I said, okay, so this is, as you rightly said, that we have to remember another
but
thing
we need to be very careful when we are using this drug, because it has other adverse effect also. There could be a respiratory depression. So definitely we need to have a supervision and interaction with a multidisciplinary approach. If you are having an exacerbation, you cannot manage this patient alone. However, we do need to remember that oxygen, the bronchodilator, and the corticosteroid, these are the three things which can immediately start, and then later on we can hand over, or maybe the physician comes in and we can step up, and later on step down the approach of the patient. That is what a message I would like to give. Thank you. Next slide, please. Yes, and of course, if this patient is coming in labor or she is near term, and how do you optimize the peripartum care of this patient? Dr. Sharda, please. I could see her in the
I'm really sorry. Actually, I
got
logged in from the viewers,
no problem. Please go ahead with the peripartum care.
I was just hearing the whole of the talk.
Ma'am, can I interpret on the basis of the previous slide? You have mentioned terbutaline subcutaneous. So what my knowledge is concerned, I mean, terbutaline is not available nowadays.
Yeah.
So
Terbutaline is, but it is very useful.
It is. We used to even use it for preterm labor also.
Yeah, definitely.
Or in cases
but in the guidelines, very nicely.
Hypertonic contractions.
Yeah. Dr. Sharda?
Sharda, this is for you about the peripartum care of this patient now.
Now after, stabilizing the woman, suppose she goes into labor. Now we have two things to, take care of. One is the labor part and the fetus, and of course the stabilization of the mother. because during labor as such, all the physiological vitals, they increase. So it is very important that we take a good care of her. If she is in spontaneous labor, of course, the woman, if she has come with exacerbation and she is in ICU or in that setup, of course, that's a no problem. And she goes in a spontaneous labor, then there is no role of like cutting short the second stage of labor. But yes, if she requires the normal monitoring of labor, like augmentation and all, that should be done. And in this case, only thing that is contraindicated is the use of our prostaglandin, post delivery, because that should not be given. And she should be laid down. The anxiety and the apprehension should be taken care. And one can use morphine and meperidine, as I can see in the slides. So the labor part of this woman should go as of a normal thing. But the additional point that to be noted is the woman should be taken, there should be a senior obstetrician first of all. It should be taken care
Yes.
by a good team, and of course, if you require a physician, that person also should be there, because the escalation of doses and all of her, the agonist, that should be also that should be taken count of. And that is like the stress dose of steroid, as I said, lower, who goes in labor. That's very important for us, that the doses should not be decreased, but it should be kept in an optimum level. And of course, after delivery and the postpartum care should also be in the hospital, like at least 48 to 5 days she should be in the hospital till the time she is stabilized.
Yeah.
And one more thing is, because all this thing leads to hypoxia. So the we have to take care of the babies also, because sometimes they will be associated with fetal distress also. So they might need cesarean section, though it is not absolute indication, but in case if required, then the baby should be out as early as possible.
Very right. Dr. Surekha?
Yeah, definitely. We are talking of
here. Sometimes with asthmatic patient, there are chances of polycythemia is there because of hypoxia. Then this patient may be a risk. There is a risk factor for DVT or deep venous thrombosis. So we can take care for this, or at least we can take preventable action.
Yeah, definitely we would like to know that we should not do something which will harm the patient, like prostaglandins rightly said that we are not supposed to give F2 alpha to this patient. However, we could, if required, we could go and give the PGE1 or the E2 analog if required, but oxytocin is considered more safe if you want to augment the labor of these patients. We could also use a mechanical Foley's catheter to, if you want to really start induction for these patients. But however, as rightly said, oxygenation, you should remember, and if the stress dose of steroid is required, hydrocortisone, which we initially also mentioned, that can be given. In case of cesarean section, epidural anesthesia is considered to be important for pain control, and it can be continued if a cesarean section is required. Avoiding general anesthesia, as it increases the risk. And of course, we need to have a good team of physician, an anesthetist, and a multidisciplinary approach for this patient.
Okay, thank you so much, Dr. Surekha. So, Dr. Sanchita, after delivery, what are the important things that we all as obstetricians must remember in patients of asthma? The postnatal management and contraception. Oh, we didn't mention. Okay, I think we will restrict to postnatal management. Yeah, Dr.
Okay,
Sanchita.
so post delivery, there are a lot of cardiovascular changes, respiratory changes in the mother. So we have to be very careful about, cutting short whatever the medicines have been started initially. We need to manage it, and we need to reschedule our treatment accordingly. So, I mean, it's basically the monitoring which we do post delivery. Again, I would say that oxygenation, Then sudden, whenever if the patient has undergone a normal delivery, then there is a lot of respiratory distress also. So it is not that once the patient is delivered, we just leave her alone like that. We need to immediately manage that. Then it comes to a little later management also, like we need to train her that she, for few weeks, it's not that once she is delivered, she is going to be absolutely okay. There are few changes which keep on happening to her in her body over next 4 to 6 weeks. So she needs to be warned about certain risk factors, I mean the risk symptoms where she needs to be little alert on. And I mean, this regarding this cough,
so very rightly
excessive
said,
breathing, and all.
actually, Dr. Sanchita, that an asthmatic, after she delivers also, although the major, the hemodynamic changes and all those changes because of labor and all are there, but again, we have to reevaluate her status as with respect to asthma and her symptoms and her education. And we expect that at least now she would be more intelligent and monitor herself. So that is why this peak expiratory flow rate I have mentioned, we've mentioned so many times, so that all of us should educate and make sure that while the patient is in the hospital, this has to be taught and she has to do it so that when she goes home, she can monitor. Because as we said, it's a very simple test and a patient will be able to know if she is going in for a attack. So that is why as an obstetrician, we must include this in our counseling. And of course, chest physiotherapy is very important in patients of cesarean section and exclusive breastfeeding. So I think we'll be winding up with this last part, Dr. Ekta. What are the preventive strategies for bronchial asthma?
Here, preventive strategies are for two things, basically. One is the general condition of the patient, general persistent thing of that asthmatic thing, and one is for acute exacerbation. So for routine improvement of health, she can use some breathing techniques and physiotherapy on daily basis. And for acute exacerbation, she can avoid the triggered things so that she can not indulge in this
so basically,
acute attack of this.
While we are, as you rightly said, while we are dealing with an asthmatic, we as her primary care physician must educate her about, like you said, breathing exercises. Yes, we should enforce that on every asthmatic patient. They should be really good in doing pranayams and anulom vilom, because that is very helpful in increasing the vital capacity and avoiding the triggers. And this is one very new thing that I learned. So I thought of sharing this. I was not aware, frankly, friends, that if in asthmatics, the mother is supplemented with very high dose of vitamin D, which is more than the recommended dietary allowance, to the level of 2,000 to 4,000 international units. And this helps in, suppressing asthma in the baby. So if the baby is exclusively breastfed, so the baby will be protected from allergies and atopy. Also, if the mother is given high dose of vitamin D, that helps in decreasing asthma in the baby in the future. So this is an important slide that we have to move up to improve the control, move down if it is improving. And these are the steps and these are the add-ons. I thought this is a very interesting slide. So if anybody would like to take a shot, can take that. And thank you, friends. The asthma is well maintained if the obstetrician adds to the knowledge of the patient. And we thought that we will add to our knowledge and also knowledge of all our colleagues. So over to you, Dr. Surekha.
Yeah, so that was really thrilling, and we both of us, and with Noida Society, they are giving us too many thrilling cases. So we have dealt with one, and now we have landed with another patient who has come
just
to us
one
with
thing,
liver
Surekha,
disorders.
I want to just say one thing, that friends, Dr. Sharda Patra, who's a panelist over here, she is an authority, and we have taken a lot of help from her presentation. Over to you, Dr. Surekha.
Yes, definitely. And such challenging situations are coming to you as a liver disorder, which is really one case which we fear actually. If a patient is having liver disorder and coming to us. So here is a case for Dr. Taruna, who is a 30-year-old second gravida with one vaginal delivery. She's at 32 weeks of pregnancy and complaining of loss of appetite and weakness. An examination, you find that jaundice is present. Now, what could be the common differential diagnosis which come to your mind when a patient of jaundice is coming to you?
So whenever we have a patient of jaundice, we have to think in terms of, is this jaundice related to the pregnancy? Is it because of some pregnancy induced disease, or is it due to some liver disease which is like coincidentally present with pregnancy? So as mentioned, there can be the diseases which happen in pregnancy are acute fatty liver of pregnancy, intrahepatic cholestasis, preeclampsia, eclampsia, HELLP syndrome, and hyperemesis, which usually happens in the first, second trimester. And then the other coincidental diseases can be acute viral hepatitis, hemolytic jaundice, or polylithiasis, drug-induced or obstructive. Or there can be other jaundice which is developed in a patient who already has a chronic liver disease, like if she's a cirrhotic or having chronic hepatitis. So we'll have to do some investigations to,
Yeah, and of course, these are again other unusual varieties which we could have. And so we need to keep into mind that this patient could be having something related to obstetric maternal condition or something which is not maternal, it's an additional, and we need to investigate and find out that. So, and in Vidarbha region, where you might come here from, yes, ma'am, I would just like to share that when we from Vidarbha, we are having a patient with jaundice, we think of hemolytic disease first, because sickle cell is so common here that patient having jaundice, we think of sickle cell. But as this patient is coming with loss of appetite and weakness and all, we could focus on viral hepatitis also. Dr. Sharda, if you want to add in, please.
Yeah.
But we would like to be brief.
Yeah, basically, actually, the studies that we have, in our Lady Harding that I have done for the last 20 years, what we have observed is any woman, who clinically comes with jaundice, you just have to think about one in your mind, that is acute viral hepatitis. Because in this part of your India, in Delhi, Delhi is endemic for viral hepatitis. So the first thing that should be suspected of is acute viral hepatitis. And of course, other, clinical features should also be taken into account, like any history of fever or any history of loose motion or diarrhea. So the first
we
thing
will
that
come
should
to that. We will come to that, Dr. Sharda.
Okay.
Of course, the amount of jaundice will also tell you what kind of case this is. Is it a mild variety? So the differential diagnosis will differ, and if the jaundice is very deep, then the differential diagnosis will differ. And yes, viral hepatitis, it's quite common and it's life-threatening also. So we need to really look into. But in my area, if we have jaundice, and we also look into hemolytic variety. If it's a milder variety, it could be HELLP also. So we need to keep into in our mind that there is a spectrum which we really would like to, but we as a clinicians have been trained. Yes, fever is there, diarrhea is there, weakness is there, then pinpoint to a viral hepatitis. And if a history of blood transfusion is there, then it should be a sickle cell disease. So that is how we have been trained to actually focus on a disease when we face the patient. So this is a very interesting case. I would just like to read it out for you. A 27-year-old primiparous lady presents at 29 weeks of gestation with generalized pruritus for a week, and the pruritus is more common on the palms and the sole. Otherwise, the pregnancy is not very much complicated. She doesn't have any allergic conditions. Everything else is normal. So what is the diagnosis which come to you in mind in such a case related to the liver disorder, and how do you confirm and manage this? I think this is for Dr. Taruna.
This pruritus, which is very typical on the palms and sole and is worsening at night, it points towards intrahepatic
Next slide. Yeah.
of pregnancy. And for this, we'd like to do some investigations, the liver function test along with bile acids. And if the bile acids are more than 10 micromole, then it points towards intrahepatic cholestasis of pregnancy.
Yeah, definitely. Yeah, very rightly said that when patient is coming with this intractable sort of pruritus, which is troubling her even in the night, and she's not able to sleep, and the bile salts, the serum bile acid levels are high, which definitely goes towards an obstetric cholestasis, and we can manage her account. So could you mention something about how do you manage this case and the key points, because there is a risk of maternal morbidity and fetal also in these patients, and because of the decreased reabsorption of vitamin K, there is a risk of PPH also. So how do you actually go about managing this case?
So in this, we'll first have to provide symptomatic relief to her. We could be prescribing her some emollients, some soothing agents, along with ursodeoxycholic acid, which is quite a helpful drug to mention the to control. This is usually given in the dose of 10 to 15 milligram per kg body. And then if it is not controlled, then we can add other drugs also, like rifampicin and cholestyramine have also been tried in this, but usually it is managed with ursodeoxycholic acid. And then we have to do a serial monitoring of the bile acid levels, because if they go beyond 40, then the mortality for the fetus and even maternal morbidity, mortality all increase. So we have to keep a check on this.
Previous one, Dr. Mitra. Yeah.
Yeah. And if the bile acids are controlled with the medicine, then we can continue the pregnancy even up to 37, 38 weeks, or even up to term if the levels are controlled. But if they are like approaching 40, then we have to think of terminating it around 37 or 38 weeks of pregnancy. But if they increase really high, like reaching up to 100, then we can even think of terminating her before 37 weeks under steroid cover. So
yeah, thank you so much. I think she has very well summarized the whole thing. We need to remember that we need to do a serial, at least a weekly LFT and bile acids for this patient to find out if she is deteriorating. And if there is deterioration, then the fetal problems are quite high in these patients. The distress and sudden deaths may be there. So stillbirths are reported if the patient, the levels go beyond 40. So that's why, you know, the role of induction of these patients at 37, 38 weeks of gestation. And we need to remember that because of the vitamin K levels are less. So if there is a chance of PPH in this patient, so we need to remember, and we need to keep alert for PPH in this patient also. So thank you very much for summarizing very well this patient. We move on to our next case, Dr. Mitra.
Okay, I'm unable to see who's going to answer, but I think anybody can take it. A 31-year-old
Dr. Dimye is there after Dr. Taruna.
Okay. So a 31-year-old primary gravida, 24 weeks gestation, admitted with over a week's history of passing dark urine and yellowish discoloration of the eyes. She had developed fever, chills, headache, and weakness by the time of her admission, and was thought to have intravascular hemolysis of unknown etiology. So how do we, so now I think, okay, yeah, I changed it because I wanted Dr. Sharda to take this. After all, Dr. Sharda, you are the key person. So how do we arrive at a diagnosis of a patient?
Now, because she is 24 weeks, she is less than 28 weeks. And as I said, a woman who comes with, say, clinical jaundice, and there is a history of fever. So the first thing that comes to my mind at this gestation would be acute viral hepatitis. And of course, looking into her, of course, we have to do initial workup like a proper history. As I said, the history of fever, pain, and any bowel symptoms like loose motions, vomiting, these are to be taken into account. So based on the predominant symptoms, number one. And the second is, of course, I have to assess her general condition. whether it's associated, it's only icterus which is present and the degree of icterus, and what is her conscious level, whether she is say conscious, or if she's conscious, what is the level of consciousness, that is very important. The vitals should be noted, her pulse, BP and temperature. And as I said, for we have to look for some rashes, spots and scratch marks. And if she is unconscious, if she is disoriented, and the grading of hepatic encaph should also be noted. So this is to be done initially when such a woman presents to us. And the various investigation that should be done, of course this should go simultaneously. But yes, of course, viral serology report comes very late. I mean, you don't get the report very easily in 24 hours. So she is 20. So first thing I would like to do all the viral serology A, B, C, D, E. In our part of country, we have E and B very common. And then apart from that, her CBC smear, that should be done, because I saw that intravascular hemolysis point was mentioned about that. So I'll keep HELP syndrome into account. So that's why BP is important for me. And apart from that, liver function test should do all the four bilirubin, AST, ALT, and alkaline phosphatase. Albumin is also important because that will also tell me about the condition of the liver, whether is she suffering from some chronic liver disorder. And then coagulation profile, of course, and kidney function test. Urinary protein, LDH, these are important for your preeclampsia, severe preeclampsia or HELP. And serum bile acids, of course, I would do, even if she doesn't have pruritus, I would like to rule out cholestasis, because usually in viral hepatitis, 30% of the women can have cholestasis of pregnancy also. So they could be two things together. So after getting all the investigation, if suppose she comes out to be positive, if she comes out to be negative, then my hepatitis part has been ruled out. So I will go ahead to look for severe preeclampsia, HELP, AFLP to be kept in mind, because the incidence prevalence of acute fatty liver pregnancy is in third trimester. Usually it is after 28 weeks, but atypical presentation can also happen. So that is why the 2DD I would keep after a negative viral markers. That would be preeclampsia, HELP, and the second would be AFLP. And if the bile acids are negative, there is no pruritus, then cholestasis also I would exclude. Suppose she comes out to be acute viral hepatitis. So at this point, if she has, now this is an algorithm.
This is very nice algorithm, Dr. Sarada, which you have
ma'am,
this
is based on our own experience over the years. What we found that based on the lab investigation, if you have a serum bill less than 10 and SGPT, the liver function tests are not very elevated, then we should look for the platelet, LDH, and a coagulation profile. With this low bilirubin, all are normal. We should, and her BP is high, then it comes under severe preeclampsia. And if she has high LDH and low platelet but a normal coagulation, so she goes for HELP. And if the platelets and LDH are LDH is normal, but there is low platelet thrombocytopenia along with the DI, this is deranged coagulation, she goes under acute fatty liver of pregnancy. And after excluding all this, Budd-Chiari syndrome is not very common in pregnancy. Usually it presents in the postpartum period once a woman delivers. So if the platelets are normal, LDH is normal, and the LFTs are not very elevated, so we could keep it as Budd-Chiari. Now these are based on when the markers are negative. So she could be acute viral hepatitis in the early phase of AVH, when she has these low bilirubin and low SGOT. So next slide, can we have the next one? Yeah. So now there is a second scenario. The second scenario is a woman who comes with very high bilirubin and high SGOT, SGPT. Now this will go into acute viral hepatitis. Now in acute viral hepatitis, we have two categories. One is a woman who has acute viral hepatitis who has recovered, One is the woman who progresses to fulminant hepatic failure. Now, how do we, differentiate between these two? A woman who has got a normal TLC and normal coagulation, but she has very high bilirubin and high SGOT, she is acute viral hepatitis in the early phase. And if there is derangement of the coagulation and if there is leukocytosis, then the likelihood of this woman going into fulminant hepatic failure is very high. And we have to be like very cautious about it. This, the antenna should raise up that this particular woman, instead of getting recovered, she is progressing. But if the bilirubin is high and the SGOT, SGPT are coming down, and the TLC and coagulation profile are markedly deranged, then these are the women, they are in the fulminant and they can be acute fatty liver of pregnancy. But if it is normal, then that means she is in the recovery phase. So this is very important that we have to see for the lab investigation, and accordingly, the management, the diagnosis should be made. Next slide, ma'am.
Dr. Sharda, this is so important to actually stress that we have to do the serial testing and the serial.
This is overtime. This is overtime because
actually will tell us what the patient is going towards.
Yes, because the woman would be with us, for 2, 3, 5 days, 7 days also. Any woman who comes with jaundice, we keep her admitted. We admit the patient and we have to serially monitor her, liver function test, her level of consciousness, and based on that, the diagnosis. And this is when the viral markers are coming negative. If the viral markers are coming negative, and this is the scenario, we should think that it is fulminant failure because of acute fatty liver of pregnancy. And if it is positive, then it is because of acute viral hepatitis.
Yeah, so two things are very important to note. If the bilirubin is very high, it could be viral hepatitis, it could be acute fatty liver of pregnancy. So how do you determine, so if there is a negative viral marker, then our all thought process goes towards acute fatty liver of pregnancy, and fulminant hepatic failure may be attributed to that. If the viral markers are positive, then definitely we go, our whole management goes the other way. And three things are important again: the bilirubin and the enzymes, and of course the coagulation. So these three things we need to definitely as an obstetrician remember to keep on sending these. And of course the leukocytosis, if it is very high or very low, and if it's recovering, that is how we should monitor this patient. So Dr. Dimmi, we are coming to this patient now who is having acute liver failure, and you want to optimize and manage this patient. So how would you go about? Salient features we would like to note, because see, we want to take home some messages. We can't actually, because this is a multidisciplinary approach after all, but we get a lot of patients. When I was a resident, we used to have 5, 6 patients of viral hepatitis, and so many patients were there. So at that time, I used to not understand, but now with this understanding, we really need to stress upon optimization, and then how to deal with the delivery and part of the patient. So how do you optimize your patient of acute liver failure?
In the case of hepatic failure, we
just go ahead, slide, move ahead. Yeah.
It has to be a multidisciplinary approach. And here, both physician, hepatologist, neonatologist are to be consulted for the thing. And the first priority is to stabilize the patient. I mean, certain corrective measures have to be done, like coagulation, that has to be corrected. The glucose levels have to be corrected. Electrolyte imbalance, that has to be corrected. And if hemoglobin is falling down, she may need blood transfusion. And once she's stabilized, in case she's more than 24 weeks, then she may, in case she's more than 27 weeks, we may give her steroid so that to enhance maturity of the baby. And then we can, once she's stabilized, we can cause delivery of the patient. But if it is less than 24 weeks, then it is immaterial. I mean,
I want to comment here. That a woman who has acute viral hepatitis, and we see that she is recovering. And if we see the particular case, 24 weeks wala patient, And as
No,
I said,
not in viral hepatitis. In viral hepatitis,
Yeah.
we have to stabilize the patient. There's no role of termination of the
termination of
Yeah,
pregnancy.
definitely.
Right.
Yes, if the
Dr.
cause
Demi,
is something else. Viral
Yes.
hepatitis is not the cause, but it's
Let
fulminant
us keep
hepatitis
into
because
our
of
mind
something
two
else.
types of scenarios. One
Yes.
scenario where there is a hypertensive disorder and preeclampsia, we are talking of help. And
That
if
we
this patient
terminate,
is severe,
yeah.
then we terminate.
Terminate.
But if we have these cases who are viral hepatitis, then whether they are in labor, whether they are not in labor, and what kind of
No role.
gestational age.
No
Okay,
role.
if there is the gestational age is like 24, 28 weeks, there is no role of any termination.
They
of these
recover
patients.
and they continue the pregnancy.
Definitely. And
Yes.
if they are in
Yes,
labor and they are going towards labor, then we have to deal with the condition of
That's
correcting
right.
the
I was confused. I know. I had not heard it earlier. I was not aware that she was a viral hepatitis patient. In viral hepatitis, yes, we have to manage conservatively.
Next slide,
And it
Dr.
is
Mitra.
okay. And then
Yeah, definitely we need to fix upon the supportive management, correcting the coagulation, and if there is progression towards hepatic encephalopathy and metabolic disturbances, we need to deal with that. And of course, we need to prevent certain complications like PPH. If this patient is going towards labor, then that is what we really need to optimize. So next for Dr. Mitra for you.
So having actually, what the aim of this panel is just to remember all the possible things with the liver disorders. And Dr. Sanchita, I invite you to just comment, what do we mean by fulminant hepatic failure? Is there any role of prevention and what are the principles of management? I know this is a little bit more in depth, but together we'll be able to take some important learning points. Dr. Sanchita.
We can go ahead with these slides quickly because there are a lot of things. Yeah.
एक महीने के बाद repeat कर
Dr.
देना.
Demi, please mute yourself. Dr. Demi, please mute yourself.
Yeah. See, when you
Yes,
talk
ma'am.
about
Dr. Sanchita is there. Dr. Sanchita?
Yes.
Would you please?
So when you talk about acute fulminant liver failure, as we were discussing about the viral hepatitis, so these things we need to keep in mind, and the most important thing for us is the coagulation profile of the patient. So whenever there is a fulminant liver failure, we need to be ready with the blood and the blood products. We should be working on the coagulation profile because that's the biggest nightmare for us as obstetricians, that if the patient goes into labor and she is delivering, so we need to be very, very, we should be prepared with the blood products, and we should be knowing that she may not get into DIC. So that is one very important thing. And of course, we will be dealing this in coordination with the...
Basically, this fulminant hepatic failure is going to be very detrimental to the mother and the baby. And our aim is just that we all should be on a high alert.
Ma'am, shall I add?
Liver disorders. Yes, Dr. Sharda, please.
Ma'am, I think many of you must be having this query in their mind. How do we know that the woman has gone in fulminant hepatic failure?
Yeah.
So there is no definition of it as per, if you go to as per the hepatologist, it is whenever there is an hepatic encaph sets in. So how will you know hepatic encaph sets in? Okay, so the first thing that the woman could go in is, number one, when the serum bill is more than 18 and it is increasing. Second is the INR goes beyond 6. Number one is, if the INR is 6, serum bill is more than 18. And SGOT, SGPT are coming down. Okay, and the third point is the level of consciousness. She is from 1 to 2, she will go to 3 and 4. So this is 1 and 2 is she's just drowsy. She will be conscious. She will be orientation would be there. Irritability would be there. So how will you know that the woman has gone in fulminancy? One has to remember, one is the serum bill is increasing exponentially. Second is the SGOT, SGPT after an elevated level are coming down. I mean, they are less than 500 and the INR is going up. So this will clinch that she is in fulminant hepatic failure.
So, Dr. Mitra, we just go ahead with these slides, which are of the yeah. We just go ahead.
This was just a study that we did. Whites decreasing, ma'am.
I'll answer to that question. The decrease, because the viral hepatitis, it causes the hepatocytes necrosis. It kills the cytolysis. So you don't have any synthetic function. That is why the SGOT, SGPT levels comes down. And
so that is why that is the most ominous sign.
Yes.
I mean, a rising bilirubin with increasing SGOT-PT is more reassuring than a rising bilirubin and falling SGOT.
Yes. Yeah. That means
So
the
that
liver
implies
has
that the liver
failed.
is
The
failing.
liver no more can synthesize the enzymes.
So in fact, the most important
message
thing
for the
from
audience
us is that we have to look at the enzymes. If they are falling, then you should be on very high alert that this patient is going into fulminant hepatic failure.
And the
we
second
just go ahead with this case. We just give the message from this the study which is being shown is about the role of fresh frozen plasma here. So
Dr. Surekha, let's just recount these things because we have to finish. I'm getting called from
Yes.
Dr. Sujata.
The only point I want to make here is the delivery, the peripartum management. Now, 80% of the cases who are in fulminant hepatic failure, they will come in labor. In 24 hours, they'll go in labor. Only 10 to 20% are the women who will be they will be not in labor. So the question comes to us whether to terminate. I mean, in order to, prevent the progression of the disease. I would say in our experience that we have seen that in such scenario, there is no role of termination even if the woman is in fulminancy. But yes, two questions. One, there will be associated IUDs. They will be, sometimes they come with post-term pregnancies. There'll be premature rupture of membranes. So in that scenario, if you want to terminate, make it a point that the INR should be at least 2 to 3 by giving fresh frozen plasma, a peripartum. Like what we do, we give 15 ml per kg, initially 4 fresh frozen plasma, and then we repeat this 2 hourly. Ekta must be knowing because she was in Lady Harding and we've been managing this now. So two FFPs 4 hourly to be covered during the labor part. And even if the INR would not come and she is in labor and she is delivered, so one should be very careful, one should be very cautious, and full team should be there. A senior obstetrician should be there to manage such deliveries because these are associated with laceration. There will be vaginal laceration, there would be cervical laceration, that will cause a traumatic PPH. And atonic PPH, what we saw in our study was very less. It was only 15%. 80% of the time we saw that the delivery was conducted by a postgraduate or an inexperienced person. So, by and by, we also got to know so many things and we became clever and we learned from the, lessons learned from the mistakes, they say. So that is why we made a point that this is the obstetric management that should be done during delivery. We should be cautious to prevent traumatic PPH, number one. Like sweeping, stretching of perineum, second stage, fundal pressure should not be given. This is very important. Timely epi should be given rather than having perineal tears, because any tear, any trauma, because she is in DIC, she has a coagulation defect, they bleed like hell. So we have managed keeping packs inside, and then instrumental delivery should be avoided because again that will lead to lacerations. And after each delivery, the genital tract should be examined for any tear or any laceration. And as I said, these are the things that should be kept. And suppose there is atonic PPH and INR is very raised, you can't take up the patient to the OT. OT is busy. Balloon tamponade should be ready with you. That thing should be done. And of course, we should be using uterotonic tonics to prevent atonic. And
now we have carbetocin also, Dr. Sharda.
Yes, ma'am. That also you can use. So for the obstetrician, for us, it is very important that if she is in labor, these are the points should be noted, and this should be the woman should be taken care, not leaving her and then
depending on the, but leaving the patient with the with the postgraduates or
So the
some
bottom
junior
line
people.
is that this is a very, very high risk patient.
Yes.
Better to be cautious, better to prevent the tears and be on the lookout for hemorrhage. Thank you.
Yeah, and definitely we need to keep a watch on the INR. What the INR is.
Coagulation
That's
profile.
very important.
That's
So
very
you
important.
have to have the measurement of the INR, and you should your
SSP.
goal should be to keep it below 2. So fresh frozen plasma is more important than the whole blood. That is what is the key message we should give, and avoid any sort of trauma.
Yeah, Dr. Surekha, there is one more thing. If suppose the woman is not in labor and there is IUD and all those things, and if you have a facility of hepatic transplant in the institute, then in those cases you can terminate immediately and the patient should be sent to the hepatologist for a transplant. Because once FHF occurs, it is not reversible. The liver is gone means the only treatment of it is only liver transplant. So these are the cases where termination has a role.
Fulminant hepatic failure is stabilizing and considering the liver transplant, which is, we all have to also know that when we won't be able to do and we have to hand over. I'm so sorry.
Here I want to add 2 very simple things, but want to convey to the audience. One is we are dealing with very severe patient, whether it's asthma, severe asthma, or it's a liver condition. Here, at every step, we have to counsel our patients and relative at every stage. This is a but obvious thing, but we have to be make our patients and relative to be in confidence. One thing, and second thing, ma'am, vitamin K use we can do for such patients.
I will request before Dr. Surekha ends it up, I will ask all the panelists to give 1 point each. Their one personal learning after this panel.
It's wonderful, ma'am. It's untouched part. Actually, the untapped, the tapping of the untapped.
Yeah, but what I would say is that I would ask our panelists, Dr. Sanchita and Dr. Dimmi, all please, if you can just say 1 or 2 sentences each so that we close the panel. Dr. Dimmi, are you there? Dr. Sanchita?
Yeah.
Have they logged out?
Ma'am, you have summarized it.
Yeah, definitely. What we have learned that obstetrics is quite thrilling, and we as an obstetrician in the institute actually cannot avoid also these patients. They keep on coming to us, and that's why it is better that we learn how to optimize them, how to really manage challenging situations with a multidisciplinary approach. So keeping ourselves updated and learning together actually is very important. And of course, planning a patient, what investigation to do, how often to repeat, and what are the optimizing thing, that is very important for an and once you plan a proper execution of the whole plan with the help of your team. This cannot be done alone, and definitely this part is for Dr. Mitra on my behalf. We are going for
Okay, so I have to thank Dr. Sujata, but I have to thank Noida Society because I don't know औरों का फायदा हुआ कि नहीं. मैंने तो बहुत सारा पढ़ लिया है, asthma and liver disorders. Thank you to Dr. Sharda Patra. I've used your full presentation. I'm so glad that you could overcome.
1 point, ma'am.
Yeah, Doctor. Lastly, I just want to say one thing, that friends, I do think that you will support Dr. Surekha Taide, my partner, for her pursuit in Foxy as our clinical research committee chairperson. She's been a wonderful teacher, trainer, and a guide. And in addition to good academics, she's a wonderful person. And I must thank all of you, and Sharda especially, because you have actually, taught us so much about liver disorder.
Thank you so much. I would say one thing, asthma, I've never touched, Today I just took out and was reading it.
Yeah, I will.
Yeah.
So after this panel discussion, ma'am, definitely, you have put in a lot of confidence in us to manage the medical conditions. At least now we, even if we call a physician, it will be like for a dummy only, and we'll be managing our cases ourselves.
Actually, exactly. I thought that इसमें मैं obstetricians as a management क्या करेंगे? We are all so fantastic obstetricians, but I thought if we upgrade our knowledge about asthma and liver disorders, I think that will be a job well done. Dr. Uma, namaste. Thank you for being there with us.
I'd like to end this session.
Yeah.
A special thank to Dr. Mitra and Dr. Sureka and all our panelists for making us wiser. So now I hand over the session to Dr. Anshu for the vote of thanks.
Thank you, Dr. Jigyasa. So, and after this mind-blowing session panel of Mitra ma'am, it was really amazing, ma'am. And it was mind-blowing session, I have to say, with all the panelists. Thank you so much, ma'am. So on behalf of Noida Obstetrics and Gynaecological Society, I would like to take this opportunity. Thank you, our all eminent persons, speakers, wonderful moderator, and eminent panelists for their wonderful presentation and the gracious presence to make this CME successful. Looking forward to welcome you all again tomorrow morning for our tomorrow's session. Thank you, everyone. Good night.
Thank you. Thank you, Dr. Sureka.
Thank you, everybody.
Thank you, Sureka ma'am.
Thank you.
Ma'am, for a wonderful panel. It was wonderful. People can't just stop the things. It was even the one line I can't just. Thank you. It was a wonderful panel.
Thank you. Though it was quite complicated, I hope we could make it a little simpler.
But you tried your best and it was simpler. It was easy to understand. That is the best thing of this panel. Thank you, ma'am.
Thank you. Thank you very much and have a pleasant evening. Thank you.
I close the session.
Thanks, everyone.
Looking forward to welcome you all.